No, no. First, first one you just show open. That's not the one, I think. Where is mine? No, this is not the one. No, ये नहीं है. नहीं. मैंने पूछा था ना.
Extremely sorry for the technical glitches that happened. So just keep patience for a few minutes. We will be ready within a few minutes. Request to the speakers that it will be 1 hour talk. So there will be 50 minutes for the speech and 10 minutes for discussion, question and answer session.
No problem, sir. It's done. Absolutely no problem, sir. Sir, you just don't need to worry, sir. I'll read.
Don't worry.
I am there. I can solve this technical glitch. So I am ready. Projection. Projection.
Oh, it has changed.
Sir, any problem, sir? Sir, should I check the font? Should I change the font or something?
No issues at all.
No, sir, you can tell me. I can wait in my minutes. I am very fast with these technical things.
No issues. Can we start?
Projection.
Am I this the one? Yeah. Back is this. Okay. Okay.
This is light changer.
Yeah.
This is the
Pointer.
This is the pointer. Sir.
Which is the
This is back slide. This is front slide.
yeah.
This
Point
is-
pointer.
Pointer is I think this. Point.
Okay.
এই pointer কাজ করছে না কেন?
Okay. Leave it. I'll manage.
Pointer কাজ করছে না? This pointer
Yeah. Good morning. At the outset, I thank the organizing committee, particularly Dr. Chakravarti, for for giving me this opportunity to present before you the imaging of the pituitary gland. As you all know, pituitary is one of the master gland we all consider because it produces so many hormones which not only controls the hemostasis but also stimulate the other endocrine glands in the body. You know it has got a adenohypophysis and neurohypophysis, and usually the patient presents either with the symptoms of the hormone hypersecretion or hyposecretion, which can be acromegaly or hypopituitarism or due to the mass effects, mainly the visual symptoms and other endocrinal symptoms. Before going into the imaging, one should have a thorough understanding of the anatomy as well as the embryology of the pituitary. And we need to know the associated clinical features, and by that we can actually interpret the imaging findings. So a systematic approach should be there based on the location which I will be telling, and also on the embryological origin. Pathologies include, which I will be telling, it can be anatomic, that is the embryological associations, the neoplastic, which can be either or the non-neoplastic, the infectious or the inflammatory lesions. Coming to the imaging, in the yesteryears it was the X-ray, the CT scan, but MRI is the modality for imaging of the pituitary. The X-ray we used to know that is the enlargement of the sella, and presently we use the CT scan one to look at the location of any lesion in the cellular or the suprasellar region, and to look for the calcifications or the involvement of the adjoining structures. But MR is the modality actually to look for the pituitary gland as such. And when we do the MR imaging, I think I understand you are all the residents may be acquainted with the imaging sequences in the MR. There are T1 weighted images, T2 weighted images, flare, diffusion, spectroscopy, SWA imaging. These are all the various parameters we play around to produce a image. So using that parameters, we get the images somewhat like this. There are coronal sections, sagittal sections and the axial sections. Majority of the times it is the coronal and the sagittal sections that are looked into to evaluate the pituitary gland. Normally we do the T1 weighted imaging in the sagittal section. Since the gland is very thin, we take a 2 mm to 3 mm sections always, and they are all consecutive sections. And on the T1 weighted image, this is a T1 weighted image. How to identify a T1 weighted image is, you look at the CSF, that is in the ventricles. If it is Hypo means it is suppressed, which is appearing black, then it appears a T1 weighted image, and also the white matter which is hyper intense. So here is the white matter, you can see, which will be hyper intense on a T1 weighted image. Whereas on a T2 weighted image, which is something like this, the CSF will be hyper. Okay? CSF will be hyper, and we have to do the pituitary imaging using that. Now, and on the T2 weighted image, the white matter will be hypointense. So this is the basic fundamental which I am telling just to make you all people understand. Oh, okay, I can use this. Yeah. So this is the CSF which is hyperintense, and this is the CSF in the ventricles which is hypointense. This is on the T2 weighted, T1 weighted, and this is the T2 weighted. What we do is, we take a coronal images in 2 to 3 mm with a fat sat imaging. Fat is saturated, means fat is suppressed. So this is how the pituitary gland appears in the sella. So this is how the pituitary gland appears. So we do the T1 and the T2 weighted imaging normally. And in the T1 weighted imaging, usually the posterior pituitary, which is you having vasopressin and oxytocin, which will be hyperintense. So this is the hyperintensity, that focus. So it will be hyperintense. In pathological conditions, which I will be showing, this hyperintensity will be lost in such cases. Usually they present with diabetes insipidus. And you will have the pituitary gland like this, and this is the infundibulum. This is the mammillary body, this is the hypothalamus, and this is the infundibulum. From the infundibulum comes the pituitary gland. This is the posterior pituitary, this is the anterior pituitary. So that is how the normal anatomy will be. And in the coronal imaging, this is the pituitary gland, and this is the anterior pituitary. If when you go to the posterior sections, it appears hyperintense on a T1 weighted image. Anteriorly, they all appear hyso-intense. We always compare this intensity with the grey matter of the normal parenchyma. That is, grey matter means this is the cortex, which is the grey matter, and this is the white matter, which is the normal this is the chiasma, that is the optic chiasma that you are seeing on the coronal sections. So to understand both the pituitary as well as the surrounding structures, we do the coronal imaging as well as the sagittal imaging most of the times. And this is the pituitary gland, this is the sella, this is the sphenoid bone, which is the sphenoid sinus, which is filled with air, so it is appearing hypo. So normally the gland will be flat or it will be concave towards it. So that's how a normal pituitary appears. We do other sequences such as the diffusion weighted imaging to look for the cellularity of the lesion within it, because that is most important when the surgeons are operating. If it is showing restricted diffusion and uniform enhancement, very likely they can suck that pituitary adenoma, whatever is there, through the transnasal approach. If it is restricted and not enhancing, usually it is fibrotic, they will not be able to take it out, they will go through the cranial approach instead of that. So to give that information, we do that. We give the contrast also. The contrast enhances both the infundibular stalk as well as the pituitary. So both will be showing the enhancement, and this is one gland which doesn't have blood-brain barrier. So normal enhancement of the pituitary is a normality. Means usually when the pituitary enhances, it is a normal thing. It is not an abnormal. Whereas other areas of the brain, they don't enhance. Only the pituitary gland and few other areas like choroid plexus and all, they enhance, because there is no blood-brain barrier in that. So this is the normal pituitary infundibulum and the pituitary. You can see this is the posterior pituitary, which is more hyperintense, and this is the pituitary gland. We also do in the pituitary imaging the MR angiogram, because there may be the involvement of the surrounding vessels, encircling of them by the by the lesions. So we take that also into consideration. Coming to the embryology, as you all know, there are two things. One is from the neurohypophysis, then the other is the adenohypophysis. Why this is important is the both they are formed from the ectoderm. One is the neuroectoderm and other is the stomatodium from the oral ectoderm. From the oral ectoderm, it evaginates and goes upwards. That is what that causes the adenohypophysis. Whereas the one that invaginates, which comes from above downwards, is the neurohypophysis. That is where it comes from through the hypothalamus. So this is the neural ectoderm, this is the oral ectoderm. They both go and meet at the level of the sella. So this path all the way from the oral ectoderm, it goes through the sphenoid bone into the to form the adenohypophysis. This is the neurohypophysis. They both fuse together. This stalk from the oral ectoderm, this will disappear, whereas this will remain. This remains is a infundibular stalk, whereas this disappears. If in case if this remains and if some cyst forms, that is called as the Rathke's cleft cyst. This is the Rathke's cleft cyst. That's where it comes. Next, so this is the final pituitary that is there in this. So when you look at the images, yeah, you can see this. This is how the pituitary, this is the infundibular stalk, the anterior pituitary, the intermediate, this is the posterior pituitary. This is the sella, that's how the whole thing will be. This is the mammillary body, and this is the hypothalamus. The one that lies between the mammillary body and the infundibular stalk is the hypothalamus. So just a simple anatomy, how to identify on the imaging. Now coming to the lesions as such, they are the lesions which are involving the anterior pituitary. I think everything has gone for a toss. I had made a slide. Anyway, this is the anterior pituitary lesions, this is the posterior pituitary lesions. If you see this, is the bright spot absent or ectopia? If they are absent, then it can be due to the Langerhans cell histiocytosis, germ cell tumor, or the absent bright spot which can be congenitally be there. Or if it is present, it may be ectopic, or it can be in the septo-optic dysplasia or a stalk interruption syndrome. So this is the way to look at the posterior pituitary. If you come to the cellular lesions pars intermedia, that is in between the adenohypophysis and the neurohypophysis, there can be cysts at the pars intermedia or the Rathke's cleft cyst. This can be there. Or if the anterior pituitary lesions are there, then if there is a mass lesion, if there are no mass lesion, it can be just an hyperplasia which is normally seen during the pubertal age, or hypoplasia or hemochromatosis. If there are mass lesions, a whole lot of lesions are there, which I will be telling. Similarly, regarding the suprasellar lesions, whether involving the bones or the cisterns or the stalk. So based on that, we divide the lesions. Coming to, so this is how the lesions will be. This I have taken from the article. So this is the chiasmatic recess, infundibular recess. These are all the various lesions which can happen. This is the hypothalamus, which can cause the hypothalamic hamartoma, and posterior pituitary, anterior, and the intermediate pituitary. Now coming to the lesions per se, I will be going from the anterior pituitary to the posterior pituitary. So in the anterior pituitary, it can be pituitary hypoplasia. Hypoplasia or a aplasia which is usually congenitally associated. It can be associated with septo-optic dysplasia, and usually if it is less than 5 millimeter in height, we consider as a hypoplasia. So that can be there. These patients, they can present with the hypopituitarism in this. Not only with that, they can be associated with other congenital malformations of the brain. So not just look at the pituitary, you should look at the corpus callosum, which will be thin, or there can be associated cortical dysplasia in this. So this is what that happens in a pituitary hypoplasia or a hypoplasia. Coming to the hyperplasia. Hyperplasia or a normal finding which we usually see in a case of at the pubertal age, or when there is a hormone the end target organs are not are not functioning properly, that time the hormones get hypersecreted. Even that time also it will lead to hyperplasia. So how to differentiate the hyperplasia from an adenoma is, in a hyperplasia, though it is a convexity is there, the convexity normally I told it will be flat or the concave. Here the convexity will come in the hyperplasia. What is more important is it is uniformly hyperintense, and there is no interspersed heterogeneity which will be there in a case of hyperplasia. Added to that, you have to corroborate with the age and other factors to call it as a hyperplasia. Though it is convex, we still call it as a hyperplasia in these scenarios. Okay. Now coming to the adenomas. In pituitary, which actually involves the gland is pretty much involved, are the two adenomas, that is the micro and the macroadenomas. In the microadenomas, we call when the lesion is less than 10 millimeter. When it is more than 10 millimeter, it is called as macroadenoma. We go by microadenomas. They are most of the times incidentally detected. Sometimes they are associated, majority of the times they may be associated with the hypersecretion of the hormones. And prolactin is the one, prolactin microadenoma, followed by ACTH. These are all the hormones which are produced by the microadenoma. The thing how to identify a microadenoma on the imaging is, they usually something like this. This is the anterior pituitary. Posterior pituitary, very unlikely to get a microadenoma. Only in the anterior pituitary we do get this, and they will be very small in size. So how to identify by on the imaging? They may be iso-intense to the pituitary gland, so you may not be able to pick it up. Sometimes they will be hyperintense because of the presence of the cells within them. This hyperintensity which is seen can produce the changes in the contour at that level, or it can shift the infundibulum to the opposite side. These are the indirect signs to consider a to actually look at the microadenoma. But one of the ways, okay, it is doing a, can, the video is playing? Yeah, you can see. Okay, can you see? Please concentrate on this, whether my cursor is seen. Yeah. Please concentrate on this area. The idea of dynamic imaging is this: we acquire the images of the pituitary at an interval of 10 to 20 seconds in the sequence with 1 millimeter thickness after giving the contrast. One, it starts before the contrast injection, then continues contrast injection, then we see how the pituitary enhances. Normally, pituitary is a hyperperfused gland, means it will be there. Whenever there is a adenoma, that will be a relatively hypoperfused when compared to the normal gland. So when you give the contrast, the hyperperfused pituitary will get enhanced first. Then my adenomas will take time to get enhanced. Then after enhancement, it stays for longer time in a adenoma when compared to normal pituitary. So when you give the contrast, the pituitary enhances, followed by the enhancement of the adenoma. Then the washout happens in the normal pituitary. The washout means that persists in a case of microadenoma. So you please concentrate on this area in this video. You see, initially this is there, this is not enhancing. Then later part, this particular thing is getting enhanced and it is remaining, whereas this washes out. So that's how a microadenoma is identified. Most of the times, means nearly around 70% of the cases, this works. Not all the time this will work. We have to corroborate with the clinical features to identify a microadenoma. And this is one more image you can see. This you can see very well. It has shifted the infundibulum also to the opposite side. This is very easy to identify, in this case a microadenoma. Whereas in spite of doing all these, there are situations where you will not be able to identify. That time we go for sinus sampling. This sinus sampling is mostly done for microadenomas which are producing the ACTH hormones. So what is the how we do this sinus sampling? We do the puncturing of the femoral veins bilaterally. You can see this is the inferior petrosal sinus on both the sides. This is how the sinus is seen. I think you can see this. This is the inferior petrosal sinus. This is the IJV. This is the internal jugular vein. So through this we approach till here. We approach till here. Both the sides the catheters are kept, and we draw the blood samples. We draw the blood samples, one as a baseline, both from both the sides and also from the peripheral line. Then we give the corticotropin releasing hormone, which is 1 microgram per kg body weight. After giving that, we again draw the blood samples from the same catheters at 1 minute, 3rd minute, 5th minute, 10th minute and 15th minute. So totally 5 samples from each side, 5, 5, 5, 15 samples. Then the baseline 3 samples, totally 18 samples. These are taken, immediately they are frozen, they are centrifuged, the plasma is separated, this plasma is stored, and we look at the levels of the ACTH in that. If there is a difference, the ratio of more than 2 is there between the peripheral and the central ACTH, central samples, then very likely the microadenoma is there, and it will be from the pituitary, the ACTH. If it is more than 3.5 between the 2 sides, then we consider that is the side that is where the microadenoma is present. Either one is to localize and to identify whether it is the central or the peripheral pituitary. Then this is regarding the microadenomas. Coming to the macroadenomas, which as I told previously, lactotropes are the most prolactin secreting adenomas are more in number. Non-functioning adenomas are also there. Then normally, as I told, this is how it will be seen, both the sella as well as a suprasellar location. Because of the presence of the diaphragma sella here, there is a constriction which will appear as a figure of 8 or a snowman appearance. This is the normal appearance of a pituitary macroadenoma, and they appear hypointense or isointense or hyperintense, as I told, depending on what exactly is the content of that macroadenoma. So it will show uniform enhancement or a subtle enhancement, as you are seeing in this case. Most of the times they present with the pressure symptoms, and they not only restrict themselves to the pituitary sella or the suprasellar region, but they also can go into the invade the cavernous sinus. The invasion of the cavernous sinus, this information is very important from the surgical point of view. Then that portion of the cavernous sinus involvement has to be left over. That is the reason. Then the way how we differentiate this from the that is a meningioma, which also mimics the same, is you look at the involvement of the ICAs here. These are the ICA phloids, that is ICA means internal carotid artery phloids. They are all of equal size. There is no constriction of the lumen of the ICAs. Whereas if in a case of pituitary adenoma, there won't be any constriction. Whereas if in a case of meningioma, there will be constriction of these ICAs, and that is the differentiating feature in such cases. There is a way of grading the involvement of the cavernous sinus by the knobs grading, as you are seeing. One, look at the margins of the ICAs. This is the adenoma, if it is just touching or medial border of the ICA, then grade 1, grade 0. If it is in the middle part, grade 1. If it is on the outer part, then it is grade 2. Grade 3 is the involvement of above, 3A is above and 3B is below, and grade 4 is the involvement of the entire cavernous. Grade 3B and grade 4, there is an involvement of the cavernous sinus. All others, it is not involved. That's how we actually tell whether indirectly cavernous sinus is involved or not. There is what is called as a invasive pituitary adenoma, which not only involves the sellar and suprasellar region, but also invades into the sphenoid sinus, invades into the surrounding parenchyma. These are invasive pituitary adenomas, which may respond by giving cabergoline some of the time. This is one such case. You can see the size of the adenoma, which is seen after giving bromocriptine. This is how it is. The size of the lesion has reduced significantly. So with this itself, it can come down. There is what is called as a pituitary apoplexy, which happens because of the decreased blood supply to the adenoma, wherein there will be infarction of the pituitary, which is where usually the patient presents with headache, visual symptoms, and ocular palsy, pan-hypopituitarism. Most of the times when it is presented, that time only the adenomas are detected. So this is one case, such case. You can see there is a pituitary adenoma. This is the one where it has blood, and you can see the hypo-intensity in the periphery and hyper-intensity on the T1 weighted image. So this presence of hemorrhage, the way how it appears depends on the age of the hemorrhage, whether it is acute hemorrhage or the early subacute or the late subacute or the chronic hemorrhage. Depending on the type of hemorrhage on T1 and T2 weighted images, it varies. That's how a radiologist tells it's a early subacute hemorrhage, which is beyond 4 days, and late subacute is beyond 7 days, and more than 21 days we call it as chronic hemorrhage. So that's how you can see this. This is a adenoma. This is a hyperintensity. Wherever the hyperintensity is seen on T1 weighted images, it is either early subacute or late subacute. If it is hyperintense on T2 weighted images, it is late subacute. But if it is hypointense on T2 weighted image, it is early subacute. So that is how we actually look at the way of hemorrhage. One more thing which I want to tell regarding the hemorrhages due to the pituitary is, these hemorrhages may be happening subtly. It may not produce the apoplexy-like symptoms. It may be happening subtly. That will be seeping into the subarachnoid subarachnoid space. When it is seeping into the subarachnoid space, it will produce what is called as a superficial cirrhosis, wherein the blood which is seeping from the pituitary gland is going and settling in the dependent areas of the brain. Usually it is seen in the cerebellar region and also in the 7th, 8th nerve complex, that is the CP angle areas. The patients may present with hearing loss in such cases. So we call it as superficial cirrhosis in such scenarios. I have not put that image, but that also can happen when the hemorrhage is happening in a subtle way, but it is not happening continuously like what happened with the pituitary apoplexy. The other lesions which are involving the pituitary or the tuberculosis, this is the infectious etiology. You can see, apart from the involvement of the pituitary, here what happens is the entire pituitary gland is involved. You may not have the posterior bright spot, and there may be associated involvement of the basal cisterns in this case. That's how the indirect way of identifying the tuberculosis in that scenario. The other entity is the sarcoidosis. In the sarcoidosis, as I told, in the tuberculosis, it is mainly the sella, that entire pituitary gland that is involved. Whereas in the sarcoidosis, what is involved in the infundibulum? In the infundibulum, you can see there is a thickness of the infundibulum which is seen in this particular case, and it shows homogeneous enhancement. Like this, the infundibulum will not be seen normally. So there will be homogeneous enhancement, and since there is an involvement of the infundibulum, posterior pituitary gland may not be hyperintense in this scenario. So you should not just look at the pituitary, you should also look at the surrounding areas where you can see there is an enhancement of the 7th, 8th nerve complex. You can see at the chest imaging involvement of the hilar regions with the gland, with the enlarged hilar lymph nodes. You can see this. This is the involvement of the infundibulum. You can see this. This is the chiasma. This is the infundibulum which is thickened, and that is showing enhancement in this part. And there is enhancement at the level of the leptomeningeal enhancement you are seeing in a case of sarcoidosis. So the involvement of the pituitary isolated, it will be very, very difficult even on imaging to tell. You have to correlate with the other symptoms which other areas also to actually look at the diagnosis of the sarcoidosis as well as tuberculosis. Coming to the empty sella, this is a entity which is usually seen due to the herniation of the CSF space into the sella because of the defect in the diaphragma cella. So this is where the diaphragma cella will be there, that will be defective and it will be herniating. When it herniates, it looks hyperintense. Normally partial empty sella will be seen around in 15 to 20% of the cases. You need not associate any etiology to it. But more sometimes you have to differentiate from the idiopathic intracranial hypertension, which will be associated with partial empty sella. So in such scenarios, there will be associated dilatation of the perioptic subarachnoid space as you are seeing in this case. And also there may be association of this is the transverse sinus and the sigmoid sinus. This junction between the transverse and the sigmoid junction will be hypoplastic, or it will be stenotic in cases of idiopathic hypertension. So this is one entity which may be relevant, but 15 to 20% of the cases it may not be associated with any pathological features. As I told, there are what are called as a pars intermedia cyst. Pars intermedia is between the anterior and the posterior pituitary. In between it will come. So this is how you can see, this is the anterior pituitary, this is the posterior pituitary, there is a cyst here. This is a remnant of the Rathke's cleft, that cystic area, but only thing, this is lined by the non-functioning epithelium. So you need not have any some importance to this pars intermedia cyst. The difference between pars intermedia and Rathke's cleft cyst is, here in pars intermedia, since it is anything, am I audible? Am I audible? No, it has switched off. Okay, can I?
The connection to podium is lost.
On T2 weighted image and hypointense on T1 weighted image. It can show peripheral enhancement as you are seeing. It is a normal enhancement of the pituitary. So this will be there in a case of pars intermedia cyst, which can be incidental. Whereas in a Rathke's cleft cyst, which will be there anywhere from the oral stomatodium up to the level of the infundibulum, anywhere this cystic area can come. This cystic area can be will have a active epithelium lining it. Because of that, there will be increase in the size of the Rathke's cleft cyst with time, and it can appear hyperintense on T1. The intensity varies with the content of the cyst. It can appear hyperintense on T1 and like what you are seeing in this case, and may not show enhancement at all. And you can see the posterior infundibulum is very well seen, whereas here the anteriorly the cyst is there. So that's how we will be seeing see this. This is the Rathke's cleft cyst. This is the anterior and the posterior pituitary and the infundibulum. Now coming to the absent bright spot. As I told, on T1 weighted images, the posterior pituitary will have a bright spot, which will be absent in few of the cases. It can be absent because of the embryological reasons, or it can be absent because of Langerhans cell histiocytosis, germinomas, or hypophysitis. But most of the times they are all associated with central diabetes insipidus. So this posterior pituitary will be absent as you are seeing in this case. Now, coming to the Langerhans cell histiocytosis. This is an entity which is due to the proliferation of the dendritic cells in the monocytes or the macrophage lineage. This Langerhans cell histiocytosis will be seen involving the pituitary stalk. Most of the times it is the pituitary stalk that is involved. If there is a pituitary stalk involvement, there is an involvement of the dentate nucleus, involvement of the white matter with diabetes insipidus. Invariably consider Langerhans cell histiocytosis in such a scenario. The dentate involvement and the white matter involvement is the characteristic of the Langerhans cell histiocytosis. And when we give the contrast, usually it enhances. It not only involves the parenchyma, it also involves the meninges as well as the bone. When it is involving the bone, it will have a punched out lesion like with the beveled margins as you are seeing in this case. So, all put together, a lower variant, but there are other variants which will involve the meninges. Those are all Erdheim-Chester or the Rosai-Dorfman syndromes. They not only involve the pituitary stalk as well as the meninges. As you are seeing in this case, there is abnormal enhancement of the FRAX here posteriorly. There is involvement of the brainstem also in this case. So this is a case of Rosai-Dorfman. You can see there is an involvement of this pachymeninges all along with and the abnormal enhancement. These are all the variants of the Langerhans cell histiocytosis that are there. Coming to the germ cell tumor, which is usually seen in the younger age group with due to the, and it will usually present with the absence of the posterior pituitary. This is due to the persistence of the germ cells in the cellar and the paracellar region. What happens is, due to the hypercellularity of the lesion, usually it shows restricted diffusion and shows hypointensity. As you are seeing in this case, there is this hypointense lesion in the cellar suprasellar region. You can see this, and because of the hypercellularity, they show restricted diffusion. Restricted diffusion means, you can see this is a there are two images in that, diffusion weighted images and the ADC maps. On the diffusion weighted images, they appear hyperintense, and on the ADC map, they appear hypointense. As you see in this case, it may not be restricted only to the cellar suprasellar region. It may be the pineal gland, pineal region also may be involved. As you are seeing in this case, there is a increase in the enlargement of the pineal region. And when you are suspecting germinomas, you have to actually screen the entire craniospinal axis, because the germinomas can seed into these areas also. Coming to the ectopic pituitary, as you are seeing in this case, it can be seen ectopic posterior pituitary. You are seeing the infundibular stalk is disconnected, and you can see the hyperintensity at the level of the infundibulum. Septo-optic dysplasia, this is one of the congenital variant. You can see this. Septum is the absence of the septum pellucidum. So you are seeing one entity as a lateral ventricle as a one entity, not right and left. There is, you can see here, yeah, you can see here right side optic nerve is present, left side optic nerve is absent. So septal optic, and dysplasia is, there can be associated schizencephaly, cortical dysplasia along with it. When this is there, when this entity is there, the posterior pituitary may appear hyperintense. It may be ectopic in location. It can be seen anywhere from the infundibulum, the hypophysis, along the infundibular stalk up to the posterior pituitary. Anywhere it can be seen, that is a septo-optic dysplasia. Coming to the suprasellar mass, I think this has gone for a toss the way this one. So, is the pituitary normal? If it is no, then it is I will come to this suprasellar masses. If there is a mass lesion in the suprasellar, you consider craniopharyngioma or teratoma. If the optic chiasma is involved, it is a glioma. If the mass doesn't enhance, it is a hematoma. I will be showing each of those entities. Craniopharyngioma, they usually arise from those cells which are due to the Rathke's pouch. Those which lines the Rathke's pouch are the originator cells for the craniopharyngioma. Usually the patient presents with a younger age group with a short stature, headache, visual symptoms and precocious puberty. Most of the times usually they present with the visual symptoms. It has got a 90% rule. 90% means 90% of the time it will be seen having a cystic component. 90% there will be associated calcification. 90% it will enhance, and 90% of the times there will be suprasellar location of the craniopharyngiomas. This is the entity. This is the normal. This is the pituitary. This is the posterior pituitary. You can see this. It can involve all this sella as well as the suprasellar region. And this is how there are two variants in this. One is the adamantinous variant, one is the papillary variant. Usually the papillary variant comes in the later age group. This is the adamantinous variant, which is showing hyperintensity on T2 weighted images. You can see this. There is a peripheral hypointensity also, which is due to the presence of the calcification on CT scan. You can see that, and it shows enhancement as you are seeing this in this case. Usually the cystic margins they enhance, and also the solid areas also they enhance in a case of craniopharyngioma. How the cystic area appears on imaging, both on T1 and T2, it depends on the content, proteinaceous content within the cyst of this craniopharyngioma. So this is how the craniopharyngioma looks. Most of the times we will not be able to differentiate the involvement of this craniopharyngioma from the optic chiasma. We will not be able to differentiate that. And this is a papillary variant of the craniopharyngioma. You can see it will have more of a solid component and enhances heterogeneously, usually comes in the later age group. You can see this. There is a pituitary involvement is very less when compared to the adamantinous variant in this variant of craniopharyngioma. The other variant is the opticochiasmatic glioma. Opticochiasmatic glioma is the glioma which is arising from the hypothalamus or along the entire optic pathway from the optic chiasma, even the posterior part of the optic nerve. And it can have both variants, pilocytic variant or the pilomyxoid variant. So usually the patient presents with the endocrine dysfunction because of the involvement of the hypothalamic stalk. There will be diabetes insipidus in this particular case, and they usually extend along the optic pathway. It will be difficult on imaging for us to differentiate between the opticochiasmatic glioma when it has a cystic component from the craniopharyngiomas. During that time, we look for the calcification, which is very unusual in a case of opticochiasmatic glioma when compared to craniopharyngioma. And in those variants, the opticochiasmatic glioma, when it is a pilomyxoid variant, usually it disseminates along the meninges. So, and you have to actually look at the entire neural axis to look for the dissemination of such gliomas. So, this is an opticochiasmatic glioma which is showing a tall choline peak. Usually, we don't do this spectroscopy usually in a case of pituitary regions. Whereas here in this case, you can see there is a elevation of the spectroscopy, and usually the opticochiasmatic gliomas, they enhance brilliantly when compared to craniopharyngiomas. Hypothalamic hamartoma, as you are seeing, this is the hypothalamic area, mammillary body, pituitary stalk, in between comes the hypothalamus. So this will have two variants, sessile variant, pedunculated variant, and usually sessile variant, they come with gelastic seizures, pedunculated with the precocious puberty, and this lesion is hyso-intense to the grey matter, means the intensity, whatever is the grey matter intensity is there, same intensity will be seen in all the images, either T1 weighted, T2 weighted or the FLAIR images. And it doesn't show any enhancement. If it shows enhancement, it is not a hypothalamic hamartoma, it is something else. So see, you can see here there is no enhancement of the this hamartoma in this case, whereas the pituitary is enhancing. This is almost similar to what is seen here. So that is how hypothalamic hamartomas are diagnosed. Then the entity of pituitary hypophysitis. Hypophysitis, as you are seeing, it will involve the peduncle, the pituitary stalk predominantly, which will be hypointense on T2 weighted images. Usually the patients present with pan-hypopituitarism as well as the diabetes insipidus, and it shows brilliant enhancement. It can extend along the nerve roots also in a pituitary hypophysitis, and when we treat them, usually they respond to the treatment, but I think they will be put on lifelong hormonal therapy for the pituitary. So this is how it is seen, the pituitary hypophysitis. Suprasellar arachnoid cyst. Arachnoid cyst, as I told, it will have CSF as a content. So this CSF content is appearing hyperintense on T2 weighted images. You can see that hyperintensity, same as CSF. So this is the one entity in the suprasellar region, the suprasellar arachnoid cyst. Then the lipomas can be there. These are all the abnormal rests of the ectoderm during the development. They will be seen at the hypothalamic region. You can see that the lipoma appears hyperintense on T1 weighted images and suppresses on fat suppressed images. That's how we differentiate lipoma from a dermoid cyst. Dermoid cyst doesn't get suppressed on a fat suppressed images, but both can appear hyperintense on T1 weighted images. So this is how a lipoma looks, and in the lipoma, whenever it is there, is seen at the level of the hypothalamus posteriorly, and you can see the pituitary stalk normally anteriorly, and this is the normal pituitary that will be seen. It can be an incidental finding, and the corresponding image is the epidermoid. These epidermoids are something like these are all the abnormal rests of the tissues where it will be seen in the suprasellar system. They are heterogeneous intensity on FLAIR images as well as on T2 weighted images, and they do not show any enhancement. Usually the epidermoid mass insinuates along the tissue. Insinuates means usually it does not produce any mass effect. As you are seeing in this case, insinuates means it just goes along the free pathway that is available for it to spread. So that's how it is being seen here. There is no mass effect as such because of the epidermoid, and usually the epidermoids, they show restricted diffusion as you are seeing in this case. Then this is a dermoid cyst which is ruptured. As I told, they are isointense, means hyperintense on T1 weighted images, and invariably they ruptures and comes with the chemical meningitis. So whenever it ruptures, wherever that dermoid is there, ruptured dermoid, it shows hyperintensity along this one. This is a case of a teratoma which it is involving the pituitary area, pituitary fossa. Coming to the fibrous dysplasia, due to the abnormal osteoblastic differentiation, wherein you can see this, there is a sclerosis that is seen along the expanded sphenoid bone. Because of this sclerosis, you can see usually it will not produce, these are all the bony lesions which will affect the pituitary. They usually compress the pituitary fossa, and because of the expansion, they can show intense enhancement post this one. Then coming to the chordoma, which is centrally located when compared to the chondrosarcoma, these are all doesn't involve the pituitary per se, but they compress upon the pituitary and can lead to the symptoms. So that's why these images have been included. So in the chordoma, they show uniform enhancement but not much of calcification when compared to chondrosarcoma, which shows calcification on both the CT scan as well as on the SWA images. Usually they show heterogeneous enhancement. This is off-centered. In a chondrosarcoma, this is off-center, whereas in this one, In a chordoma, it is more of a centrally located, and if you see this, centrally located, and usually it is seen in the superior aspect of the clivus. Coming to the giant cell tumor, which usually arises from the pituitary fossa, that is the sphenoid bone, you can see that there will be destruction due to the differentiation of the osteoclastic cells. These cells, they differentiates and produces this type of images which shows calcification within them. Then coming to the last two entities, one is a meningioma. Meningiomas are suprasellar in location. You have to identify a normal pituitary at the pituitary fossa. Then only the meningiomas are seen. As I told earlier, they show uniform enhancement as you are seeing in this case, iso-intense or hyper-intense on T2 weighted images. And as I told earlier, the meningiomas, when it involves the this one, cavernous sinus, you can see there is a narrowing of the ICA margins. Whereas here, the ICA, compared to the opposite ICA, the involvement of the ipsilateral ICA on the left side, that is very thinned out when compared to the other side. So that is seen in this case where the contour of the vessel has come down. Coming to the other entities, this is a trigeminal schwannoma, which can compress upon the pituitary area, and also this is a case of hemangioma. You can see this in a hemangioma, it will be brilliantly hyperintense on T2 weighted images, and it will be compressing on the pituitary fossa, extending that. What happens is, with time, the hemangioma shows brilliant enhancement. If you take a immediate imaging, it may not show much of an enhancement, heterogeneous, but in the later part of the imaging, it shows a brilliant enhancement, which is a feature of hemangioma. The last entity is the cavernous sinus ICA aneurysm, cavernous sinus, which can mimic the pituitary adenoma. The only way to differentiate from that is the presence of, because people have operated thinking it as a pituitary adenoma, turned out to be a cavernous ICA aneurysm. So such incidences also have happened. We have to look at the presence of the flow artifact in a case of cavernous ICA aneurysm, which is not present in a case of pituitary adenoma. So that's how, in a nutshell, I have covered few of the topics. Few things I have not covered, like metastasis, the round cell tumors, which are usually very rare in such areas. Otherwise, we need to have a thorough understanding of the embryology, the location of the lesions, which are very, very important, whether the posterior pituitary bright spot is there or not, to interpret the imaging findings, whether it is an inflammatory, mass lesion, whether either neoplastic or non-neoplastic. Thank you.
Thank you, Dr. Arvind, for this vast and beautiful lecture. So may I have 2 or 3 questions from the audience? Yes.
Any questions?
There is some amount of problems in stock, and it is not diagnosable by some traditional means, then we want to have a biopsy. So how can we get the help of radiology in doing a pituitary biopsy?
No. What is the question?
How can we get the help of radiology while doing a pituitary biopsy?
Pituitary biopsy. Oh, pituitary biopsy, honestly, I don't have any experience regarding that, this one. What we go to the extent is the sinus sampling. To that level, we go as a radiologist. That we do it routinely at NIMANS. Other than that, as a pituitary biopsy, no, I don't have. We try to interpret the imaging findings only, based on the imaging.
Yes.
It is a collaborative thing. It's not just a radiologist who will be able to tell entirety. This one.
Sir, one question. Hello. Yeah. So, sir, regarding this hypophysitis or sarcoid, generally we see the optic tract and the optic chiasma at times together with the hypothalamus they get infiltrated. So, is that a means is this a sign of hypophysitis? How to differentiate means?
No, I showed the case of hypophysitis where it was involving the optic tract also, where you can see the T2-weighted hyperintense areas in the along the optic tracts.
So
In a case of sarcoid, see, sarcoid involvement of the pituitary stalk is one of the ways how it can present with. Along with that, the sarcoid will have other lesions like the involvement of the leptomeninges. There may be nodular involvement of the parenchyma itself or a disseminated sarcoid. Apart from that, there are other things like you have to image the chest to look for the hilar lymph nodes and also the involvement of the lungs. This one. Based on that thing only, you will have to come to a conclusion of a sarcoid because everything looks hypo and they all enhance. And pan-hypopituitarism usually will not be seen in a case of sarcoid. It is this one in a hypophysitis. So these are the ways you have to put multiple things into place to arrive at a diagnosis.
Thank you, sir.
Any other question? So thank you, sir, for a beautiful lecture.
Thank you for the opportunity. I once again thank the organizers.
So before the moderator says so, I have an announcement to make that we will, after the lunch session, we will gather together again at Subhash Mukherjee Hall, where we will have a brief introduction, followed by we will gather back here again. Over to Dada.
So moving from pituitary to next to adrenal. So we have our next speaker, Dr. Anupam Lal. So requesting Dr. Lal to please proceed with this presentation.
Yeah. Concept presentation. Open the presentation. Tuberculosis versus that last chondrosarcoma.
Thank you. Good morning. I thank the organizer for having me here. Please excuse me for my voice. I have some sore throat.
When there is a superficial siderosis, so when the pituitary hemorrhage is there, so there will be acute bright spot. Yeah.
No. Superficial cirrhosis happens.
आगे किससे बढ़ाएंगे इससे? हाँ? Presentation mode में डालो. Okay. So imaging of adrenal is a vast topic, and it is not possible to cover everything in a short time. But I'll be giving you some hard points, and I'll be speaking something about introduction and anatomy, clinical indication for imaging, and then common adrenal lesions, differential diagnosis, and protocol for management. Why it is very important for accurate imaging of adrenal? It is very essential to distinguish benign from malignant lesions. So if you diagnose a malignant lesion or suspected malignant lesion, further workup is required. If you diagnose a benign lesion and it is of no endocrine significance, then you can accordingly monitor these lesions with assessment in subsequent time. And it is also very critical for treatment planning and surgical decision. Imaging enables precise characterization of adrenal lesion composition, and we'll come to that, and guides follow-up protocols. So what are the clinical indications for imaging. The most common and most important clinical indication is finding an adrenal incidentaloma. It's very common, and in about 7% of CT studies, we see incidental adrenal lesions. So it's quite common. Then you have, if you have suspected hormone excess, then that is a clinical indication for imaging. Malignancy workup, obvious. Then surveillance and follow-up of known adrenal lesions. And there are additional considerations for imaging. If a lesion is more than 1 centimeter, it typically, in adrenal, it typically requires a characterization. So imaging is required for that. And if any adrenal lesion has a growth rate of more than 1 centimeter per year, it requires further evaluation. If a lesion has a atypical imaging feature, like heterogeneity, irregular margins, or high density, it requires further evaluation. And if there is a history of malignancy and you find an incidental adrenal lesion, it requires further evaluation. Briefly about anatomy. So most of the adrenal is formed by the cortex, and cortex has 3 layers: zona glomerulosa, which secretes mineralocorticoids; fasciculata, glucocorticoids; and reticularis, everybody knows, androgens. Then medulla secretes catecholamines. Adrenals are supplied by 3 adrenal arteries and drained by single adrenal vein. So let us briefly review what is the imaging modality we use for adrenal imaging. So CT is the workhorse, and it has an advantage of very high spatial resolution. And moreover, in CT we do some adrenal protocol imaging, and we calculate the washout. Based on the washout characteristics, we can characterize the adrenal lesion, which can be a adenoma, and CT is very reliable for calculating the washout and characterizing it as adenoma. So what is the adrenal protocols? In adrenal protocol CT, suppose you order a adrenal protocol CT, the radiologist will do a non-contrast CT, then a contrast imaging of the adrenal at 60 seconds. That is the time when the adrenal lesions will have a good enhancement, and then a delayed image at 15 minutes to calculate the washout. MR has the advantage of chemical shift imaging, or in chemical shift imaging, what happens? We do a gradient echo image in the phase where the water and fat, intravoxel fat, is spinning in the phase. So the signals adds up, and when they are in out of phase, their signals drop. So it is the chemical shift imaging is a detection of intravoxel or intracellular fat. So that we'll come to that. The why adenomas can be detected with can be diagnosed with confidence with MR. Ultrasound is not a good modality, and it is, but it is good for in case of children. Nuclear medicine does functional imaging. So when you are suspecting a metastatic disease, or you are suspecting a pheochromocytoma which is hidden, or there are multiple pheochromocytomas, then you can do a functional imaging. So let us come to the common adrenal lesions. So the most common adrenal lesion is incidentaloma, which is a lesion detected in adrenal for imaging done for some other purpose, not for adrenal cause. Then most of the incidentalomas are adenomas. We'll come to that. We have adrenal cyst, hemorrhage, and benign lesion like myelolipoma, pheochromocytoma. Then we have adrenal cancer, which is very aggressive, adrenal cortical carcinoma. Then adrenal lymphoma, adrenal metastasis, and some infections. So what is an incidental adrenal nodule? So it is an adrenal lesion more than 1 centimeter. Less than 1 centimeter, we don't pay much attention for characterizing it. More than 1 centimeter detected incidentally. It is usually a benign adrenal adenoma, and most common adrenal adenoma, out of all adenomas, at least 70 to 80% are non-functional. So they will not have hormone excess. It is very common, so 9% of general population in autopsy series have shown adenomas in adrenal, and 7% of CT studies we see adenomas. So it is quite common. So one has to be very familiar with the imaging protocol for adenoma. So most adenomas are non-functional, 70% are non-functional, and out of incidentalomas, 70% are adenomas. Very rarely 1 to 2% adrenal cortical carcinoma when they are picked up in a small, when they are still small, or pheochromocytoma. So incidentaloma workup involves non-contrast CT for initial density measurement and chemical shift MRI for indeterminate lesion. We'll come to that. So adenoma can be lipid rich or lipid poor. When there is too much of in the intercellular fat, it's lipid rich. So lipid rich adenoma will have a non-contrast CT attenuation of less than 10. Okay? So if you see a focal lesion in adrenal, and on NCCT, non-contrast CT, if the attenuation, mean attenuation of that lesion, it is homogeneous, mean attenuation is less than 10, finished. Your imaging stops there. It is a lipid-rich adenoma, provided it is not a cyst or a myelolipoma. So both myelolipoma or cyst can show decreased attenuation, but you can, by looking at it, we will be able to see that it is not a myelolipoma or cyst. So less than 10 HU, it is lipid-rich adenoma. If it is more than 10 HU, then we do a adrenal washout protocol, and we calculate the absolute washout or relative washout, depends on the, if you have done a non-contrast CT, then you can calculate the absolute washout, and that is the CT attenuation value of the lesion in enhanced phase, minus the CT attenuation value in delayed phase upon CT attenuation value in enhanced phase minus unenhanced. So mathematical terms, it will be washout per unit enhancement into 100. If it is more than 60%, then it is a lipid-rich adenoma. And similarly, relative washout more than 40%, it is adenoma. I'll show you an example. So this is a incidentally detected lesion in the adrenal. Yeah. Incidentally detected lesion in the adrenal. So measuring it, the mean attenuation is 5. No need of further imaging. It is a lipid-rich adenoma. Nevertheless, the technician was asked to do a CT adrenal protocol. So he did a enhanced phase 66, then delayed 11. Plug in all these numbers, you have a washout, absolute washout is 90%. More than 60% adenoma, lipid-rich adenoma. So when we do MRI, when the CT attenuation of adenoma or suspected adenoma is 10 to 30, those cases the MR may help by chemical shift imaging. So the MR will pick up intravascular fat, and I'll show you how. In phase and out of phase imaging, there is a adrenal layer enlarged. So this is an in phase image, gradient echo sequence. This is an out of phase image. You can identify the out of phase image by India ink appearance, cartoon character like organs. So in cartoon characters, you see their dense dark line around the cartoon characters. So India ink appearance, and you see this lesion has a drop of signal in the out of phase image. So you are sure now that it has an intravoxel fat, so it's an adenoma. Similarly, a small lesion here, in phase image, out of phase image, drop of signal, intravoxel fat, adenoma. Sometimes adenoma can show macroscopic fat, and it is very rare, but adenoma can undergo a change and can show macroscopic fat. Other differential would be a small myelolipoma or a lipoma, which is very rare. At times, or not very uncommon, you will see multiple bilateral adenomas. And in those cases, if hormonal excess is there, you have to do a lateralization by adrenal venous sampling if you are contemplating surgery. Imaging cannot distinguish between hyperfunctioning from non-functioning adenoma. So once you have diagnosed an adenoma, the hormonal workup has to be done to assess whether it is functioning or non-functioning. So management of incidental adrenal lesion, there is a general consensus that if lesion is more than 4 centimeter among the endocrinologists and the radiologists, if the lesion is more than 4, if the lesion is more than 4 centimeter, they have a very high risk of malignancy, so they should be resected. Now, the endocrinologists are of the opinion that if the lesion is less than 4 centimeter, radiographic evaluation should be done at 3 to 6 months, then annually for 1 to 2 years, and annual hormonal assessment for 5 years. Whereas the radiologists think that if once you diagnose a benign lesion, no need to follow up. So for masses 1 to 2 centimeter with no benign features, follow up adrenal CT MRI at 12 months to document stability, and 2 to 4 centimeter lesion, consider prompt adrenal CT MRI. There is no threshold growth rate for benign versus malignant lesion. I'll tell you why. Some benign lesions are very large, so they can enlarge, and so growth rate, if you take the growth rate consideration, you have to contemplate surgery in those cases. So coming to adrenal cysts are rare, and there are 2 types, simple or endothelial line cyst or pseudocyst, which is commonly seen after hemorrhage. So cyst, the key imaging feature is no enhancement. And you can see the large adrenal cyst, thin-walled, regular, no enhancement. Then cyst will appear bright on T2, and on out of phase image, actually it is showing gain of signal. So this is not an adenoma, this is a cyst. Sometimes the cyst will show calcification in its wall, and presence of calcification suggests that this is an acquired cyst. Well, radiologist has to be very, familiar with that. Sometimes the adrenal cyst, what appears to be adrenal cyst is not actually adrenal cyst. It is a exophytic renal cyst which is abutting the adrenal. We can see here, this is an exophytic renal cyst which is abutting the adrenal. So in axial image, it may appear as if it's an adrenal cyst, but it is not. And moreover, on the left side, a gastric diverticulum can mimic an adrenal cyst. And once you see it, presence of air will suggest that probably it's not a cyst and it's a gastric diverticulum. And you can give positive oral contrast to delineate. This was appearing as adrenal cyst, so give positive oral contrast is outlining the diverticulum. Then coming to adrenal hemorrhage. Hemorrhage on CT will appear hyperdense, about 50 to 90 Hounsfield units, with surrounding fat standings. And typical characteristic feature of hemorrhage is it does not enhance. If you are seeing enhancement within a hemorrhagic lesion, then you should suspect a tumoral bleed or something is there which has bled. MR is very sensitive and a specific modality which can not only diagnose hemorrhage but also tell you the age of the hemorrhage. The causes are traumatic and non-traumatic, like sepsis, surgery, burns, pregnancy, etc. And rarely adrenal tumors can also undergo a hemorrhagic change. So you see here, they say on CT it is hyperdense, no enhancement, surrounding fat standing, say adrenal hemorrhage. Ultrasound is a good modality for children. You can see a hemorrhage and fat standing around the hemorrhage. Post-hemorrhagic changes in adrenal will appear as a pseudocyst. This was a large adrenal hemorrhage, and you can see calcification in the wall. So it is acquired cyst. So adrenal cyst forming a adrenal hemorrhage forming a pseudocyst kind of appearance. Then this is a pregnant. She was a pregnant lady, and during pregnancy she had a large adrenal hemorrhage. Coming to a benign lesion, myelolipoma, which rarely, very, very rare to undergo a malignant change. So once you diagnose myelolipoma, nothing doing, unless it is causing mass effect, so no treatment is required. So it is a rare benign neoplasm, consists of macroscopic fat and hematopoietic bone marrow elements. So it will show large amount of macroscopic fat, and these are the examples. A large adrenal myelolipoma, fat will appear dark as if and comparable to the subcutaneous fat here. So large myelolipoma, sometimes the myelolipoma can be quite large and can cause mass effect, shifting the kidney to the other side. So when large, it can cause mass effect, and that time surgery may be undertaken. A very rare entity, as a myelolipoma can be extra adrenal also. So this is a perinephric kind of extra-adrenal perinephric myelolipoma. Now coming to adrenal hyperplasia, usually occurs when the adrenals are stimulated due to excessive ACTH production, ectopic or from pituitary, or in congenital adrenal hyperplasia when the adrenaline is not producing enough cortisol, so there is a positive feedback, and from pituitary excessive ACTH comes. These patients will have enlarged adrenals, and usually the limbs are more than 10 mm, and a useful indicator is that when the adrenal limbs are more than the adjacent diaphragmatic crust in measurement, they are likely to be enlarged. Usually the adreniform shape is maintained, and it may be functioning like in Cushing's or Cone syndrome, and it may be lipid rich also, and may show intravoxel fat in chemical shift MR imaging. So you can see the bilaterally enlarged adrenals. This is adrenal hyperplasia, and sometimes adrenal hyperplasia can be macronodular. You see both the adrenals here are enlarged, and you can see multiple nodules. So this is a macronodular adrenal hyperplasia. Then one very interesting topic is adrenal TARTs, adrenal rests in testes. What happens, there is excessive ACTH. So adrenal rest in testes, they undergo proliferation. Okay, especially in patient with congenital adrenal hyperplasia. So that is testicular adrenal tissue, the rest, small rests are there. They undergo proliferation, they destroy the normal testis parenchyma, and they appear on MR like this. This is called testicular adrenal rest tumors. Coming to pheochromocytoma, very important. and it's called a 10% tumor. So 10% cases are, from MBBS time, 10% are bilateral, 10% are extra-adrenal, 10% occurs in children, 10% are malignant, and 10% can show calcification. So the catch here is, once you see a brightly enhancing lesion in adrenal, and if the attenuation is more than 110, it is very likely to be a pheochromocytoma. So catch here is 110 Hounsfield units. So you can see, this is just a basic. The diagnosis of pheochromocytoma is not radiological, it is biochemical. So once you see increased amount of urinary metanephrines, catecholamines or plasma metanephrines, then you have to look for a pheochromocytoma. You see this very brightly enhancing lesion in right adrenal. So Hounsfield unit is more than 110. So this is an adrenal adenoma, adrenal pheochromocytoma. Pheochromocytoma are likely to show large amount of cystic changes in the center. Sometimes they appear as if there is a cyst, but some peripherally enhancing nodule will be seen always. So mean age is around 40, and they can be hereditary form, especially in von Hippel-Lindau disease, multiple endocrine neoplasia in type 2, or neurofibromatosis type 1. And then there is a pheochromocytoma paraganglioside syndrome. So an example of this is a cerebellar hemangioblastoma. So large cystic lesion, eccentric nodule, one nodule here, enhancing nodule. And what you see here, a brightly enhancing lesion in the adrenal. This is a von Hippel-Lindau disease. You can, it's not very clearly brought out. There will be multiple pancreatic cysts. Pancreatic serous cyst adenoma, they are associated. Bilateral renal cyst or bilateral RCCs. Then neuroendocrine tumor of pancreas, they are all associated with this. So on MR, how does pheochromocytoma appear? They appear as brightly enhancing lesion, but they can show cystic changes within it. And you can see that this is a brightly enhancing lesion with a large cystic change in the center. This is a pheochromocytoma. So the catch here is arterial phase enhancement more than 110 Hounsfield units, and lesion heterogeneity should prompt the diagnosis of pheochromocytoma. Then about imaging of pheochromocytoma, there was a notion that you should not image the pheochromocytoma without giving a alpha beta blocker, but with modern non-ionic contrast, it is not a contraindication for imaging. It can be done safely. So MR, the pheochromocytoma will show a light bulb kind of sign. In T2 they are very bright, so that's called a light bulb sign. So about functional imaging, we do a MIBG scan, which is very sensitive and specific for diagnosing pheochromocytoma. Not only it can confirm the diagnosis of pheochromocytoma, it can pick up extra adrenal sites of pheochromocytoma also. And in malignant pheochromocytoma, site of metastasis. So there are two, we'll come to that. So how will you identify a MIBG scan? You will not see a bone uptake and liver spin uptake. So you are seeing here a pheochromocytoma, which is very, MIBG is very specific, more than 90% specific and sensitive for detecting pheochromocytoma. Then DOPA PET is also, dopamine is a amine precursor, and it is picked up with epidomas, like here in carotid body tumor, and there is a pheochromocytoma. So both these lesions are picking up this avid uptake of DOPA PET in DOPA PET CT. Then MIBG scan can show you multiple metastases from pheochromocytoma, which are not suspected by other imaging. The endotopet again showing multiple metastases here, in a case of pheochromocytoma. Extra-adrenal pheochromocytoma is not uncommon, and one of the common site is organ of Zucker candle, which is at the level of the aortic bifurcation. And this is an example of a organ of Zucker candle pheochromocytoma. So all these lesions will be showing bright enhancement. Then sometime you will see multiple paraganglioma syndrome, like in MEN1, MEN2. So here you can see one in right adrenal, left paravertebral. There are others also. Then pheochromocytoma is one lesion which is very vascular, so it will show washout. And sometimes washout can mimic that of an adenoma. So this is one exception of washout characteristic. Like in this case, you see the washout is calculated here, it was 68%. So you may misdiagnose it as a adenoma. But you see in contrast phase, the mean attenuation is 108, very close to 110. And moreover, the diagnosis was confirmed on elevated catecholamines. So you have to remember that small pheochromocytoma can have a washout characteristic which can mimic an adenoma. But once you see an enhancement more than 110 or close to 110, it is likely to be a pheochromocytoma, not an adenoma. Then histopathology is not a very good indicator for malignancy. It can not very reliably differentiate between benign and malignant neuroendocrine tumor. So the criteria, radiological criteria are still better. You can see a malignant pheochromocytoma, which is invading the aorta here and psoas here. So once you see invasion metastasis, then it is a malignant lesion. Coming to adrenal metastasis, commonly seen primary from lung, thyroid, colon, kidney. So these are the common sites where, so you will see lesions in both adrenal or one adrenal, and they will not conform to the enhancement characteristic of adenoma. So there will be indeterminate lesion, but once you know that there is a malignancy, so you have to always suspect a metastasis. And you can see metastasis in the liver also. And here the PET CT comes to your rescue. It is a most commonly functional imaging. And it is non-specific marker of hypermetabolism. So infection can also be avid in PET CT. You have to take care of that. So here are some examples. Bilateral adrenal avid lesions. So it may be TB, lymphoma, or metastasis. Adrenal adenoma can also show avid uptake. Metastasis, avid uptake. Adrenocortical carcinoma with metastasis, avid uptake. So all these can show, it's non-specific. So all these can show avid uptake. Then there is an entity called collision tumor. Sometimes the metastasis occurs in a pre-existing adenoma. So the adrenal will show tumors of two cell lines. So these are called collision tumor. And this is an example on CT. There was an adenoma, and you can see there's heterogeneous enhancement. And MR will show the adenoma part will be showing drop of signal in MR, but the metastatic part or the other tumor part will not show drop of signal. So pre-existing MR is there. You have to compare it with after the metastasis occurs, then you have to compare it with that MR. So you will know that this is a collision tumor. Adrenal cortical carcinoma are very aggressive tumors. They have a bimodal age distribution, occurs in first decade and fourth and fifth decade. They may be functioning, especially in children. 70% of adenocortical carcinoma are functional, and they can cause Cushing syndrome, viralization, or feminization. They have, in general, ACC have very poor prognosis. Usually they are large in size, may show necrosis and calcification. So I have CT appearance. Calcification is rare in adenoma, but it is common in ACC. And I'll show you some example. This is a child. Usually the ACC are well-defined lesions, but they are very aggressive. This is a tumor in the adrenal in a child, and you can see sclerotic metastasis in the bones. Metastasis in the bones, so it's a ACC. ACC in an adult, very aggressive tumor, infiltrating the stomach, then infiltrating the liver, and the adjacent metastatic lesions are there. So this is adenocortical carcinoma, and PET-CT imaging is required to assess for metastasis, which may be unsuspected on other imaging. So this is a large adenocortical carcinoma with multiple lung metastasis. Then lymphoma or primary adrenal lymphoma are rare. Usually they occur because there is a retroperitoneal lymphoma and secondary involvement of the adrenal. And bilateral is more common than unilateral. Then usually you will see a adrenal is enlarged and they have maintained the adreniform shape. It is a primary adrenal lymphoma. Then you have these large masses in the retroperitoneum, which is involving both adrenals. And since lymphoma are soft tumors, you will see the vessels coursing through it without much distortion, or even the veins are patent. That is a sign very suggestive of lymphoma. Again, you see lymphoma, the renal vessels are coursing through it. The vein is not distorted, so bilateral lymphoma involving the adrenals and kidneys. Neuroblastoma are pediatric tumors, aggressive, and they have to be differentiated from Wilms tumor. Usually they cross the midline, they can show stippled calcification, very aggressive tumor. And adrenal, this is an example of adrenal neuroblastoma, large tumors. Then ganglioneuroblastoma is another tumor which is intermediate in severity, I mean aggressiveness, because they have a ganglionic element and neuroblastoma element both. And the characteristic imaging feature is that they take the shape of the area where they are located, and they show large nodular calcification. So let's come to, sometimes the imaging is not very diagnostic of what we are dealing with, and we are perplexed. And these are some cases where you see the dense calcification in the right side of the abdomen, and a large tumor showing very dense calcifications, not conforming to any other known lesion. So dense calcification here. PET-CT, faintly avid, marked calcification, adrenal involvement, and possibly infiltrating the kidney. So it was biopsied and it was poorly differentiated carcinoma. Again, we are tempted to make a diagnosis of tuberculosis, bilateral adrenal calcification, but the odd point here is enhancement of the rest of the adrenal, which is at this stage of tuberculosis when the calcification occurs is not seen. So it was taken out and it was a adrenal leiomyoma, very rare tumor. So adrenal leiomyoma. Now coming to tuberculosis, tuberculosis is very common in this part of the adrenal, tuberculosis is very common in this part of the country, and in fact it is the most common cause of adrenal insufficiency in our part of the country. So in tuberculosis of adrenal passes through 3 stages. Early stage you will see mild adrenal enlargement with enhancement, and then there is a granuloma phase when granuloma forms in the adrenal adrenal is enlarged and granuloma cause inflammatory response and causes destruction of the adrenal. You may see adrenal abscesses formation. Then there is a late stage where calcification and fibrosis occurs. So this is an example of adrenal tuberculosis. You can see adrenal is enlarged. You can see an abscess formation here. And you can see retroperitoneal lymph nodes showing hypodense centers, which is very suggestive of something which is causing lymph nodal necrosis or tuberculosis. Another example of tuberculosis, you see the tubercular abscesses in adrenal. So subsequently this will, then you see the retroperitoneal lymph nodes showing hypodense centers. Subsequently this will lead to fibrosis and calcification, as in this case. Another case of tuberculosis which was misdiagnosed as adenoma, and FNA was done. This is tuberculosis. Then advanced stages of tuberculosis will see calcification and fibrosis. Sometimes the calcification can be quite subtle and adrenal will be hypoplastic. Then fungal infection, histoplasmosis, is rarely we see histoplasmosis. So in the lung we see this immunocompromised patient, and histoplasmosis is usually part of systemic infection or isolated adrenal histoplasmosis also we see. So lung we see multiple nodules, interlobular septal thickenings, ground glassing, and what we see in adrenal are enlarged, hypoenhancing, and usually maintaining the adreniform shape. See the marked enlargement of the adrenal here, and you can see the on FNA, these are all intercellular histoplasma showing capsule. Abscess of adrenal is very, very rare, and usually it occurs in immunocompromised patients. Sometimes there is a large necrotic tumor and you do a biopsy and infection may travel to that tumor and you may see an abscess. And a characteristic hallmark of abscess is air within it or enhancement of the wall. This is a patient with HIV, and you see a right abscess in the liver, and then you see abscesses in the adrenal. It was sampled and it was a pyogenic abscess. Then one very rare fungal infection is mucormycosis. You can see large inflammatory mass showing thickened enhancing walls and surrounding fat standing, involving the right adrenal. And this is the biopsy showing stout fungus, showing right angle branching, or this was communicated to us that this is mucormycosis. So we'll summarize here. Recommended imaging protocol is initial evaluation by in a adrenal lesion, non-contrast CT. If you see a density of less than 10, no further imaging is required, only biochemical assessment is required. Then if you want to calculate the contrast washout, non-contrast or portal venous phase CT. In suspected adenoma, non-contrast CT or chemical shift MRI in indeterminate lesion when the CT attenuation is not less than 10 on non-contrast. In suspected pheochromocytoma, contrast enhanced CT or MRI and MIBG scan. Suspected malignancy, multi-phase CT, MRI with diffusion weighted image, and consider PET CT. So most adrenal adenoma, I'll conclude by saying that most adrenal adenoma are lipid rich and can be correctly diagnosed on chemical shift MR imaging or unenhanced CT. Some adrenal masses have pathognomonic CT features such as hemorrhage, myelolipoma, and cyst, and do not require any further follow-up or imaging. Then there are indeterminate adrenal lesions which require further evaluation, and the further evaluation consists of hormonal analysis and imaging follow-up. PET-CT in selected cases, biopsy and resection in some cases where you are suspecting malignancy. So I'll give you summarize with clinical practice guideline. Adrenal incidentoloma less than 1 centimeter requires no follow-up. For lesion 1 to 4 centimeter, use CT attenuation. If it is less than 10, it is adenoma, no further imaging, only biochemical workup. Consider dedicated adrenal MRI when CT is inconclusive in incidentoloma. And integrate imaging findings with biochemical testing for optimal management. That is the take-home message. Thank you.
Thank you, Dr. Anupam Lal, for extensive discussion about this adrenal imaging. So, do we have any question? So we can allow 3-4 questions. So requesting all the students to please get active participation in this workshop because we need a lot of questions from you.
Thank you, sir, for your nice presentation. I have one small question. Pheochromocytoma is very frequently cystic. So how come the Hounsfield unit becomes more than 10 almost always?
Yeah, very good question. Sometime you will see pheochromocytoma largely cystic, but it is very unlikely that you will see a pheochromocytoma without any enhancing nodule in the periphery. There will be some enhancing nodule in the periphery. It will not be purely cystic with thin regular wall. That is what.
Any other questions?
So do we have any other question?
So if no, so I can make a question.
Yeah.
Sir, you have shown there is in the picture of mucormycosis, adrenal mucormycosis, there are some thick fat, thick standing like pictures. Does this standing like picture, if they are present, does they indicate mucormycosis or do they call be sine qua non?
Very good question. See, we have seen renal mucormycosis very commonly. Adrenal is very, very rare. So mucor is a angioinvasive fungus. So what you will see in kidney, first I'll come to kidney. You will see a global hypoenhancement of the kidney, and you will see very thickened renal fascia and fat standing around it. Because it incites, when there is angioinvasion, incites ischemic changes and incites very good inflammatory response. So that is what you are seeing in adrenal also. So thick septae kind of thing and marked peripheral fat standing is very common with mucor.
So how can that be differentiated from adrenal hydatid, sir?
Adrenal hydatid. Hydatid adrenal very, very rare, and I have not seen a single case till now. It was labeled as adrenal hydatid, but it turned out to be something else. Hydatid, per se, the hydatid tissue is a parasitic tissue. It will never show any enhancement. That is point number one. Hydatid will be showing a well-defined wall calcification and then depending on the stage. But parasitic tissue will never show enhancement, whereas this inflammatory lesions will show some enhancement.
Thank you, sir. So any questions?
Sir, regarding this mean HU value, sometimes we have a problem that there is a small lesion, maybe 1 to 2 centimeter size, and I went to 2 radiologists for different opinions, and one would say that the mean is 10, one would say the mean is 15. So there is how exactly within the same tumor, there is some area which is minus 10,
Yes,
they report it as minus 10 to plus 5.
So for assessing the mean attenuation value of a lesion, first you have to have a thin sections. Okay, you should not assess with a large thick section. So at least 3 mm thick sections should be there. Second is that you will have to avoid the areas where necrosis or calcification is there. All right. So if you include the necrosis part, that will not enhance, so it will be fallacious. So usually it is for homogeneous lesions. If it is homogeneous, then because you are trying to diagnose adenomas. Adenomas are homogeneous lesions.
And if it is heterogeneous, we will directly go for a washout study.
Yeah, move for washout study.
Sir.
Thank you, sir. If you can give us some ideas regarding imaging in Conn syndrome. Conn's hyperaldosteronism.
Yeah, yeah.
So if you can
So,
give some practical tips regarding.
I mean, it's not very specific for Conn syndrome. Like you see, if you find some adenoma, you can characterize it. But there is nothing specific for Conn syndrome. But there are certain, newer pharmaceuticals coming up in isotope scanning. And they can pick functioning adenoma versus aware of those studies. So I'm not the right person to answer that. So, but there are some studies which can pick in radioisotope scanning. I think you have a talk on radioisotope scanning also. So they can pick functioning adenomas versus non-functioning adenoma.
So thank you, sir, for this wonderful discussion. So moving to the next part is the pancreas, which we all know that pancreas imaging is very, sometimes in some other diseases like FCPD or chronic pancreatitis, is easy to pick with this, even with the simple X-ray, but still some of the issues like insulinoma, which is a very small pancreatic tumor, is very difficult to diagnose through the imagings. So may I request our next speaker, Dr. Ajay Gulati, is a professor, Department of Radiology, PGIMEH, Chandigarh, India. May I request you, sir, to please proceed with your presentation.
Thank you, sir. So I would like to remind you everyone we will have to gather after the lunch for a brief session at Subhash Mukhopadhyay Hall, following which we will gather again for the academic extravaganza here. Thank you. Sir,
good morning, everyone. I hope I am audible. So, thank you for keeping interest. I know this is, one of the important sessions for endocrinologists, because we end up seeing a lot of imaging which is performed in various places, and I would briefly be talking about pancreatic imaging. So at the outset, I would like to thank the organizing team for having me here, especially Dr. Partha. So he told me that we see a lot of diabetics and what is actually the role of imaging. I thought I'll just briefly discuss upon that as well before talking about lesions which we pick up in the pancreas, how we resort to, imaging them, especially in various kind of clinical practices. So what I'll be trying to do is actually to try and show you what is the current role of various kind of imaging modalities before jumping onto CT and MR, because that is predominantly most of the imaging which we do for. So coming on to X-rays, we don't routinely, do X-rays in our clinical practice these days, but we know patients are referred from everywhere, primary healthcare setups. So we can get to see areas of calcification in a very typical location of pancreas and easily diagnose chronic pancreatitis. Sometimes in the setting of acute pancreatitis also, there are some signs which have been described. Like, in our MBBS days, we used to read about sentinel loops and colon cutoff signs, which are an indirect indicator of some sort of pancreatic pathology. Bariums, again, have lost favor. We don't routinely do them in our practice, but again, some primary and secondary healthcare setups, people still do bariums for various pancreatic pathologies. So we can get these kind of appearances where we can actually see widening of the C loops, again suggesting some pathology happening in the head of pancreas. Or you can get this reversed Frostberg 3 sign, which is mainly seen in periampullary malignancies, that areas. So something to know about. Ultrasound is, very commonly done for, I would say, a lot of non-specific abdominal complaints. And we know ultrasound is very good at hepatobiliary imaging. Having said that, pancreas generally is not very, very well suited for assessment by the ultrasound. The reason is because we have a lot of obesity in our part of the country. So patients are thick, there is gaseous distension within the stomach. So you may not be able to see the pancreas entirely in all your patients. So something to remember about. Having said that, we know, ultrasound is such an easily and available modality, but you need to have experience to see the various pathologies. So we'll be discussing that as we go along. EUS is again another thing which I've just brought up here because this is something which has really changed the management of some of the patients with pancreatic pathologies in the last decade or so. Although this is more a domain of gastroenterologists, but we should know what is the importance of EUS in the clinical setting. And the real importance is when you are interrogating smaller lesions which may still be indeterminate on CT or MR, EUS has got one of the excellent soft tissue resolutions. So you can actually characterize those lesions very, very well on EUS. You certainly can sample those lesions. Sometimes there are cystic lesions which you are not sure what you are dealing with. So you can do an FNA, you can take out fluid, send it, and that can help you. So something for us to know about. ERCP, again, we don't routinely do this domain of gastroenterologists, but again, mainly with the intent of, doing therapeutic interventions, like you need to place in stents there, or you can remove calculi, but there are some very specific imaging features, again, for various pancreatic pathologies. So having said that, let us move on to CT, which is in fact the most commonly used imaging modality. I would say this is the workhorse of various kind of pancreatic pathologies which we see in our practice. It's got a very good spatial resolution, so you can actually see the entire pancreas. That's the head, that's the body, and the tail region. Very, very well outlined. There are no technical challenges. We can do it in pediatric patients as well. Now with the current machines, the radiation, we can really bring it down to a very significant level. So CT is predominantly done in most pancreatic pathologies. So how we do a CT? So commonly done as a multiphasic technique whenever we are looking for lesions. So we commonly do a non-contrast CT. So that can help you in picking up calcifications, areas of hemorrhage. And more importantly, you get to see the baseline attenuation. So you can actually compare how much a lesion is enhancing, and that is what will help you in characterizing those lesions. But the most important phase is this pancreatic parenchymal phase or the arterial phase, where the pancreas normally enhances very, very optimally. And you can try and differentiate the background pancreas from any lesion which is there. So that's a very important phase whenever we are looking for any kind of pathology. And then followed by that, we do a portal venous phase, which is more like a general assessment phase where we look at the entire abdomen. We can look at lymph nodes, we can look at liver metastases. So various kind of pathologies in the rest of the abdomen. So if we order a CT abdomen, majority of the times people will just do a portal venous phase. But whenever we are interrogating any focal lesions in a pancreas, we need to do a multiphasic imaging because that is what will help us in characterizing those lesions. So coming on to MR, MR again is one of the very important tools. Although we don't routinely use it because of the logistic issues, it is challenging to do an MR because you need to breath hold, it takes a long time. There are issues of claustrophobia in some patients. So we need to remember where should we do an MR and where should we do a CT. CT works for most of the practical situations, but then sometimes there are lesions which may be indeterminate, or there are lesions which are cystic and you need to characterize. That is where MR scores over CT. So any cystic lesion which you are trying to interrogate, you would want to do an MR to better characterize if CT findings are inconclusive. Another important role is to look for ductal anatomy. So MRCP, we all know, is very good at ductal anatomy. So whenever you are looking at intraductal filling defects or communication of lesions with ducts, that is where you will want to do an MR. So we need to know which modality to use in what kind of setting. So again, these are the various sequences which we do. So we do a T1 and a T2 weighted sequences. Then we do an MRCP, a thick slab MRCP, which will give us an overview. I'll show you some images and then we understand that. And then we do diffusion and post-contrast imaging, which will give us some insight into the functional aspect of the lesion. So we'll discuss that as we go along. So basically, we need to know that CT is the main workhorse and MR is more often used as a problem-solving tool in smaller lesions, cystic lesions, and assessment of ductal pathologies. So now let us look at some of these lesions. So I've just put this up here. So we'll be briefly overviewing how we see these lesions on imaging. So let us, before actually moving on to the lesions, let us talk about diabetes, because we have a whole lot of audience of endocrinologists, and all of us see diabetes every day. And we know pancreas is the central organ, and majority of the biochemical imaging which we do, the HbA1c, doesn't give us a lot of information as far as the etiology of the diabetes is concerned. And this is where pancreas imaging is actually coming up, and that might provide some diagnostic and prognostic insights into how we image these patients. So in diabetics, majority of the times, if we look at the pancreas, that's an MR picture which I have put up. The pancreas will be more irregular in outline with altered in shape, and that is just a normal control subject which I put up. So the pancreas, look at the normal appearance of the pancreas, that's a control patient. The BMI was like 22, and that's a diabetic. So more irregular in outline, and generally the volume goes down, so we can actually do volumetry. Most of the current machines do have softwares where we can actually calculate the volume of the pancreas. So normal pancreas is around 70 to 80 cc's. But in diabetics, the volume will gradually go on reducing in time. And early on, you can actually have some volume coming back if the diabetes gets controlled. So there are studies now looking into that aspect as well. Again, so these are the kind of softwares which are available where we can actually map up the entire pancreas and we can calculate the volume. So this was a diabetic of around 15 years duration, and that's just a normal pancreas to show the normal volume. So that is giving us some insight into the volume. So I've also done some work on this where we developed a software with the engineering guys and tried to segment the entire pancreas and try to correlate as to how the volume correlates with the diabetics. So pancreatic fat is again another thing which is generated a lot of interest, because we can actually now quantify the pancreatic fat with some sequences which are now available. And PDFF is one such sequence where you can actually objectively quantify the degree of fat. And it has been shown that diabetics have an increased propensity of having fat, and there is a risk of increased development of diabetes in some of such patients. Now there are some recent studies which I've also seen looking at the stiffness of the pancreas. Now these are still research things and not routinely performed in clinical practice, but something to know about. So there is work going on even to assess the stiffness of the pancreas, which is supposed to be increased in these diabetic patients. And we know radiomics is coming up in a big way, where we are able to pick up information from the imaging data beyond what is visible to the normal eye. So there are some features which are automatically segmented, and that can help you in classifying these patients, whether a patient is likely to develop diabetes over time. So that is where the research is going into, and that might be the future as we go along. So now let us look at some of the imaging manifestations of conditions. This is the dorsal agenesis of pancreas, where there is failure of development of the dorsal pancreatic duct. So we basically see only the part of the head there, that's the MR, and the rest of the pancreas is not seen, and this is occupied by the small bowel loops. So this has an association with the MODY5 syndrome. In partial agenesis, you can get to see some part of the body as well, but the distal body and the tail region are not seen. So again, they have very, characteristic imaging features, so we can confidently pick this up on CT and MR, and certainly we know that they are associated with the MODY5 syndrome. Coming on to pancreatic lipomatosis, which is basically nothing but the replacement of the pancreatic glandular parenchyma with fat, and it basically extends from variable degrees. So that's partial pancreatic lipomatosis. You can see fat which has started replacing the pancreatic parenchyma, and you can actually see that the signal of this fat is comparable to the fat elsewhere in the abdomen. So that's all retroperitoneal and visceral fat, and you can compare. So pancreatic lipomatosis again is associated with the MODY8 syndrome, and these patients can develop cysts over time. So that's just an MR of the same patient where you can see the partial pancreatic lipomatosis very, very confidently. Again, another patient with complete lipomatosis. If you see the entire pancreas is replaced by fat here, you can see the signal of the fat very confidently on CT, and this is just like an imaging spotter. Coming on to hemochromatosis, again, this is one entity which can be very confidently seen on imaging, and imaging is actually helping in guiding the treatment of these patients. So we know we can pick up iron deposition both within the liver, the pancreas, and we can actually differentiate between primary and secondary based upon where the iron is accumulating. So in the primary hemochromatosis, we see that the iron starts getting deposited in the liver, the pancreas, but the spleen and the bone marrow are characteristically spared because the reticuloendothelial system is not getting deposited by iron. So that's how we differentiate between the two entities on imaging, and the liver predominantly looks very dark on both T1 and T2. That is how we diagnose hemochromatosis on MR. Again, another patient, this is again another patient of hemochromatosis, just to show you the dark part of the liver as well as the pancreas. And I've just put in this picture to compare that this is how the normal signal of the liver and the pancreas should be. So you can actually compare, and now you can actually quantify the amount of iron which is deposited by the T2 star values. That can help you assess your therapeutic response to the treatments which these patients are receiving. So this is certainly adding to management of these patients of hemochromatosis. Coming on to pancreatitis, we see a lot of pancreatitis in our setups, and this is one of the common pathologies which may sometimes have endocrinological manifestations, but I would say more often the diagnosis is of typical abdominal pain with raised amylase and lipase levels, and we actually don't end up doing imaging in most of the patients who have mild pancreatitis. Having said that, imaging has some very characteristic features. So I'll be just showing you very, very briefly how pancreatitis looks like on imaging. And this is what the classification which we follow while reporting such patients, because this is trying to standardize the terminology. People use various kind of terms. People use, things like pseudocysts, phlegmons. So there are some very specific terminologies which will help in standardizing the way we report the fluid collections associated with pancreatitis. And remember, CT, which we do, should not be done very early in patients of pancreatitis, because you don't pick up necrosis very, very confidently in early pancreatitis. So the Atlanta classification is the main classification how we report these patients, and that advocates that we do a CT around 3 to 5 days. In fact, beyond 3 days, generally 5 to 7 days, when we can confidently pick up the fluid collections of pancreatitis. So in pancreatitis, we get to see a mild bulky appearing pancreas there, and you have a little bit of stranding. This is mild pancreatitis, which happens more often than commonly. And this is just a normal pancreas I put up. So just to show that the normal pancreas, you can very beautifully outline the clefts along the margins. And if you compare the two, here the pancreas appears swollen, there is stranding, the fat around is not clean. This is what we get in mild pancreatitis. And that's the relatively less common but the more badder part of pancreatitis, which is the necrotizing pancreatitis, where we get these necrotic fluid collections which can involve the pancreas or can extend elsewhere in the abdomen. So we basically, classify the fluid collections into various categories based upon whether the patient has interstitial or the necrotizing pancreatitis. And that's interstitial pancreatitis, where the fluid collections are very low in attenuation. These are the patients who do generally very well, don't need to do a lot of interventions to treat these patients. And some of these patients can actually evolve onto developing pseudocysts, which are again clear and would generally respond on their own. Sometimes they are larger and you need to drain them when they are causing pressure symptoms. But the more badder collections, or the prognostically badder group of pancreatitis, is the necrotizing pancreatitis, where we see these necrotic collections. This is involving the pancreas, or sometimes they are more heterogeneous appearing, can involve the pancreas with involvement of various peripancreatic locations. We end up doing a lot of interventions in these patients. Again, if you do MR in these patients, you can pick up the non-liquefied components, and that's got a very important advantage of picking up these components, because these patients need to be treated more aggressively. Now, coming on to chronic pancreatitis, which can present with type 3 diabetes, we know this commonly because of repeated attacks of inflammation. The pancreas will start appearing more heterogeneous on whatever imaging modality which we may do. We can pick up areas of ductal dilatation. We can pick up calculi or calcifications within the pancreas. That's an ultrasound just to show some ductal dilatation. There are these filling defects within the ducts which represent intraductal calculi in this setting. And that's the CT of the patient of chronic pancreatitis. You see this irregular appearing pancreas. There is intermittent ductal dilatation with some calculi along the course of the duct within the glandular parenchyma. So you get a background setting of chronic pancreatitis very commonly. There may be superimposed acute pancreatitis or other complications like even malignancy coming in the background of chronic pancreatitis. So we need to know this because we see this very commonly in our practice. Again, this is just some of the MR pictures to show the ductal changes of chronic pancreatitis. You can get to see irregular ductal dilatations with strictures. You can get to see filling defects, and that's how MR scores over CT in these patients. Another patient with florid chronic pancreatitis with irregular appearing ducts. You can pick up small intraductal filling defects, which are the calculi within the ductal system. The classical chain of lakes appearance seen in chronic pancreatitis. That's the CBD stricture in the head of the pancreas. You see some biliary dilatation more proximally. This information is really well outlined by MR over CT. Coming on to another entity which has some very classical imaging features is the autoimmune pancreatitis. We know the diagnosis of autoimmune pancreatitis is made by a combination of various imaging factors with imaging, raised IgG4 levels. They have a very characteristic lymphoplasmacytic kind of histology when you sample these patients, and we know how dramatically they respond well to steroids. So on imaging, what we get to look for is basically a bulky appearing pancreas, similar to what we get in the interstitial pancreatitis, but you don't get associated significant stranding or fluid collections which are seen in the common garden variety of interstitial pancreatitis. So you get a very smooth looking pancreas. Again, you don't see those clefts which are normally present. That's again a very sausage appearing pancreas. Another patient, if you look at the pancreas, it is absolutely smooth, lack of lobulations, hardly any stranding around. This is what may, think of autoimmune pancreatitis. Again, just put up a normal picture of the pancreas to show that the normal lobulated architecture is actually lost in autoimmune pancreatitis. And sometimes you can actually get a thin halo around the entire pancreas, which is again a very classical radiological sign to diagnose autoimmune pancreatitis. Now we know IgG4 is more like a systemic disease and can have various other presentations, one of them being sclerosing cholangitis. So this patient also had biliary dilatation because of the associated sclerosing cholangitis. We can pick up lesions elsewhere in the abdomen, like there may be renal lesions which are actually pseudo lesions or periaortic soft tissue thickening. So we make a diagnosis of IgG4 quite confidently when we pick up a combination of these imaging findings. So let us talk about pancreatic tumors, because this is one of the most sinister malignancies which we see in our practice, and majority of the patients are actually unresectable when we pick these up. So what we do as a radiologist is we not only help in the detection, but we can stage these lesions very appropriately and can guide the subsequent management. So what we basically look for are these hypodense lesions which are very scirrhous, and they will cause ductal obstructions. So always try and trace any ducts whenever you see a dilated duct in the pancreas at the site where the duct is getting obstructed. One should always be very cautious in evaluating that area for early malignancy. We can certainly, talk about the resectability of these tumors, but that's more of interest to the surgeons, where we try and look for, whether there is any arterial involvement or venous involvement, and that is how we stage these patients for further Whipple's or NACT treatments. Again, various kind of manifestations of ductal adenocarcinomas, which are generally hypoattenuating. You see the duct getting obstructed at the level of the mass. And once you look at the distal gland is actually quite atrophied. Look at this picture. You see a significant atrophy of the distal gland with marked ductal dilatation. Once you see that much of amount of atrophy in the distal gland, one should always be cautious in looking for pancreatic cancer. Sometimes you get it in a background of chronic pancreatitis in diabetics as well, where you try and look for soft tissue masses. You need to sample most of these patients to prove whether they are cancers developing in a background of chronic pancreatitis. You can get to see abrupt ductal obstructions by larger malignancies, and rarely you can get to see even cystic areas within these adenocarcinomas. MR again, as I told you, has a very good soft tissue resolution. So you can see similarly the mass very well on MR as well, leading on to distal ductal dilatation and some atrophy of the gland. Another patient where you see a mass in the head of the pancreas, that's the T1, that's the T2. But notice this picture, you can actually see the dilated duct, and that's getting abruptly cut off in the region of the pancreatic duct. And when you compare this with the T2, you see a mass which is causing obstruction. That's a very specific imaging feature to diagnose pancreatic cancer. So this is just to highlight how we actually say whether the vessels are involved or not, and that is how we determine the resectability both with the arteries as well as the vein, and we can actually predict whether the tumor is resectable. Some patients are borderline resectable, so I'll just skip this in the interest of time, and then there are larger unresectable patients. So coming on to NETs, which is more important from the endocrinology perspective, and this has again some very characteristic imaging features. Majority of the patients are sporadic, but we know they may be associated with syndromes like VHL, MEN1, NF1, and again what we try and look for, so that's the spectrum of hormones which may be produced by these patients. And what we see on imaging is basically lesions which appear hyper-enhancing. So that is similar to what we see in adrenals as pheochromocytomas. We see lesions which enhance well on the arterial phase. And remember, routine adenocarcinomas generally don't enhance. They are hypovascular. And this is one thing which will help us in picking these lesions very well. Smaller lesions are generally homogeneous, but larger lesions can appear heterogeneous with areas of cystic changes and necrosis. Now let us look at this patient. Now that's a lesion in the head of the pancreas. You see irregular peripheral rim enhancement. That's the arterial phase. The lesion even shows enhancement on the venous phase. One should always suspect an NET in such a patient. So another patient, look at a bulky mass, very well enhancing on the pancreatic parenchymal phase, and again, retaining some contrast even on the portal venous phase. This is very classical of an NET. Dual energy CT, this is a relatively recent advancement in the field of CT technology, where it can help us in picking up lesions which are only subtly hypervascular, or the hypervascularity is not really that avid to pick up very well on routine CT. So this is where dual energy can help us. Look at this patient who presented with dysphagia and had an incidental pancreatic lesion. So when a pancreatic lesion was seen on routine CT, you can see there is a subtle lesion which is there in the pancreatic neck region. But on a dual energy CT, this lesion is relatively more confidently picked up on the lower KV images. We can even generate these kind of iodine maps which will help us in detection of iodine, which is the contrast which we give when we do a CT. So the lesions which are subtly hypervascular will be better picked up if we have the luxury of having these kind of CTs. We will try to do dual energy in these patients. Coming on to MR, again MR can pick up NETs similar to CT, and MR sometimes can pick them up better because of the better soft tissue resolution. Again, the catching point is to pick up hyper enhancement in the arterial phases, similar to what we see on CT. Functional imaging is coming up in a big way, and in this sense, in fact, the majority of the time, the diagnosis when we are in doubt on CT on MR, the nuclear imaging comes to our rescue. So we can do an octreotide scan, but we commonly end up doing a gadolinium DOTA scan, which is very well picked up in lesions which are well differentiated. The poorly differentiated NETs will be better picked up on the FDG PET CT. Let us see an example. There is a bulky lesion replacing the head of the pancreas, some calcification. We are not really sure what we are dealing with on routine CT, but when a gadolinium DOTA PET was performed, the lesion lighted up very avidly, confirming it to be a neuroendocrine tumor. Coming on to lymphomas, again, these are not very common lesions, but sometimes we see them in our practice. NHLs are the more common lesions which can present as focal lesions. We see a focal lesion, can't really say on the CT whether it is a lymphoma or something else. Sometimes they can diffusely involve the entire pancreas. So just for you to know that lymphomas can involve the pancreas, similar, but just on a single imaging, I think you can call it as autoimmune or some sort of pancreatitis. So coming on to metastases, again, just want to show you an example. This is a patient who had a nephrectomy for RCC. you don't see the left kidney, and you see multiple hypervascular lesions similar to what we see in NET. So metastasis is an imaging differential of NETs. NETs certainly would be symptomatic in majority of the patients which we image. Cystic lesions is again something which we are increasingly picking up with increasing use of cross-sectional CTs and MRs. We pick up very small cystic lesions. We don't know what to do with them. So CT, especially the smaller lesions, we are not really sure. We end up doing an MR, and that has some very specific features which we'll see as we go along. So whenever you see a cystic lesion, the first thing which should come into your mind is, are we dealing with pancreatitis? Because pancreatitis is so very common in our practice. But once there is no background history of pancreatitis, there is no alcohol abuse or any biliary cause, and you see a complex looking cystic lesion, that is when you should try and think, are we dealing with a cystic neoplasm? So these are some things you need to keep in mind. So again, based upon morphology, whether the lesions are, commonly they are pancreatic associated fluid collections, sometimes they may be microcystic or macrocystic. I'll just briefly show you some examples. So that's a serous cystic neoplasm, a microcystic lesion, very well outlined on the MR. If you see the CT, you are not really sure what you are dealing with, but MR can have very characteristic imaging manifestations. Another patient of serous cyst adenoma, multiple small cysts, very beautifully outlined on the MR. And when you see the CT, you can pick up calcification. Remember, calcification will always be very well picked up on CT. MR is a little difficult to pick up calcification, which will be seen as dark flow voids. Mucinous cystic neoplasm, this commonly presents with larger cystic lesions with some mural nodules. Another patient with larger cystic lesion, more than 2 centimeters, some peripheral calcification. This is mucinous neoplasm. IPMN is again another entity which we pick up at times, and what we actually try and look for is any communication with the ductal system, which sometimes you can very well see on the MRCP, and that is what will help you in making this diagnosis. Now before I end, just want to show you some interesting cases, and I actually want to ask some residents to say, because this is pretty much what we've seen over the last 40 minutes. So let us see this patient who was in fact a diabetes, and that's the CT. Anybody wants to come up with an answer for this? What are we dealing with here?
Anyone with the answer? Can anybody want to give an answer? So please raise your hand and tell.
Yeah, so I thought we should keep it a little interactive. So if you try and see the pancreas, what do you see? So you see a major part of the pancreas being replaced by fat. And you can easily pick up fat when you compare it with the fat in the adjacent retroperitoneum. So there is definitely partial pancreatic lipomatosis. That's the normal part of the pancreas which is still left and not replaced by fat. So this is partial pancreatic lipomatosis and is associated with MODY5. These patients can develop cysts over time in VHL patients especially. May be seen with aging, but then various sort of metabolic syndromes can present like this. Let us look at another patient. Yes, this is in fact a spotter for majority of the radiology residents when we see these patients. Very characteristic morphology. Can anybody point out what are we dealing with here? Sorry? Ma'am, here on MR actually there are multiple cysts, if you see, which are replacing almost the entire pancreas. So you actually don't see the entire pancreas here, which is nearly replaced by the cystic changes. And that's the contrast MR, again, you know, beautifully outlining the cysts which are replacing the entire pancreas. And this patient also had a lesion in the, had brain symptoms, so we imaged the brain and there was a lesion in the posterior fossa. Now anybody can come up with a, yes, so this was a patient of VHL, okay. Another patient, so this patient actually had a lot of epigastric distress, also had endoscopies planned, but patient was reluctant to undergo endoscopy. They asked us to do imaging, patient recurrent peptic ulcerations. So we did an imaging and we could see a very subtle lesion, actually not really well seen here, but if you see the venous phase, you see a very subtle lesion. We were not really sure what we were dealing with here. When we looked at the stomach, the folds of the stomach looked a little thicker to us. So this patient actually underwent a nuclear imaging where this lesion in the pancreas lighted up. So this was actually a gastrinoma which was leading on to Zollinger-Ellison syndrome. You could see increased uptake diffusely within the stomach wall, and you could pick up the NET. So nuclear imaging certainly comes to rescue in times when cross-sectional imaging does not help us in practice. Another patient, this is again one of the spotters, I would say. If somebody can just come up, if you look at the distal gland, what do you see? So you see a lot of ductal dilatation, and there is significant atrophy of the gland there, right? And when you follow this, so in our radiology teaching, we always say that you should try and follow the dilated duct. And this is the place where the duct is getting obstructed, and there is a mass sitting in this area. So this is basically early pancreatic cancer. So one should always pick up such kind of patients. Okay, so this was a cystic lesion in the pancreas on a routine ultrasound. So it's very non-specific to say what we are dealing with, but the point which I want to make here is that whenever you see heterogeneous cystic lesions in the pancreas, always put on your color Doppler. So you might actually be dealing with a vascular abnormality. So this was actually a patient of pancreatitis who had developed a pseudoaneurysm secondary to pancreatitis. So this is just a learning. Whenever you see fluid collections, you get some very specific signs on color Doppler as a yin-yang, and you can pick up these pseudoaneurysms very confidently, even on ultrasound. And then this patient was taken up for interventional radiology treatment, where this lesion was trapped. So there were coils which were deployed to take care of this pseudoaneurysm. So I would want to end here by saying that CT remains the workhorse in majority of the clinical situations. MR, although technically more superior, we use it more for problem solving, for cystic lesions, for ductal abnormalities, and a lot of advancements are happening in the CT technology. So it has to be a multimodality strategy to pick up these diseases, to try and follow these patients up. Thank you very much. I'll be happy to take any questions if they are there.
Thank you. Thank you, Ajay Gulati, sir. So, do we have any question?
Sir, would you like to comment anything on groove pancreatitis being mislabeled as tumors?
Okay, so that's a good question. So groove pancreatitis is something what we pick up in our practice, but majority of the time what we try and look for is some stranding within the groove with some fluid collections. So cystic medial dystrophy is one of the common differentials, but what we commonly look for is inflammation happening in the groove. Differentiation from cancer is relatively less likely, because majority of the cancers will incite desmoplasia and they appear more fibrotic. Sometimes there is associated pancreatitis when it becomes difficult. But groove pancreatitis commonly can be very confidently seen on CT with stranding and some fluid happening along the groove, the head appearing a little heterogeneous. Sometimes if it is only to the groove, the head may actually be normal. So can be picked up well on imaging.
Just wanted to know your experience with using GLP-1 targeted nuclear imaging for insulinomas, extending for scans.
So ma'am, there are some exanthem scans which are being done by the nuclear imaging people. So majority of the times they will still end up using routine NET scans like DOTA PET and FDG PET, because majority of the insulinomas, they are benign lesions. So FDG is generally negative. They pick them up well with DOTA. There is literature of exanthem scans as well. I personally don't have experience because we have a different nuclear medicine department which looks into this part. But there is literature to support that these scans are supposed to be more sensitive and can be used, I would say, still as a problem solving tool in times when there is hypoglycemia and Whipple's triad and you are not picking up lesions. There is literature to support exanthem scans.
Yeah, supposed
but
to
I don't have a practical.
Better expression of the GLP-1
Anupam sir, can you add something in this? Because. Okay.
Thank you.
Sir, I have a question.
Yes,
sir,
please.
You have mentioned about the volumetric assessment of the pancreas.
Yes.
So do you have any study comparing the C-peptide level with that of the volumetric assessment so that we can replace this imaging modality as a part of the insulin status of the
Honestly, I am not aware, because C-peptide levels earlier were more commonly used, But now with the present softwares, and we commonly do this volumetry. More often we do it for the liver because pancreas is more a shorter organ, more curved in, but the softwares are pretty accurate, and we've actually done volumetry. We've actually developed one software with our engineering teams as well. But now at a click of a button, you can get volumetry, you can follow these patients up. So there is work going on this, but vis-a-vis comparison with biochemical studies, I am not aware about such things. Sir.
What I found interesting was your imaging modalities in metabolic syndrome and diabetes. So we are going to see more of that, and is that going to be a definite science in future? Because you see type 2 diabetes or metabolic syndrome walks in, that would be very nice to tell the patient, see your pancreas and see how it can become normal.
When I was trying to review the literature from imaging perspective, looking at diabetes, now there is literature where people have shown, there are some papers, and I believe it is still into literature, but they are trying to predict whether the patient would be having diabetes over future course of time by CTs. And there are some automated softwares. We don't know how much are they validated to actually be useful in practice, but work is certainly going on, and I believe with the way AI and radiomics is coming up in a great way, that might be the future. Like
the size of pancreas does change.
Yes, certainly, ma'am.
Actually, same thing I wanted to ask, ma'am has asked. Okay. But are you doing radiomics in PGI?
Sir, honestly, not in routine clinical practice. As a part of some projects, we are doing some work on that, but that is still into a little bit of research only.
Sir, I have another question. For the FCPD particularly, still our routine practice is to do USG, and also the guidelines also suggest that. So do you want to replace the US with the CT scan, as you have mentioned that it's not well picked up by the US?
So this is the practice which we routinely follow, doing an ultrasound. Ultrasound certainly has its own advantages, right? But then when you are trying to pick up some malignancies in the background of FCPD, I would believe cross-sectional imaging, either CT or MR, certainly whenever there is a clinical suspicion, that is, as a radiologist, I would say that would certainly give us wealth of more information than a routine ultrasound. Yeah.
So students, any question to sir? No. Thank you, sir. Thank you for your...
I have a question.
Yes, yes, please. Yeah.
So, sir, you have told us about the dual energy CT scan. So, from the standard CT machines, is it possible? Or
No. So, dual energy CT, these are different CTs. Every vendor has a dual energy CT. So, basically, the difference is that it acquires the entire data in two different energy sets. It is not feasible with all the CT scanners which are available. There are some specific machines. Some machines have actually two CT tubes, so they can actually acquire at the same time so that the overlapping is proper. But then there are some machines, but that has to be a separate machine. So they are called as dual energy CT scanners as well. And still I would believe not many places have them. I don't know about Kolkata, but still the availability is certainly an issue. But again, we have the luxury of having it at our institute, and we do it for most of our patients, and it certainly adds to a lot of value, especially in cases where the enhancement is subtle, you are not really sure on CT. So we are using dual energy more confidently.
And sir, another question is, when you told us about the proton density fat fraction,
yes.
So is it available in all the MRI machines, or we have to install?
I think it's available in majority of the 1.5 Teslas. That's more like a sequence which is available with majority of the vendors.
So if I ask the technical team to give me the proton density fat fraction images,
yes.
or
you can objectively quantitate the degree of fat. It gives you a value in percentages, 10%, 15%. We actually did a study where patients on DEPA of diabetes, we tried to show that the fat is coming down. So we did a PDFF, and then 6 weeks beyond DEPA, we again imaged and tried to see whether the fat is coming down. So it's available, routinely feasible.
So any more question? So thank you, Ajay Gulati sir, for your excellent deliberation and discussion. So hence, we have completed this workshop session. So requesting all the registered participants, we have already registered for this workshop, please come and take the participation certificate.
So the participation certificates are available at the corner with us. Those who have registered, please come to us. We will distribute the certificates one by one.
Amit Bagga,
ये लेना बेटे.
Dr. Amit Bagga. Sure. Dr. Ankush Upenja. Dr. Ankush. Dr. Arsad Mosha CM. Dr. Ayush Gupta. Dr. Bandana. Dr. Debolina. Dr. Sanjay Kumar. Dr. Gullapai Veera Venkata Shiva Ramakrishna. Dr. Isha Gupta. Dr. Kanav Khanna. Dr. Kritiman Mondol. Dr. Moinak Sarkar. Dr. Mrinal Meshram. Done. Dr. Nidhi Sheth. Dr. Pratyush. Dr. Rajdeep Basu. Dr. Remaya. Dr. Shamoli Misra. Dr. Siddharth Pandey. Dr. Siddharth Shankar Bhuya.
Just interrupting a bit. So after this session, we will have lunch at the outside at the tent. And after that, we will gather around in the Subhash Mukherjee Hall. We will for a brief session, after which we will regather here. Thank you. So on to the distribution.
Just come this side. Dr. Sneha Purohit. Dr. Sonali Palai. What? Sneha. Yeah. Yours? Dr. Shomodik Rokhit. Dr. Srihari. Dr. Tati Hamia. Dr. Vojala Nishant. There's no name. No. Give it. Dr. Piyush Agarwal. Dr. Prithvij Kole. Dr. Ranita Bhattacharya. Dr. Shapon Shah. Dr. Shishendu Mondol. Dr. Siddharth Panigrahi. Dr. Anjali R. Nair. Dr. Apurva Agarwal. What's the name? Dr. Ayush Agarwal. Dr. Ayushi Singhal. Dr. Batusri Vaishnavi. Dr. Ruhi Nanda. Dr. Ajit Jagtap. Dr. Ajit Jagtap. Dr. Gursiman Singh. What is that? Ajit. Dr. Jemina Islam. Dr. Kishan Subramanya Vishwamitra. Dr. Kumar Swapnil, Dr. Maitri Doshi, Dr. Naman Agarwal, Dr. Simran Thakkar, Dr. Shoma Srinivas, Vezendra, what? What's the name? Just wait for a minute, we'll give it. Just Dr. Sonalika Shao, Dr. Shomil Bera, Dr. Shukanto Dotto, Dr. Vaibhav Goda, Dr. Aditi Chapra. Thank you.
So anybody who has not received or who has gone outside, please know that we will keep these certificates with us in the corner so that they can be collected later on. Thank you. Only for those registered ones. You have registered for that in this session? Name? Just tell. Just tell.
Behind the registration desk for the workshop.
And right now?
No, when we came.
Or today only. I don't think that. Meanwhile, discuss with the registrar. First, then we will, right? So we declare lunch now. We will gather in the Subhash Mukherjee hall after the lunch, after which we will regather again here.
দেখছি আর না হলে ইয়ের ফাইলগুলো লোড করে দেবে মানে না ওয়াইফাই কি কেটে যাবে না না ওতে কিছু লাগবেই না প্রিভিউ রুমের সাথে মানে কেটে যাবে প্রিভিউ রুমের সাথে প্রিভিউ রুমের
Hello, check, check, check. Hello, check, check two.
Warm welcome to you all. Hello. Warm welcome to you all. After the sumptuous lunch we have, it is our next session to commence. But before that, I will request the esteemed delegates who are present here to briefly gather in the Subhash Mukherjee Hall, which is just beside this hall, for a brief introduction session, after which we will all gather around in this hall for further academic extravaganza. Thank you. আজকে জাস্ট ফর কনভেনিয়েন্স রিজন এটা হয়েছে, পরের দিন এটা হয় ওইটাও দেখো লোকজন ঢুকছে। So, reiterating once more, we will have a brief introductory session at Subhash Mukherjee Hall, where the delegates are requested to gather for a brief session, after which we will all gather here for the next session of academics extravaganza, the topic of which is advanced courses regarding DEXA. Thank you. उसके बाद मैम इधर पे होगा एडवांस सेशन इन डेक्सा। थैंक यू मैम। আসছে এখানে। So we are good to go. After that heartwarming video on the development of endocrinology in Bengal, we have again gathered here for the next session of academic extravaganza, the topic of which is bone mineral density, the advanced DEXA imaging sessions, right? So for this session, I would like to call upon stage Dr. Shinjan Patro, who happens to be known as an endocrinologist and an astute physician who is serving as assistant professor in the Department of Endocrinology, All India Institute of Medical Sciences, Kollani, and who also happens to be one of my best friends, right? So, putting the baton on, so I would like to call upon stage Dr. Shinjan Patro for moderating the next session. Thank you.
Warm welcome all. So it's been a privilege to having a part of this DEXA workshop, and so working on the DEXA during my DM time and post DM also has made me, or rather allowed me to learn a lot of intricate things, and we are still learning, and all are still learning. So it's very happy that SCCON has given such opportunity to learn more in detail about the DEXA. So obviously I think I can see a lot of residents, and I think with couple of minutes I think it will be full and overflowing. I think there will not be any seats left, so that's very good to see and very encouraging for all of us. So for SCCON 2025, I need to thank the organizing committee, Sujoy sir and all, Pradeep Mukherjee sir and all organizing committee to giving me the opportunity to moderate and having the session on DEXA, which is very important for all DM residents, as well as when we are going out to practice. We need to learn the intricacy to interpret the reports, to advise anti-osteoporotic therapy accordingly, and learn apart from usual learning the DEXA, only the BMD reports, what are the other intricacies which we have. So in that aspect, we have a lineup of 5 distinguished speakers who are actually working on the DEXA and have a lot of academic publications as well as academic acumen to their credit. So I would, very importantly, all talks I would like to say will be more of a interacting. I would like to have more of interacting, so I will ask mostly the residents who are there. I'm sure a lot of will come more also. So please ask your queries to the experts, and at the end also we'll have a panel discussion where you can put all your queries there. So without not furthering delay these things, I'd like to ask respected Dr. Manoj Chadda sir, consultant endocrinologist at PD Hinduja Hospital, Mumbai. Sir has been a prolific endocrinologist, DNB teacher since 2008. Ex-faculty in KIM Hospital, and many more laurels to sir's credit. So sir will start off the most important part for the beginning of the DEXA, that the usefulness of DEXA in practice and how to advise and interpret the reports. So that is the most important foundation stone the residents need to learn. So welcome sir here, and over to you sir.
Thank you, Shinjan. So whenever you have a big program going on, you have the star players, speakers, entertainers, and then you have 1 or 2 persons to come and start the program. So I feel like the person who's going to introduce you to the topic, and then we've got star speakers following me. So just have to bear for 20-25 minutes with me. To give me a feel, how many of you are confidently seeing DEXA reports and commenting on it? That's it? Okay, so then does it make sense to ask you the second question? How many of you have a DEXA machine in your center? Oh, there's so many hands, then why you're not confident about reports? Okay, hopefully in the next 3 hours things will change. We'll ask you the same question at the panel discussion. See, panel discussions are not one-way discussions. They're always two ways. And since this is a workshop, although I will be speaking continuously for 25 minutes, please feel to stop me in between. If there is a burning question, just raise your hand. I will stop and answer you. There's no idea waiting for the end and then we are short of time and then we wait for dinner and cocktails and things like that. So we'll do it here itself. And the whole idea of this, my part of the talk, is to get you comfortable when you hold a DEXA report in your hands. Most doctors that I know pick up the report, look at the T-score, and then decide what next. I mean, after 25, 26 years of looking at DEXAs and bone patients, I'm still not very comfortable or confident what I'm going to do next. So please respect a DEXA report, spend some time. It's not like looking at a blood sugar or a lipid profile where even in my sleep, if you tell me HbA1c is 8.6, I know what to do. If it's 6.6, I know what to do. So just we will spend some time on that part. And then we will see what are the pitfalls and how to go about looking at things. So DEXA is dual energy X-ray absorptiometry, and it is written as DEXA and not DEXA. There's been some controversy on that. ISCD had some remarks, but for us, today it is DEXA, tomorrow it may change. And the simple thing is there used to be a single energy DEXA and now it's dual energy. So to make things simple, you have a hard structure and you have soft structure around it. So the low energy goes through the soft structure but can't go through the hard structure, and the high energy goes through both. And simple mathematical calculations, it gives you an idea what that hard structure calcium content is. This is a simplistic way of saying why DEXA. Traditionally, we have looked at spine, the lumbar spine, L1 to L4. We looked at the hip, total hip and the neck. We don't look at the Ward's triangle. So in that report, you will see somewhere Ward's triangle. Please ignore those numbers. Then you have the radius 1/3 and the radius ultradistal. As far as possible, if you have a good site, that is the spine or the hip, that's not been damaged, it doesn't have implants in it, don't look at the forearm. Don't look at the radius, don't look at the ultradistal, because it causes more confusion. And as you can see, bone is cortical and trabecular parts. The spine is predominantly a trabecular part, and the hip is predominantly a cortical part. But as I think one of my colleagues is going to talk to you about software and other developments, we'll see how you can make out which is cortical and which is trabecular. Can someone really tell me why this minus 2.5 is a sacrosanct figure? T less than minus 2.5 is osteoporosis, less than up to -1 is osteopenia, and less than, if you go above -1, it's normal. So this is the definition that was put up in the late 70s, and today in 2025 we still continue with the diagnosis of osteoporosis based on BMD scores. Yeah, so someone wants to tell me why this minus 2.5 came up? Okay, so I'll give you that answer in the next slide. The two terms that we use are the T-scores and the Z-scores, and they are generally written as capital T and capital Z and not as T and Z given below. You will notice there are three types of slides in my presentation. The ones which are like this light blue have been borrowed from the osteoporosis essential course of IOF. There's a set of slides which are borrowed from Nitin Kapoor, which I'll tell you when it comes, and there are some of my simple plain slides. So T-score is when you compare the person to a person of peak bone mass. So that's, we are looking at, so the databases of most machine makers is a white Caucasian 30-year-old or 28-year-old women. We have had this discussion time and again, and I'm very happy if some of my colleagues here tell me, why should we compare it to a young female? Why not to a young male? Or why not to a age matched male. So these things have been discussed time again. We have ICMR data, we've got some Indian data, but we pursue with a white Caucasian female. The probable answer that is the T-scores may vary. The BMD is what, the density is what decides the fracture risk. So that is why if you look at the Indian database, most of us are very healthy in terms of bone mass, but if you compare it with a white Caucasian race, then a large majority of us fall below normal. However, the risk is not based on T-score, but it is based on BMD, and so we continue using the female database as our base. And to compare ourselves to age and sex matched controls, so that's the Z-score. Does that make sense to the students? You can still think over it because I've got one more slide to that minus 2.5. So about the late 70s, 13 wise men got together in Geneva, sat down with the fracture risk data that was available at that time, and they came up with this cutoff value of minus 2.5. So the T-score was a standard score based on standard deviation from the mean for that population, for that machine. So there were different machines available, there were different technology that was being used for the collection of the mass determination. So that's why they standardized it to a T-score. And these wise men decided that based on whatever statistics they had seen, that if 30% risk, if we count as a fracture risk in a postmenopausal women. So most of the work on osteoporosis always starts with postmenopausal women and then goes to perimenopausal women and then last to men. So this was the fracture risk in 30% postmenopausal women. And when they looked at the data, they found that the risk in these postmenopausal women, lifetime risk is, if you look at the, based on the T-score and the actual fracture risk, it comes between 30 and 39%. So that's how, statistically speaking, this number minus 2.5 has continued. I always remember my professor, Dr. Bhandarkar, he used to say, there is lies, and then there are damned lies, and then there is statistics. So I know Lakshmi is an expert on meta-analysis, so she'll... Oh, Dr. Bhandarkar used to use stronger words. I can't use them here. So that's the part of why minus 2.5 has continued. We look at the report and we see the T-score and, okay, we look at the Z-score and then we decide, yeah, this is osteopenia, this is osteoporosis. So often the radiologist or whoever is reporting it writes osteoporosis at the lumbar spine, osteopenia at the hip, and severe osteoporosis at the forearm. Okay. The chain is as strong as the weakest link. So if you say osteoporosis, it is full stop. It is osteoporosis. You don't say normal at this pate and mildly osteopenic and all. And we don't like to use adjectives when we are using osteoporosis, generally. So we say osteoporosis. And the T-score is a way of standardizing or normalizing across machines. I don't know how many of you were students in the 70s and the 80s, but madam will remember that we had something like 30 criteria for diagnosis of diabetes. Because till a time when 75, 76 WHO came up with the standard criteria so that someone sitting in Mumbai could talk to someone sitting in Kochi and talk to someone sitting in Amsterdam or New York. So that was a standardization. So similarly, T-score gives you a standardization. Please remember, in case I forget, that when you follow up a patient, it's not the T-score. It should be done at the same center, preferably on the same machine with the same technician, and you compare the BMDs. And that's how you say 2%, 5%, 10% improvement or 2%, 3% worsening, not the T-values. And why not the Z-score? Because as you age and your peers age, the Z-score will remain the same or may actually improve. Short while ago, madam was telling me that her Z-score has improved fantastically over the last decade. And I keep referring to her because she is a role model for all the young ladies and young men out here. So you can't rely on Z-score. So Z-score becomes very important when you see the younger set of patients and you find that it is very low, then you need to look for secondary causes. And you measure both spine and hip and not only one. Does anyone know what is the cost, running cost of a BMD machine? I mean, buying the machine could be 50, 70, 90 lakhs or more. But what is the running cost of a machine? Next to nothing. A little electricity, cost of printing the report of 2-3 papers. But most centers would charge 1 part, 2 part, 3 part. That's nonsense because it's just not costing them anything, but they're trying to do that. So we insist on 2 parts because 1 part may be defective, have some implant, as I said, may have some compressions, can't work out, or somewhere down the line, when you want to compare and follow up that patient, there may be a problem there. So it's nice to have at least 2 parts. And the fracture prediction is dependent primarily on that part only. So the lumbar spine will predict spinal fractures and hip will predict the hip fracture. So that's the importance of doing at least 2 part. The last part of this initial introduction is on radiation exposure. So everyone is scared. DEXA. So this is X-ray. So that's a lot of radiation problems. Why do you keep advising it again and again? So you have, initially you had rads, and then you have 100th part of it is sieverts, and then you go down to microsieverts, that's 1,000 part. So a DEXA new machine gives an exposure of about 1 to 5 microsieverts, which is practically next to nothing. Whereas a QCT, it's about 100 to 600 microsieverts. It's a couple of X-ray chests that the patient is being exposed to. Peripheral QCT, I think only PGI Chandigarh has that, so we can avoid that. And what is the meaning of this microsieverts that I just talked about? So a natural background radiation over 24 hours is about 5 to 8 microsieverts, whereas a DEXA I said is 1 to 5 microsieverts. The annual exposure is about 2,400 microsieverts in a temperate zone. And if someone takes a transatlantic flight, so 6 to 8 hours, it's about 60 microsieverts. So to put it in perspective, that DEXA radiation exposure is next to nil. What are the indications for BMD? At my center, I come from a tertiary care hospital. Anyone who comes for a health checkup goes for a DEXA. I know so many unfortunate patients who, persons who had a DEXA done when they're 30 and 40 because they want to be absolutely sure they don't have an illness. And Dr. Bhandarkar used to say that a normal person who's not been investigated enough. If you go on investigating, definitely you'll find something abnormal. So please don't ask for DEXAs left, right, and center because they cause more problems than solutions. The NOF, the ASBMR, the NICE guidelines are looking at these indications, women aged 65 and older, a younger woman with issues like low body weight, prior fracture, high risk of medication use, which can lead to osteoporosis, or disease conditions which can lead to bone loss. The ISBMR, about 4 or 5 years, got together and the task force decided that since Indians get into trouble a decade earlier, whether it's heart disease, whether it's diabetes, whether it's diabetic complications, and since we are thinner and frail as compared to the Caucasians, we've brought these numbers down by a decade. So someone who's 55, you would think of doing a BMD, and not 35. And the same thing for men, it's 70 here, but probably it comes down by a decade. As a student, I was taught that men don't get osteoporosis, and if they do get osteoporosis, look for a secondary cause. Because the average life expectancy about 4 decades ago was less than 60. Very rarely would you see people who have retired from service and are around. Not like today when 1/3 of our population is retired and doesn't know what to do. So we are all living longer. We hope to live healthier. It's not just longer. And again, if there is an underlying problem in men, low body weight, prior fracture, on medications which can cause bone loss, or disease conditions which can be associated with bone loss, you would do it earlier. And this sort of summarizes what are the other conditions where you think about doing a DEXA scan much earlier. We are talking about DEXA as a tool to diagnose osteoporosis, but at least most of you would agree that it's not a very reliable tool. There are a lot of pitfalls, but what we can say confidently, it's the best tool available today. So take it or leave it. You would always wish for something better, but this is what you have today. So look at using this tool appropriately. There are other reasons for low BMD, and the commonest, like I was talking about, are corporate health checkups. 30-year-old, 40-year-old, backache, tired. It's not osteoporosis. This is someone from behind. Did you all get to have lunch, or like me, or without lunch? Yeah, so we need to talk about vitamin D deficiency, osteomalacia. Those are the much commoner reasons than osteoporosis or Cushing syndrome or thyrotoxicosis. I mean, these are all reasons, but think of common things first and you will be commonly right. So once you have decided to prescribe a DEXA scan or a DEXA report, one option is that you actually have a DEXA in your department or in your clinic and you go down and see how it is being done. Or when you get that report in your hand, you see something so that you know that it's been done properly. Don't look straight away at the T-score and the Z-score and decide what is happening. So the important thing to begin with is you need a nice, decent, quiet place. You don't need a huge place. The positioning of this patient is very important. You see that block below the legs? That is to tilt the pelvis in a way that the lumbar lordosis goes away. So the spine becomes straight. And how you know this has been done is when the report comes to you, you see the spine is central, the spinous process are central, and then you look at the box around it. That's called the region of interest, because all this is very important. And if there is a deformed spine, if there is a scoliosis, it becomes very difficult to interpret that scan. Something interesting in terms of little statistics, that most women, again I said, these are studies done on women, so I'm not saying only for women, but the study says that 83.5% of people would have 5 lumbar vertebrae, and the 12th rib is at T12. 7.5% may have only 4 lumbar vertebrae, so it's important to count 1, 2, 3, 4 properly. And 1.9% may have 6 lumbar vertebrae. So start with the rib so that you know that is T12 and then count downwards. And 7.2% may have 5 lumbar vertebrae, but the lowest rib may be on T11 and not on 12. So please look at that photograph. Very often it says photograph is not for interpretation or imaging, but actually it can give you a lot of information. Sometimes we see a scan, lumbar scan, which shows very good reports in an 80-year-old. So when it's too good to be true, it's not true. Look for other reasons, so you'll see other artifacts there. And I'm not going into the technology and how the DEXA bone density changes, but the important thing is that as the vertebrae increases from L1 to L2 to L3, the BMD goes on increasing. The difference should be not more than 1 standard deviation, or you know that there is something wrong. So it goes L1, L2, L3, as you can see, some idea. about 2-3% it goes in increasing, and then L4 is a little smaller than L3, so the BMD goes down there. So that's how most of these scans would look at, and you get confident about these numbers. So that the lumbar spine, generally the BMD is around 1 gram per centimeter square, 0.9, 0.96, 0.97, something like that. You'll get used to this. Okay, fine, let's leave that. I think more than the lumbar spine, the positioning of the hip is very important. So we are all scared of hip fractures. Lumbar compression fractures so often are just missed out. And it's only in retrospect that you pick up these fractures. But the hip fracture is very difficult to miss. I mean, and most of these patients will land up in hospital. So while you are talking of positioning of the hip, you have to keep the femur mildly internally rotated. So you have this support for the legs and there's a mild internal rotation. And this has come from autopsy studies when the femur has been placed flat on the table and then internally and externally rotated a few degrees at a time. And you can see how from a neutral position, a little internal rotation, and then if it's too much rotated, you can get a very high BMD. And the same thing happens with external rotation. So that's why I said it should be preferably at the same center with the same technician. I know that's a tall order, but at least if you look at the picture that comes to you, you see that the lesser trochanter is just about visible, and the region of interest should be, with the lunar it is at the neck, and with the hologic it's a little lower down, but should be away from the greater trochanter. So when you do finally get the DEXA report in your hand, be sure that you have the right patient's report. The demographics, the age has been entered correctly, because instead of 65 someone puts 55, or instead of 55 someone puts 65, the machine is going to interpret it differently. So the demographics is important. Look at the image, it gives you information, and then go on to the actual numerical values. The hologic printout gives you 3 zones for those who find it difficult. It's like green and yellow and red. So at least you know when the dot is in yellow or it's in green, it's okay, and when it's in red, there is something that you need to do more. So those who are interested, please walk up more, and those who are not interested, find someone in your neighborhood who will look at it. The lunar has, sorry this is not colored, but lunar has an orange band in between, which sort of gives you a intermediate sort of condition. So to sort of summarize this part, check the demographics, check that the patient has been positioned properly, look for artifacts. That's another very interesting part about DEXA reports. You know, people have coins left in their pocket. People may have yesterday's calcium tablet still not passed through the gut. So these artifacts are something you must look at. Lumbar compression fracture, laminectomy done. So suddenly there is a drop in the bone density, or suddenly there's an increase in bone density. You need to know that there is something that is happening. At this stage, any questions, comments? Okay. So we'll, yeah, sure. So they keep talking about this, whether you should be looking at the left or the right, or whether we take an average. I think since most scans give you left and right, if both are okay. So if there is one affected, then there is no question on it. A safer thing is either stick to left, or like the others who would say, no, take the lower one, whichever is it. When we are making it a diagnosis, we look at femoral neck and total hip. But when we are doing a monitoring follow-up, then it's the total hip that we follow. So it's just a day if you can miss out. Very often I don't even give that instruction, because I would say that they took it previous night, it has passed out. But I know some centers where they insist one day you should miss out. How many vertebrae should be taken for interpretation? Okay, so there are 4 lumbar vertebrae that we are seeing, L1 to L4, but we need at least 2 adjacent vertebrae to be intact and readable. So L1 and L4, L2 and L4 doesn't work. You need at least 2 adjacent vertebrae, otherwise you cannot interpret it. So, when we're talking in terms of glucose or we're talking of LDL cholesterol, there is a big movement that is possible in treatment. When we're talking of osteoporosis treatment, good old days, alendronate used to increase the bone mass by 1.5 to 2% per year. Today, teriparatide can do 6-7%, denosumab can do 6-8% per year, but it is 6-8%. Do you realize what is 6%? I mean, today if I, talk about glucose 6%, they'll say, oh, that is normal variation. I mean, that can happen with the best of labs. So you need to be sure. Oops, I seem to have run out of time. Okay, we need to go faster. So you need to be sure that there is a difference between what you are reading and what it was earlier. Is it a true change? And for that, we talk in terms of precision and accuracy. So you can make out this person is very accurate, but he is far from, his precision is very good, but he is far from the true value. Whereas this person is actually around it, so the precision may not be as good, but is still accurate. Let's skip this, but it's important to know the word precision, because the next thing that comes out is the least significant change. You are saying 3% change or 5%. Is that significant, or it's just by chance that that number is different? So LSC is something that is important, and it's 2.8 into precision. So we're going to skip this again. And this is the acceptable thing. So you can now understand when I say 1%, 2%, 3%, it's not enough to even cross LSC for most machines. And this is important because when you decide when to do the next BMD, I know people who do it every 6 months, who do it every 9 months. They have their other compulsions also. But as scientists, there has to be something called as a monitoring time interval, where you will find something useful when you do a scan. And that is something which you calculate by doing the least significant change and the percentage change that you expect with the treatment. So if something like romosozumab, where you expect 12 to 15%, you could be doing a BMD every 6 months also, and you'll get some reliable values. Teriparatide maybe every 9 to 12 months. Bisphosphonate every maybe 9 months, 12 months, but better it's 18 months. And that's the formula that you use, least significant change divided by the expected change. So if the least significant change is 4% and you expect a 4% change, then it's once in a year. If you expect 3% change, then it's once in 15 months, and so on and so forth. We have a talk on body composition, so I'm not going to go into details. Yeah, so these are Dr. Nitin Kapoor's slides, and we're going to see much more about how the body composition, and today it's become very important because of these weight loss therapies and how things are changing. So since we don't have too much time, let's skip this. And the last part, because when we talk about DEXA, and most endocrinologists would have access to a DEXA machine and not a QCT. I know in Mumbai there are only 2 QCT machines. And since we are not trained on QCT, I don't even find those reports reliable. More often than not, I think there are a nuisance, but there are some people who swear by QCT, because QCT technically gives you a volumetric analysis and it is better than a aerial DEXA. But it's expensive, availability is poor, and there's more radiation. But today with technology and improvements, earlier QCT used to be only for spine. Now you can do for the hip also. It's a reliable tool for fracture prediction and for monitoring now. So earlier on we had only for diagnosis, but you can do for monitoring also. So I think I'm going to leave you with this last slide on ultrasound. See, if you read about the technology, it's not bad. If you read about how it compares to central DEXA, it is not bad. The problem is how it is being done. Some pharma guy comes with that machine to a camp and just goes and does it. So the technique is good, the technologist is not good, and that's why it has gone into disrepute. See, it's easier to do a mass screening with an ultrasound than with a central DEXA or a peripheral QCT or anything. But you get more often in trouble because of the poor technology. So I think I'm going to stop at this stage. DEXA is a wonderful tool that we have today. It's not the absolutely reliable tool, but it's the best that we have. And with whatever facilities we have, if we work on using it properly, spending a few minutes on reading the machine, at times it's better to go to your technologist and talk to them what is being done, the position. See, simple things. Positioning is not proper. Get them to learn. I remember I was a part of a phase 3 study on Odenacatib with MSD about 3 decades or 2.5 decades ago. And my technicians took 6 months before they passed the sponsors' exams. So it's not something that someone comes in today and can start doing it. I'm going to stop at this stage and maybe we will take questions later on. Thank you very much.
Thank you, sir, for your nice elucidation. So any questions at this stage?
Yes.
Yeah.
Is it, sir, necessary to have least significant change for each machine? Or we take it as a standard, what you have mentioned, 3 to 4% at spinal?
You need LSC for each machine with each technician.
Exactly.
I think we can take one more only. We are just...
Yeah, take it. So we have many times where the scoliosis is there and at that thing. So what we should do then in that?
Oh, that's a very difficult thing for the technician, but he has to put the ROI, the region of interest box, in such a way that on both sides it's equally placed and matches the other. So they look at, see, we are looking only at the spine. You can look at the area of interest also and compare it on your report whether it's done properly or not.
The first time, sir, for the first time I'm saying.
Yeah, so first time you have to do the best way of positioning the spine. You've seen there's a marker which goes around the spine also. So that is something which is again very difficult when there is scoliosis. But that's the best you can do. Keep it in mind. It's not as reliable as a straight spine.
So again, thank you, Manoj sir, for the nice elucidation. So I think I can see people now need to stand there for listening here. So without wasting much time, I request Dr. Lakshmi Nagendra ma'am to come for the next talk. So she will be talking about the need of any others, the need of the FRAX tool in estimating the risk in the osteoporosis and any other screening tools that can overcome this. So it's absolute privilege to welcome Dr. Lakshmi ma'am, Associate Professor in JSS Medical College, Mysore, and having a lot of major achievements with Scientist Award, Yuva Ratna Award, and a lot more. So over to you, ma'am.
Thank you. Before I start, I'll ask the same question. How many of you don't have access to a DEXA machine at the place where you practice? Can we have a raise of hands? Okay, so that's very few, but how many of you have not been able to start treatment for a patient because that patient was not able to do a DEXA scan? Like, you know, there is a patient who has high risk of osteoporosis or who has had a fracture before and is not able to do a DEXA scan, and you know, that's why the patient could not be initiated on treatment. Have you had any patient like that? Okay, so only few. So let's talk about the available screening tools in osteoporosis and can it overcome the need for DEXA in clinical practice. So suppose I see a lot of residents here. So when you are in an academic institute, you have the best available instruments. But when you pass out and you are practicing at your own center, or you don't have the access to a DEXA, or your patient refuses or does not have the means to do a DEXA, then can you still treat the patient for osteoporosis is the question for the next 20 minutes. So when we look at the screening tools in osteoporosis, the most commonly used screening tool is FRAX. I'm sure that all of us have used this, but it's important to remember that FRAX can be used without BMD and also with BMD. So if you, I'll show you pictures, but if you enter clinical risk factors in the FRAX tool and do not enter the BMD, you still get a risk for major osteoporotic fracture and hip fracture. So we have the other tools, the OSTA, the ORI, SCORE, A-bone, and QUS. So these are less frequently used. FRAX is the most commonly used, I would say. So let's talk in detail about FRAX. What exactly is FRAX? So FRAX is a computer-based algorithm that calculates the 10-year probability of a major osteoporotic fracture and a hip fracture. And how was this derived? So this is the 2010 paper that you see. It was a joint official position of the International Society for Clinical Densitometry and the IOF on FRAX. So they sort of came together and looked at the clinical risk factors that were, more prevalent in patients with fragility fractures versus patients who do not have fragility fractures. So they identified a few clinical risk factors and came up with an algorithm. So if you open Google and type for FRAX India, this is the page that would come up, until 2 or 3 days ago. Now it's leading to a different site. It's a similar algorithm, but you have FRAX Plus also integrated into it. But this is a FRAX India tool. Very important to remember that when you are doing FRAX, there is country-specific FRAX, which is sort of, it takes into account country-specific statistics like mortality, incidence of fracture, which is country-specific, and ethnicity-specific. So always remember to, when you want to open the FRAX tool, you always have to search for FRAX India. And if you go into the FRAX site, the now new FRAX site, you can find the continents there, and then you can find Asia and then India. So always use the country-specific FRAX tool. So these are the risk factors that were identified by the FRAX team, and these are what they incorporated into the FRAX tool. And if you read each one of these carefully, so they will tell you when you have to consider secondary osteoporosis, for example. So this includes type 1 diabetes, or somebody who has osteogenesis imperfecta, or long-standing hyperthyroidism. So there are very specific conditions that you have to consider while using this tool. And also there is a guidance for glucocorticoids. For example, if your patient is exposed to oral glucocorticoids for more than 3 months at a dose of prednisolone of 5 mg daily or more, then you tick this as yes. So always very important to read, the footnote under these risk factors and how do you actually tick them as yes. So let's see this example. Here we have, used the FRAX India tool. So this is a 67-year-old patient whose weight is 55 kgs and height is 156 centimeter. And the machine that we use at our center is G Lunar. So you enter the BMD there and you get two values, which is the risk of 10-year risk of major osteoporotic fracture, which is 5.1%, and the 10-year risk of hip fracture, which is 1%. So how do you actually interpret this? How do you explain to the patient whether it is low risk, medium risk, or high risk? Can you start this patient on treatment? So let's explore these. So when you look at the current approach to osteoporosis treatment, this the NOF guidelines, which is now called the BHOF guidelines. So this came out in 2022. So the question when you're asking is, does the patient require any treatment for osteoporosis? So you're considering somebody has come to you, you're looking at whether this patient requires treatment for osteoporosis. So the first thing that you see is if the patient has had a fragility fracture. So if the patient has had a fragility fracture, then you have to initiate treatment for osteoporosis. There is no second thought about that. Every patient with a fragility fracture should get treatment for osteoporosis. So the second thing that you do is measure BMD. If your BMD is suggestive of osteoporosis, you again initiate the treatment for osteoporosis. But if your BMD is suggestive of osteopenia, then you do a FRAX score, which is FRAX for major osteoporotic fracture and hip fracture, and if it is more than 20% or 3%, you initiate treatment for osteoporosis. Now, how did this 20% and 3% come? Like, why are these set in stone? And, should everybody be using it? Can anybody answer how these, the golden guidelines that we follow of 20% and 3% as cutoffs for FRAX to initiate treatment, how did they come into place? Yeah, so it was based on economics. It was based on cost effectiveness study in the United States, and this was almost 15 years back. So this is not applicable in our country. So if you're using FRAX and if you're using these thresholds, then you're using something that is relevant in the USA about 15 years back, and that too, that was not like, fracture data or something like that. It was just a cost effectiveness study. So what does cost effectiveness mean? So at a particular threshold, if you treat patients for osteoporosis, is it cost effective to the country? So suppose in India, we want to treat patients for osteoporosis based on FRAX. We look at the thresholds at which it will be beneficial to treat, and it will also be cost effective. So the clinical benefits should be there, and there should also be cost effectiveness to the payer. So the payer can be the government. Most often we see the government. So if the government looks at how does the government bring up thresholds, how does the government decide to bring in some schemes. So they look at cost effectiveness study, and when they see that the clinical benefits are more at this threshold, then that is how they are implemented. So 20% and 3% in the United States and not relevant to us. So what are the limitations in this approach? So if you follow these guidelines, what is the limitation? So we know that the gold standard for the diagnosis of osteoporosis is the DEXA. We don't have recent statistics, but in 2013 there was a statistic that was published, and there were only about 250 DEXA machines in the country. Now we might have about 1,000, but this is still very less, comparing to the population that we have. So the availability is only 0.2 per 1 million population, where the ideal availability should be more than 11 per million is considered appropriate, and most of the scans are expensive. And when we look at the epidemiology of osteoporosis in India, 20% of the 230 million Indian women over the age of 50 have osteoporosis. So that's millions and millions who have osteoporosis. And can all of them undergo a DEXA? The answer is no, and that is how your screening tools come into play. And using a fixed T-score cutoff of -2.5 for treatment initiation has its own pitfalls. Manoj Chadha sir just told us how this T-score of -2.5 was derived. So that is also not set in stone. And if you look at the BMD of Indians, they are known to have lower BMD as compared to Caucasians. So when we do the T-score, this is in comparison with Caucasian young male or female, and this T-score was actually derived as an interventional threshold, which may not be applicable to Indians because you are already starting off with a lower BMD, and when you compare yourself to that of Caucasians, you can have higher prevalence of osteoporosis. So there are various studies, by ICMR and various other centers which have looked at using normative data in the DEXA machines, which is the Caucasian data, and using the ICMR normative data. And many people get reclassified if you use the normative data of Indians, and also T-score across all ages is not appropriate. For example, if you find a 50-year-old woman with a T-score of -2.5, then that is much more significant than the T-score of -2.5 in a 90-year-old woman. Because at 50, if your T-score is -2.5, then that is likely to be pathological rather than at 90. So age itself is a confounding factor. And FRAX cutoffs, like I said, of 20% and 3% are based on economic cost effectiveness in the United States. So this is something that we published about a couple of years back, FRAX-based osteoporosis treatment guidelines for resource-poor settings in India where you don't have access to the DEXA. So here we used data from our country, the BMI data from our country, the mortality data from our country to come up with these sort of thresholds. So these are the thresholds that we came up with. We have the lower assessment threshold, intervention threshold, and the upper assessment threshold. So these thresholds are derived from FRAX without input of the BMD. So these thresholds you can use even when you don't have BMD accessible. So these are the graphs that we came up with, easy to use graphs. So what does this mean? So if your patient comes in the green zone, if you plot the FRAX and it's in the green zone, it means that your patient is at a low risk of osteoporosis. Treatment is not required and BMD measurement is also not required. If your FRAX comes in the orange zone, it means that the patient is at intermediate risk. Here, the correct strategy would be to do a BMD measurement and then recalculate FRAX with BMD and see where it goes from there. But if your patient is in the red zone, it means that the patient is such a high risk for osteoporosis that you can start treatment even without BMD measurement. So how does this imply in your clinical practice? So for example, if you have a 70-year-old female who has a history of rheumatoid arthritis, she's on a tapering dose of steroids in 6 months, she's currently on prednisolone 5 mg, and she has attained menopause at 52 years. So if you enter all of these variables in the FRAX India tool, you get the FRAX percentages that you can see here, it's 19% and 11%. And then when I plot this in the graph, so 19% is in the red zone, 11% is also in the red zone. It means that, you know, your patient can be started on treatment for osteoporosis even without measuring a BMD. So is this valid? Can we trust this sort of risk stratification without doing a BMD measurement? So we wanted to validate these with BMD testing. So in all of the 300 patients at our center, we calculated FRAX without BMD first, and then BMD was measured and FRAX was recalculated. So BMD measurement was required only in 32.3% of these patients. That is, only 32.3% came in the orange zone. Fracture group was 18.7%. And then when we looked at treatment required with and without BMD measurement, based on the thresholds that I just showed you, only 2 out of 147 patients would have had change in treatment recommendations after BMD testing. So the intervention thresholds that I just showed you that were derived without BMD testing were valid in 98.7% of patients. So if you were to use this FRAX threshold, you would be right 98.7% of the time. After this, we wanted to study the cost effectiveness of these thresholds, because thresholds, like I said, in the US, UK, or Singapore, they're derived on cost effectiveness analysis. So we did the cost effective analysis for these thresholds in India. And the thresholds that we found that are cost effective are between age 50 to 64 years, we found that a threshold of 14% and 3.5% were cost effective. And above 65 years, the age-based thresholds were cost effective. So we recommend that if you're treating somebody in the age group of 50 to 64 years, you use 14% and 3.5%. And if it's somebody above 65 years, you can use the thresholds which are different at different age groups. For example, at 65 years, it's 12% and 4%. But at 90 years, you require a much higher threshold because age itself is a confounding factor, like I said. At 90 years, it would be 17% and 7.8%. So these are the thresholds that you can use in your clinical practice to treat patients with osteoporosis. Now, FRAX does not come without limitations. If you look at the limitations of FRAX, there are many. For example, variables like falls are excluded. It does not take into account dose-response relationship, for example, of glucocorticoids, the increased subsequent risk fracture. So somebody has had a fracture today, they are at a very high risk of fracture in the next 6 months. This is not taken into account. FRAX can only be used in untreated patients. It does not take into account for individuals who have a low lumbar T-spine BMD but have a normal femoral neck, but because when you input the BMD data into FRAX, it's the femoral neck BMD and you're not considering the lumbar spine BMD. Patient ascertainment of rheumatoid arthritis. So when I'm doing FRAX, when I ask patients that do you have rheumatoid arthritis, not many people are able to understand that. What do they understand by this? So that's a big limitation. Poor definition of secondary osteoporosis. So like I said, there are very few conditions which have been listed as causing secondary osteoporosis, but we know that there are so many other conditions that can cause secondary osteoporosis. For example, drugs, anti-epileptics, even proton pump inhibitors, all these have not been considered. Internet access is required. There can be variability in fracture rates, and country-specific thresholds are not derived in most countries. For example, many countries around the world have to use cutoffs of 20% and 3% because their country-specific thresholds are not derived. So FRAX Plus is something that is available now. It is better than FRAX. It does have some corrections. For example, you can see you can adjust based on these factors. For example, for duration of diabetes or according to recent falls. There's also adjusting for lumbar spine. So there are a few variables which are better now. But this is a paid software. You can do 5 calculations for free, after which it is paid, and therefore it's not very easily accessible to everybody as of today. But can you do adjustments to FRAX in diabetes? So we know diabetes is one major condition that we see every day, and these people are at a higher risk of fracture compared to non-diabetic individuals. Can you use FRAX in diabetes to calculate the FRAX score? So you can actually tick rheumatoid arthritis as yes, as a proxy for diabetes. This has been found to be useful. The other way to do it is if your patient is 65 years, you can increase the age by 10. So you can input as 75 instead of 65. So that's one way of adjusting to FRAX. So we studied this in a pilot study. We looked at the various corrections to FRAX, and we found that if you input the RA input to FRAX, if you use the RA input that I just showed you, you're going to be right 97.8% of the time again in diabetes. If you use the 10-year age increase, you're likely to be correct 90% of the time. So you can use FRAX even in diabetes as well with the correction of rheumatoid arthritis. Now, OSTA is something that is easily available and can be used. This is a formula to calculate OSTA. These are the sort of cutoffs that have been proposed in other countries, but there is Indian data that at a cutoff of -1 OSTA predicted femoral neck osteoporosis with a sensitivity and specificity of 88 and 42% respectively. Many other screening tools that I showed you have been studied. They range, the sensitivity ranges from 80% to 90%, but the specificity is low. Specificity ranges from around 30% to 60%. So we need to keep in mind the various sensitivities and specificities when we are using these screening tools. So the question was, the available screening tools in osteoporosis, can it overcome the need for DEXA in clinical practice? I would say yes, definitely, but there are certain cons of using these screening tools when you don't use DEXA. The biggest con would be monitoring. So if you have used FRAX score and started your patient on treatment for osteoporosis, how do you monitor response to treatment? How do you know that your treatment is working? But if you look at the clinical assessment of response to treatment, when do you say that your osteoporosis treatment is successful? So there are certain indicators that will tell you that your treatment is working. When T-score is less than or equal to -2.5, BMD increase should be at least 0.5 units. The T-score is more than that, there should be T-score increase of at least 1 unit, and there should be no recent fracture within the last 3 years. Failure is when there are 2 or more incident fractures when your patient is on treatment for osteoporosis, or if there is 1 fracture plus a significant decrease in BMD or a lack of appropriate change in the bone turnover markers, then that can also be considered as osteoporosis treatment failure. So considering this, if you've used FRAX and your patient has been started on treatment for osteoporosis, which is better than not, starting treatment or denying your patient treatment for osteoporosis just because they were not able to do a DEXA, you can look at clinically if there are no more incident fractures while your patient is on treatment for osteoporosis, then that can also tell you that your treatment has been successful without measuring the BMD. So in summary, FRAX without BMD is the most useful tool that can be used in your clinical practice. It has been validated in many studies, and FRAX without BMD is as good as FRAX with BMD, but there are certain pitfalls with FRAX that you need to be aware about. OSTA is another tool that has been studied. ORI score, A-bone, ultrasound are also available but not extensively studied. So when you're using FRAX without BMD, you should remember to use locally validated relevant cutoffs and not cutoffs that are blanket to all the countries and not certainly 20% and 3%. You have to do adjustments to FRAX in conditions such as diabetes. And if you do these adjustments, you're likely to be correct more than 90% of the time. So thank you one and all for your patient listening. If you have any questions, I'd be happy to take them now.
Thank you, ma'am. Thank you, ma'am, for your deliberation. So, invite questions from the audience, especially the residents.
Yeah. So if you can see in FRAX Plus, you have that provision to adjust for the dose of steroids, but in FRAX, that's a major limitation. You cannot adjust for it. Of course, you can actually probably try to do adjustments to FRAX in that as well, but that has not been studied as of now. Only adjustments in diabetes have been studied.
So the most important message which ma'am gave, that the DEXA we have or not, that obviously questions, certain conditions and all, but at least in our clinic, in our practice, regular screening of the osteoporosis by doing the FRAX calculation is one of the most important which we can do. All should do. So, any more queries? Yes, please.
What about, I know it's not recommended per se in the guidelines, but use of bone turnover markers? Like, can it be used as screening, not for monitoring, but for screening?
So for screening, bone turnover markers have no role in the diagnosis of osteoporosis. So their only role is in monitoring of treatment and not in diagnosis of osteoporosis.
Thank you.
So like I said, sir, if they don't have a fracture while on treatment, I think that would be a good enough indicator, which I always say is better than not starting that patient on treatment for osteoporosis.
Lakshmi, you said FRAX Plus, they charge you after 5 complementary. They charge only £2, so that's not much.
But I think, like, if you want to screen million patients with osteoporosis at the population level, at tertiary care centers, it's
at
okay.
The clinic level, it's
but if you're looking at population
yeah.
level screening, something that would benefit the population, I think we cannot still use FRAX Plus.
Yes, sir. Yes, sir. Last question.
Just a quick comment. It's good to have our own data cutoff points in relation to the cost effectiveness. Don't you think it's far too complicated? Who is going to remember all the different age-related cutoffs for the major osteoporotic fracture risk? Can't we make it simpler? Something closer, which will not be perfect according to your studies, but still would suffice for most of the population. I mean, that sort of pragmatism should also be there, I feel.
Correct, sir. So in our paper, we also wrote that 14% and 3.5 are valid across all populations. But if you're looking at more sensitive cutoffs, which are cost effective, even 14 and 3.5% are cost effective, starting from 50 to 65, and they can be actually used. But what we were thinking of, we have now FRAX tools, and when you enter the FRAX and your FRAX, you get the calculation, the FRAX tool itself can tell you whether this patient is above the threshold. So many countries have that algorithm now, and I think that would be very useful if we can do it when they do the FRAX, and there itself the recommendation comes out that what is the best thing to do for the patient.
So I think it's with the session. Thank you, ma'am. Thank you for your deliberations. So moving on to next, I'll need to introduce Dr. Khushbu Agrawal, Assistant Professor in Christian Medical College, Vellore, a member of the Obesity Task Force in Endocrine Society of India, and having a keen interest on obesity and bone health, winner of the multiple laureals. So most importantly, she will talk us about the trabecular bone score and the vertebral fracture assessment, which is the most, which Manoj sir already highlighted. The DEXA machine is not limited to only bone mineral density assessment. It's many more. And in this workshop, we are trying to highlight, along with DEXA, what we can get knowledge from doing a DEXA scan for a patient. So for this, Dr. Khushbu will tell us. Over to you, Dr. Khushbu.
Thank you, Dr. Shinjan, for such a kind welcome. At the outset, I would like to thank the organizers for inviting me as a part of such an important workshop. And in the next half an hour, we'll be talking about two major aspects of bone mineral density, trabecular bone score and vertebral fracture assessment.
Just a request to maybe keep it within 20 to 25 minutes.
Yes.
Just we are running a bit late.
Yes.
Thank you.
So this part has already been covered by Manoj sir and Lakshmi ma'am. It's an under-recognized problem in India, and its prevalence is rising due to increased life expectancy. These are the various studies that have been done across our country at various points in time, and you can see that frankly the prevalence of osteoporosis is very, very alarming. However, the prevalence ranges from 30 to 60%, and it's actually very high, 150 per 1 lakh people. What is the problem, however, is that that doesn't account for fractures, because more than 50% of the fractures actually happen in osteoporotic range. Now, we are all talking of T-score and FRAX, and we are potentially missing out on half of our population who may be at risk for fractures. So what are this is a quick recap of what Sir has talked about. So we see T-score in people who are above 50 and who are postmenopausal, and Z-score is used in patients with secondary osteoporosis and people who are women who are premenopausal and men who are less than 50 years of age. Ideally, it is done in 2 sides, femoral neck and lumbar spine, and distal third of arm. This is a typical DEXA report from our center, and we calculate the T-score as well as the Z-score, and we also have FRAX incorporated in the report itself, so we don't have to actually bother to calculate. So you can see that differential T-scores can be given about this. However, this is not perfect. As already mentioned, that it's an approximation for the density. It's not an actual density. It looks at the cross section of the bone. So anybody who is very short, anybody who is having small bones is going to have false negative reports, A, first of all. B, there is no information on the bone microarchitecture, and certain cohorts, as the main population patient population of ours, diabetes, they are prone to fracture at a BMD that is higher than normal. So it's very, very important that we look at other aspects. So what is trabecular bone score? It is the pixelated version of the lumbar spine, and it's calculated with the software. So it looks at the microarchitecture over here, and it looks at the logs of the bone and calculates the log and gives us the trabecular bone score based on that. So these are the normal cutoffs for our population. More than 1.35 is considered normal, and less than 1.2 is degraded. Between 1 to 1.35 is partially degraded. It's recommended in the BMI of 15 to 37 kilogram per meter square. I'll be coming to that part, and it can be confounded by the soft tissue thickness. Various other ranges are also given. So this is what I was talking about. So this is a lady who has apparently normal T-scores, and she's having back pain, and which may be missed. So when we went back and looked at the trabecular bone score, we found that the trabecular bone score was very low, and this actually tells that a study of microarchitecture is very important. Few technical aspects of the trabecular bone score. It can be adjusted according to the BMD. It looks like a complicated formula. Basically, 63.5 is the mean age that is taken, and you need to calculate the mean centric age, and you need to calculate the age normalized TBS, which is TBS minus 1.32, and coefficient of that is taken. So for example, a 59-year-old female who has a T-score of minus 1.2 and a TBS of 1.158, TBS adjusted T-score will be minus 1.9. So it's very, very important. So the million-dollar question, when should it be done? So these are the indications that are given by the ISCD 2019 statement, and if there is an intermediate risk of fracture according to the FRAX. In people who are above 65 and above 70, it should be a part of routine evaluation. In less than 65 and less than 70 years of men, it should be, if you have another risk factor like a low bone mass, or you have a secondary osteoporosis, or you have low body weight, then it should be done. Then of course, anybody with a fragility fracture, anybody with a condition that is associated with secondary osteoporosis, any medication that is resulting in low bone mass or osteomalacia, to monitor treatment, we'll come to that part, it can be used. And if they are not receiving treatment, but if there's an evidence of bone fragility, that will actually amount to treatment. So this is very, very important. So it's the fracture trabecular bone score predicts the fracture risk in both major osteoporotic fracture and hip fracture. And it has been proven in multiple studies. However, surprisingly, addition of TBS doesn't really improve FRAX for the fracture risk assessment. This is very, very important, and this has been studied in our cohort as well. You can see that the area under curve for FRAX plus BMD and addition of TBS doesn't really help much, but still it has a role. So where does that role come? Its role is actually when the your FRAX assessment score is very, very close to the treatment threshold. You're not able to decide whether or to treat. Ma'am just said that 14% and 3.5%. What are you going to do for 13%? Okay, so in that case, addition of TBS can actually push the patient inside the treatment initiation group, and that actually changes the treatment. Of course, there are other aspects as well. Patient stratification also changes, and we have enough data for that. This is one of the biggest cohorts, Manibota cohort, and what it showed was that it changes the FRAX probability in the people who are very, very close to the threshold, and benefit is more for people who are less than 65 years of age. It has been proven in other cohorts as well. This has been done, and you can see that in people with glucocorticoid use, and NRI is risk intervention threshold, and what we see is in people who are less than 65 and in people who are on glucocorticoid use, it changes very, very important, and the changes is also seen in people with diabetes, with COPD, with prior fractures, rheumatoid arthritis, and higher comorbidity score. In addition to that, we also see that addition of TBS changed the FRAX in multiple other cohorts as well. So again, like any other scan, what are the technical issues with the trabecular bone score? This is a very, very important cohort, and what it showed was in people who are 20 to 39 years of age, TBS is actually useless. It's a very, very important finding, and in that it showed that the standard deviation and the increased risk of fracture was associated with BMD itself rather than TBS. So ISCD 2023 position actually recommends not to do TBS in this cohort. This is a very important finding. What about, there's a whole lot of talk about Indians and Asians, and what about should it be done, should it not be done? So unfortunately on that part, the data is not very clear. There are some studies that have seen the trabecular bone score in various populations. This is one study. What it showed was that the African American men and women both have got better bone mineral density, but they have for some reason got a worse trabecular bone score. This, however, doesn't really translate into fragility fractures. Okay, there are other studies that have been done in Japan. There are multiple studies that have been done in USA, and they have shown conflicting results. As of now, there is no recommendation to use any race or ethnicity specific cutoffs. So as of now, there are no. Another main problem is that we have BMI becomes a major cutoff. It's a scan, and because it is going to be affected by the soft tissue density, this is a very wonderful study, and what it showed was that it is more impacted in the hologic, it is more impacted in the lunar densitometers rather than the hologic densitometers. However, the newer machines are not showing the same. What about the vertebral bodies? Is there any structural changes or artifacts that need to be excluded? So what they really say is that if there are severe structural anomalies, there is a surgical intervention that has been done, or there are metastatic lesions. In these cases, TBS should not be used. So one of the most important uses of trabecular bone score is secondary osteoporosis, and it has a wide variety of diseases, right from endocrine diseases, gynecology, rheumatology, oncology, CKD, geriatrics, and many other conditions. So this is a very, very interesting study from our center, and what we showed was that while the BMD is supposedly better, the trabecular bone score showed a very wide difference in people with morbidly obese individuals. And it is better than predicting fragility fractures than BMD. And what about diabetes mellitus? Yes, of course, diabetes mellitus has got a false high BMD because of advanced glycosylation end products, and that causes problems. Also, of course, there are other problems with diabetes like sarcopenia and increased propensity to fall neuropathy. So there's a low intervention threshold. And what is interesting is that while BMD may be high, what we have shown is that TBS is actually low. So it's very, very interesting to see that. And it highlights the importance of TBS in this population. Similarly, it has also been studied in various other populations. It has been proven in meta-analysis across type 1 and type 2. However, what we see is that propensity for fractures in type 1 diabetes is not completely explained by poor TBS. So I think more studies are required in this cohort. There is one study which has shown that it has got poor correlation with the peripheral QCT. Again, these children have small bones, so we need to understand better. This is very, very interesting to see that, and this is why it is important. In people with breast cancer who are on aromatase inhibitors, baseline BMD is the standard protocol, and we have to follow them up for osteoporosis treatment. And this was a very interesting study, and they looked at the TBS, they looked at the peripheral QCT, and they also looked at the bone mineral density. And what they found was that the QCT and TBS actually showed changes across time, and BMD did not really show that much changes. It also decreased over time, but the changes were a lot more with trabecular bone score. So probably it's a better and a more sensitive marker to assess the changes in the bone. Again, glucocorticoid induced osteoporosis. I'm so sorry. Yeah, sorry. So again, in the glucocorticoid-induced osteoporosis, TBS is very, very impactful, and it is more sensitive than the lumbar BMD to comment on the osteoporosis. It is also other endocrine diseases are also very important, as we have just discussed that it is looking at the cross section of the bone. So any disease which is going to have a small or a wide bone is going to be impacted. So people with growth hormone deficiency, people with acromegaly, people with primary hyperparathyroidism, people with Cushing's disease, people with hyperthyroidism, people with hypothyroidism, metastatic thyroid carcinoma. TBS has been proven important in all of these diseases at various points in times. So to conclude this part of the study, it is predicts fracture risk in type 2 diabetes, CKD in multiple rheumatological diseases independent of BMD. It can be used in glucocorticoid and aromatase inhibitors, and it is mainly unaffected by osteophytes and syndesmophytes. So what about the million-dollar question? Can it be used to monitor treatment? So no. It is potentially amenable. Obviously, any treatment that you give is going to have an impact on denosumab. And what we saw was, this was a study from our center, and what we saw that yearly zoledronic infusion there was an improvement in the BMD, but TBS did not really show any change. So, and it has been shown in various other anti-resorptive treatments as well. This was a 3-year study with zoledronic acid, and while there was an improvement in the trabecular bone score, it remained below the least significant change. So how relevant it is, we don't know. Again, the similar study with denosumab also showed the same change. So as of now, there is no recommendation to follow the treatment of anti-resorptive therapy with TBS. What about anabolic therapy? So anabolic therapy has shown definite improvement. Both teriparatide and abaloparatide have shown improvement in trabecular bone score. Again, the problem is that 80% of the people who showed improvement in the bone mineral density did not show an improvement in the trabecular bone score. So while there is an improvement in the trabecular bone score, it cannot be a goal to decide the treatment. So it can be used as an addition as of now. So this is what we were talking about. This is something that even Lakshmi ma'am had shown. So this is here is where the importance of trabecular bone score is. Addition of trabecular bone score actually changes the yellow bar to orange, and there is these are the people who will actually fall under the interventional threshold and will actually require treatment. And again, what are the treatments that you can give? You can for high risk you can consider anti-resorptive therapies. For very high risk, we should traditionally consider anabolic therapy followed by an anti-resorptive therapy. So what is the actual importance of, is it actually of any use? So yes, it has got multiple use. It is independently predictive of hereditary fractures in postmenopausal women, and it adds to the FRAX when, and it can be, when FRAX is not available, BMD adjusted TBS can actually be used. And the most usefulness of TBS actually lies in the patients where your FRAX or your T-score is very, very close to the intervention threshold. And there is a role for monitoring treatment, but further studies are required. Like any other scan, it is not perfect. So it is developed only for lumbar spine. So microarchitecture can be degraded at other places as well. It cannot be used beyond the BMI cutoffs. Can be potentially altered by vascular calcification. And if there is a water content of the soft tissue like ascites and all, can probably interfere with TBS. Coming to the vertebral fracture assessment, this was a 73-year-old female. She came with low backache. Again, she had a BMD that was in the osteopenic range. Because of a backache, we did an X-ray and we found that she had multiple fractures, and which were missed by the BMD. And this is where we did the vertebral fracture assessment, and we found that she had fractures in almost all her vertebra. And so what is vertebral fracture assessment? It is objective assessment of the vertebral fractures, and it can, the main advantage is A, it has got low radiation, B, it can be done at the same time as the bone mineral density. So this is an X-ray that shows mild, moderate and severe fracture, and this grading is given by Janan way back in 1993. So I want you to carefully look at the mild, moderate and severe deformities. These are very, very objective categorizations. So we have mild deformity in which there is 20 to 25 reduction in the anterior or posterior height, and the moderate we have 25 to 40, and severely is more than 40. So as you can see, it is probably very, very easy to misclassify mild deformities. So what are the indications of vertebral fracture assessment? So as doctors, we like to argue a lot, and various societies have come with various guidelines. But to summarize, everybody agrees if that you have a height loss of more than 4 centimeter, if your patient has kyphosis, if he is on long-term glucocorticoid use, if your T-score is less than -2.5, and if there is a history of non-vertebral fracture that has been picked up. So these patients should definitely undergo. And T-score cutoffs, various guidelines, they disagree, but by and large, in people above 70 years of age, if your T-score is less than -1, then vertebral fracture assessment shouldn't be done. It may not be enough if you have fractures that cannot be identified. If you have an extra vertebra between T7 to L4, again, it is not a good investigation. And if you have a sclerotic or a lytic lesions that may suggest a malignancy, then vertebral fracture assessment should be avoided. The question is it as good as an X-ray? No. X-ray is definitely better for vertebral fracture assessment. It is considered a gold standard for identifying the vertebral fractures. And when you compare vertebral X-ray to the VFA by DEXA, the sensitivity is 75% and specificity is 86.6%. It's not that simple. It's definitely a lot better in the lumbar area. It is definitely a lot more sensitive in the grade 2 and grade 3 fractures. In the thoracic vertebra and in grade 1 fractures, vertebral fracture assessment is probably not that great. So it is very important to identify that part. So that these limitations have now been improved by the improved vertebral fracture scanner that is now available as a part of our software. And what have they shown is you can look at the, compared to the previous scan, the sensitivity to pick up thoracic fractures is much better in this population, and there is excellent per vertebra and per patient sensitivity and specificity for both. So when are you going to bother? So if X-ray is better, then why should I bother with a vertebral fracture assessment? Okay, so this is a very excellent study that looked at the cost effectiveness of vertebral fracture assessment, and what they found was that the best cost effective method to go about is to do a BMD, get a VFA, and if you feel like there's a fracture, then you get an X-ray done. That actually improves the identification of vertebral fractures, and it improves the screening and it improves the identification. The problem is that X-rays have got high radiation. Okay, so how often are you going to do them? And this is where the importance of a VFA is there, because these people are old, most likely. They're not going to come to you again and again. It's very easy to get a VFA done in the same visit, in the same scan, in the same position, rather than sending him for an X-ray at a different place and a BMD at a different place. Clinical application, very, very important. They prevalent vertebral fractures predict future fractures. They also predict mortality. They predict poor quality of life. The main important problem is that they are not recognized clinically. They come with non-specific complaints of back pain, and more often than not, they're likely to be ignored. That's very, very important. They have less radiation than a standard spine X-ray, and it can be done in the same sitting. So that's why it's very, very important. To conclude, TBS is associated with hip and major osteoporotic risk fracture in postmenopausal women. It's a marker of bone architecture, microarchitecture, and it can be used with FRAX and BMD to improve the fragility fracture risk prediction. And VFA picks up fracture which may not be clinically evident, and the management actually impacts the quality of life and mortality. Thank you.
Thank you, Dr. Khushbu, for a very nice talk. So first, I think just before questioning, I just want to ask the residents that how many you have seen a TBS report or a vertebral fracture assessment? A vertebral fracture assessment report in your clinical practice. So you can raise your hands. How many of you have seen a report of TBS or a VFA? Because the most important advantage is that it's an added software with the same DEXA machine. At the same time, when the patient is undergoing DEXA, we can get the additional informations. So that is the real advantage of that, and we are most importantly about the diseases, the endocrinological diseases, about the type 2 diabetes. Dr. Khushbu has shown a lot of literatures have come in the other endocrine diseases, the thyroid diseases, acromegaly as well, where the BMD can be normal, but they can be of a higher, yes, can have a poor TBS, which can indicates there is more increased fracture risk. So any questions? Yes, ma'am.
So why does the TBS not improve with treatment? That is the question I was asking.
No, TBS actually improves. It is improving both with anti-resorptive therapy and with anabolic therapy. The problem is the change is less than the least significant change calculated for the BMD, because it will take time. Because, for example, if you're giving any treatment, you're going to follow the patient yearly, right? And that's where you see. So the least significant change for TBS that is calculated at various places is actually 52%. Okay, so that amount of change doesn't happen. There is definite improvement. Yes, so you really cannot base your decision on that, whether your treatment is successful or not. That's the problem. There is definite improvement even in anabolic therapy. There's definitely very nice improvement. Even in anti-resorptive therapy, various studies have shown, I did not show all the studies, some studies have shown improvement, some studies have shown questionable results. The problem is that you have better monitoring with the BMD and the bone turnover markers. So it is not good for monitoring as of now.
I think for the monitoring purpose, we need to have more researchers
Yes.
for the TBS. For the BMD and all, we still have good evidence. I mean, for
Yes.
the BMD, obviously, that's a standard evidence, but I think TBS, we need to do more researchers, and specifically from our country. So any more questions? Yes, please.
Ma'am, my question is regarding interpretation of TBS reports. Ma'am, with which value we should term the vertebra as degraded, mild, moderate, or severe? And another question, if we look at an TBS report, we get a value for individual vertebrae, and also we get an average value, like for L2, L3 and all. So what result should we take to characterize the vertebra as degraded or not?
The cutoffs are clearly defined. We have TBS more than 1.3, that is normal, and less than 1.2 is considered degraded, and between that is partially degraded. So you can, for the individual vertebra, it's not like what we usually follow is we look at the composite L1 to L4 trabecular bone score value. However, if one vertebra is out disproportionately very less, usually they are in the same range, maybe a little less or maybe a little more, but if one vertebra is disproportionately very less, then I would actually advise getting an additional imaging done, ki what is wrong with that vertebra before proceeding to any kind of treatment.
Ideal.
I think which value to take, I think you are questioning. I think in the TBS there is a lot of values of L1, L2.
L1 to L, this one.
So L1 to
okay, ma'am.
This L1 to L, where is this? This is the value that you should take. This is the value that on average you can take.
Yes, so there we have a value of the L1 to L4 as well. No? That's 1.157. So that gives the average of all the 4 vertebrae which we can use. So I think we should move to the next session. The next part. So obviously, as we are discussing, again, thank you to Dr. Khushbu. So again, we are discussing more advanced assessment of the DEXA, and apart from the BMD, which we can see. And most important aspect of doing all these things is to prevent the fractures, to prevent the fragility fractures. So we can understand BMD does not give us the exact value that it has an increased fracture risk or not. Specifically, in various endocrine diseases, diabetes is one of the commonest. To know more on this, some other parameters like hip structural analysis or bucking ratio, or the bone strain index that we need to understand. For that, I would like to call upon Dr. Anshita Agarwal, ma'am. Ma'am is Associate Professor in Aviva EMS and Dr. RML Hospital, Delhi. Ma'am has a special keen interest on the metabolic bone diseases and have lot of publications related to bone mineral health. So over to you, ma'am.
Thank you, Dr. Shinjan. A very good afternoon to the gathering here. So as the previous speakers have already reiterated, I think now we are very clear that BMD alone is insufficient to fully capture fracture risk. Why is it so? Because it is not just the bone quantity that defines fracture risk, it is also the bone quality, which Dr. Khushbu very elegantly described how it is picked up by the TBS. But one aspect of bone strength which probably has not been captured by any of the available tests, including BMD till now, is the bone geometry. I can't see my slides. So actually what we'll be discussing today will be more of geometry, so please bear with me. It's a new concept, it's an upcoming concept, and it is still long before it has more of clinical utility, but we do have data showing how it can add on to BMD or to TBS and can improve fracture prediction risks, and ultimately can also be helpful in monitoring response to therapy. Yeah, apologize. So when we talk about hip geometry, what do we exactly mean? How the bone is structured, and more importantly, yeah, the slides have come, thank you. So this is just an analogy. If we were to compare the bone to a building has various factors which defines its strength. the quantity of the material used, the quality of the material used, but also what is the kind of architecture and what is its capability to bear external loads that are put on that structure or building. So, if we were to compare this to our bone, the quantity of material used is seen by BMD via DEXA. The quality of the material used is seen via TBS. But what we are not seeing till now is the architecture and the ability to resist external loads. So this has been taken care of by the hip structural analysis. So what is this hip structural analysis? It is a software, just like TBS is a software which can be incorporated, and the same DEXA machine can be used to do the TBS. Similarly, hip structural analysis can also be Similarly, the hip structural analysis can also be used in the same DEXA scan, and we can get a report of HSA just like we get that out of a TBS. So the HSA program was developed and conceptualized in the Johns Hopkins University. Thank you. And so it uses proximal femur DEXA image, and it uses it to extract information about cross-sectional geometry in 3 different regions of interests. The narrowest portion of the femoral neck, which is known as NN, intertrochanteric region, that is the area between the greater and the lesser trochanter, and the femoral shaft region, which is 1.5 centimeters distal to the lesser trochanter. And for each of these locations, the distribution of bone mass is computed, and the mechanical properties are derived from femoral geometry. So this is the pictorial representation of the 3 areas that I was talking about: the narrow neck, the intertrochanteric area, and the femoral shaft. So there are various indices, geometrical indices, that the hip structural analysis software provides to us with respect to this. It is a post-processing tool. That means you run a DEXA scan, and after that the software applies these principles of geometry upon this and algorithmically extracts geometrical information. So this, back as 2006, it has received clearance from the US FDA to incorporate it into the DEXA systems. There are various components of the hip structural analysis. So these are the various components that we see in the hip structural analysis. There are many, as you can see, but primarily the more points of interest for are the cross-sectional area, which is self-explanatory. If we were to imagine to cut the femur, so the circular structure, that is the cross-sectional area, right? So that is the bone surface in the cross-section. The other parameter that it tells us is something known as the cross-sectional moment of inertia. That basically tells us how the bone mass is distributed around the axis. And there is another entity derived from the CSMI that is known as the section modulus. That tells us how much of the bending stress the femur can tolerate. So this represents the bone's resistance to axial load and bending stresses. What are these loads and stresses that we are talking about? If we were to see this femur, it is always acted upon by a weight which is the body weight of the person, which has a compressive force going downwards. As a reaction to this compressive force, there is also a force by the floor that is acted upon upwards. This force is known as the axial force. And it is quite interesting to note that the femur can tolerate axial stress more than 30 times of our body weight, which obviously we generally do not experience. But since it is one of the strongest, it is the strongest bone in the body. So that is the axial force that it is applied. But if you were to see the femur, it is not an entirely straight structure, right? The neck shaft area is angled. Because of this, it does not only have axial force acting upon it, but also torsional force, because it is not a straight entity. So that torsional force is seen as the tension on the lateral side of the shaft. So basically it has the axial force acting upon it and also a bending force acting upon it. So if you were to see these fibers in the femur, in the proximal part of the femur, if you were to see these green fibers, so this represents the primary tension group. These are the fibers which will tolerate the tensile, which will have the tensile forces acting upon it, right? And if you were to see these inferior red fibers, these are the fibers that will tolerate the compressive forces. Here also in this image we can see the tensile fibers, and the compressive fibers. So these are the forces that are acted upon by the on the femur. We know, and why it is happening, because of the neck shaft angle, which is large at 125 degrees. So that is why the forces are not straight. So the femur neck actually behaves like a beam, a cantilever beam, with bending forces, with axial forces. But how these forces impact the fracture risk, that is not captured by a usual BMD or a TBS, and that is what HSA wants to do. So whenever there is a bending force, so the superior part of the femoral neck will have tensile forces acting upon it, which will try to stretch and pull it apart. So with the loss of trabecula here in this area increases the risk of fractures because of loss of these fibers and loss of bearing this tensile forces. The inferior part is more under compressive or crushing forces, forces which are trying to push it together of our body weight and that of the floor. So now coming back to the parameters which we see in the HSA, the cross-sectional area, it is the area, so it will be expressed in centimeters square. It is the area in a plane perpendicular to its length, that is self-explanatory, and it is seen at the 3 sites that we had talked about, and it tells us what is our strength or ability to bear axial or compressive load that is put upon the femur. More the cross-sectional area, more is the strength of the femoral neck, and less likely it is to fracture with normal load. And what is important for us to note is that 2 patients might have similar BMD, but at the same time, they can have different cross-sectional areas, and because of that, they can have different fracture risks. The second important parameter that we talked about was the cross-sectional moment of inertia, which is expressed in centimeter raised to the power 4. It is again a geometric property. This tells us about the distribution of material around the central axis. Sorry. And it is a key determinant of a structure's resistance to bending. So cross-sectional area, CSA was telling about how they bear the axial force, and CSMI tells us how it bears bending force. More the CSMI, that means the bore is more robust, so it can handle bending forces better. To put it lucidly, if there were 2 bones which had the same amount of bone material, but the distribution was different such that one had a wider cross-section, that means the mass was distributed more farther away from the central axis. So it will have a higher CSMI, and thus it will be stronger against bending forces. This is the formula. However, it is a very simplified formula. It is not that the HSA software uses this formula per se. It is a derived parameter, because the cross-sectional area for a femur will not be a smooth or regular cross-section, unlike for what this formula is meant. Sorry. There's another entity known as the section modulus that is also derived from the CSMI. It is basically CSMI divided by C. C is the outermost point of the cross-section, which is, in case of bone, is the subperiosteal surface. More the section modulus, again more is the resistance to bending stress without failing. Coming to the next parameter. So we have talked about cross-sectional area, CSMI and section modulus. More they are, more is the strength to bear axial forces and bending forces respectively, and less likely the bone is to fracture. What about the buckling ratio? It's another parameter which is provided by the HSA software. It is the ratio of the femur's outer radius to its cortical thickness. This is an indicator of structural instability. More the BR, more is the susceptibility to buckling. What is buckling? Buckling is sudden collapse of a structure when it is subjected to a compressive force. For example, if we were to imagine a hollow pipe, the thinner the wall of the pipe, more is the propensity to buckle or collapse, especially if it has a higher radius. Similarly, if we were to imagine a paper straw, a plastic straw, compared to a steel straw, since it has the former one, it has a thinner wall, it is of course more likely to buckle or collapse. So to put it simply, this is the buckling ratio. And why does this occur? I mean, why does a change in the buckling ratio can occur? Because with age and as a compensatory response, there is a remodeling process wherein the bone mass is redistributed in order to maintain bending strength, right? So if it is redistributed more towards the periphery, such that the radius is more, but the cortical thickness is reduced. That means the BR will be high. So higher BR is a worse parameter in terms of fracture risk. If the BR is less than 10, it signifies good structural stability. Once it starts rising, it means that the risk of collapse or buckling or fracture, that is a fragility fracture, is increasing. This would have utility in patients who do not yet meet BMD thresholds for osteoporosis, but we want to identify fracture risk. In fact, that will be true for all the HSA parameters. However, it is yet in an early stage for us to use it in place of the BMD. At best, it can add on to what the BMD information we get. So just to give you an idea, this is how a HSA report looks like. Just when you run a DEXA scan, right, you will get BMD, and if you have TBS software, you will get TBS values. Similarly, if you also have the HSA software incorporated in your DEXA machine, you will also get this kind of a report. We talked about 3 ROIs, right? So those ROIs are mentioned here: narrow neck, intertrochanteric area, and femoral shaft. They've mentioned the CSA, that is the cross-sectional area, the cross-sectional area, the CSMI, the section modulus, and the cortical thickness and the buckling ratio. So these are the parameters that you will get if you do a HSA. Now, what evidence do we have to say that HSA actually tells us truly about the geometry of the bone? There have been studies wherein the HSA has been compared to volumetric QCT, although smaller studies are there. The HSA in these studies in 121 women correlated well with the QCT for neck, BMD, and standard DEXA at the neck. So the correlation with QCT has been good, but these are smaller studies. And for any parameter that we do, it is important for us to know how it predicts fracture risk. Only then it will be helpful for us clinically. So we have enough data now in large cohorts of postmenopausal women. So in this study, with 7,000 women who had hip fractures over 13 years, various hip structural analysis parameters were seen, and it was seen a higher buckling ratio along with lower CSA, CSMI, and BMD significantly predicted fracture risk. The buckling ratio and cortical thickness predicted hip fracture risk as effectively as BMD, while section modulus was less effective. Probably this means that we know that section modulus tells us how they resist the bending forces. So what they concluded that probably that when we fracture, it is not just simply failure in resistance to bending, but there's more role of compressive forces probably. So that, and this requires initiation, but some kind of local crushing or buckling. That is why probably the section modulus could not predict fracture risk as effectively. In a study of 10,000 postmenopausal women who were followed up for 11 years, it was seen that the intertrochanteric and shaft buckling ratio and the outer diameter were independent predictors of hip fracture, even after adjustments for other parameters such as age, body size, FRAX, and BMD was done. Generally, the buckling ratio is seen to be a better parameter in terms of predicting fracture risk in patients. Am I audible now? There's some issue. We have data from India as well. Thank you. In a South Indian study from Vellore, HSA parameters were seen pre and post 24 months of teriparatide therapy. So there are studies that have seen response to therapy also with respect to the HSA parameters. It was seen that significant improvement in the HSA parameters was seen at the intertrochanteric area and the femoral shaft. At the narrow neck, only the buckling ratio showed improvement. And we have other data also from, we have studies from Iran, although they are smaller studies, wherein they have studied whether after oral bisphosphonate or denosumab there was a change in HSA parameters. So far, most of the studies are promising, but we need more data for us to be able to confidently say that HSA can truly be a good predictor of fracture risk. We need more clinical data. As of now, the data that we have is more in research setting. Coming to the last parameter that is separate from the HSA. Whatever we saw now was all a part of the HSA software and all the parameters were given by the HSA. So this is another new entity that is the bone strain index. This is another novel entity. So this tells us about skeletal resistant roads which are not yet considered by other indices including the HSA. So it gives us information over and above HSA also. It is based on a principle of finite element analysis, which is just a computer-based algorithm wherein we divide any structure, in this case the bone, into very small elements, into tiny pieces. Then we simulate conditions of applying loads or stresses on these small elements and we see how the structure behaves. So it is like a stress test on a bone image. For example, to put it lucidly, this figure tells us, if you see the top two figures, we can see that this structure is made of different materials, concrete and wood. So this is like seeing BMD on DEXA. The middle image, we can see that the internal structure design shows difference in the density. One structure appears dense while the other appears sparse. So this is similar to seeing TBS. In the last panel of the two images, we can see the stress-strain relation of the bar. So it has, this bar will have some different kind of material and specific structure. But imagine there are two different people sitting on top of the structure. These people who are sitting, they will have different weights, different body structure. So what the bone strain index tells us, how the bone will behave if these different weighted persons were to sit on this bar. So that is the bone strain index. Again, similarity. If there are two trees with different kind of structures, different kind of densities of the wood, that is seen by the BMD, the different shape of the branches seen by the TBS. If there was a person hanging from the tree branches and repeatedly applying some kind of force, and different people are hanging with different weights, how the bone responds. This kind of heat map is generated by the BSI software. So this is the bone strain index, to put it very simply. So this is the kind of image that we get if we do a bone strain index. On the left, we can see a lady with a BSI of 2.09. And on the right, we see a lady with a BSI of 1.29. So these are two different patients. These red areas are areas of higher strain. So that is why this person has a higher BSI, this first image. And since it is higher, that means higher the BSI, more is the strain and less is the resistance to fracture. So it is bad. Higher it is, worse it is. Okay? So this is the kind of heat map that we get. And again, if we have the software, so we can get values of BSI with as soon as we do the DEXA image. This has been studied in various populations, even in elderly men. It was seen that BSI was a good predictor of fracture risk, independent of FRAX and independent of false history. Other studies have also shown that the bone strain index is a good predictor of fragility fracture. So, as of now, we can say that there are limited scenarios where HSA and BSI might have utility in the future. In presence of fragility fractures in the absence of osteoporosis, conditions where we can get paradoxically high BMD, such as type 2 diabetes, mellitus, and obesity. There have been studies wherein it has been shown that diabetes mellitus patients had worse geometric parameters, and irrespective of the DEXA, it was good predictor of fracture risk. And we know there are other conditions also wherein the BMD can be high, but they can still be at an increased risk of fracture. So this is where the role of HSA can come in. As of now, the ISCD says that it should not be used to predict the fracture risk. As of now, we cannot be using this. It has been used in the research settings, but in the future, it might come into the guidelines also. It tells us about the bone strength beyond the BMD, and more importantly, the HSA software is cost effective. It only modestly increases the cost of the DEXA scan to the patient, and it can also be applied to archived DEXA scans. That is another pro of this. However, just like all other softwares, it is dependent on DEXA access, and it's still long before we can say confidently that it is a good predictor of fracture risk independent of BMD. As of now, it is more of an adjunct to BMD. Thank you so much for your patient hearing.
Thank you, ma'am. That was very nice of you. So that the most difficult part you have taken, but at least I think some of us have understood the concept of the hip structural analysis and the bone strain index. So any questions from the audience? Any clarification? Yes, sir.
Sir.
So I think 2 points. Is there any difference between patients with diabetes and without diabetes as far as these parameters are concerned, particularly buckling ratio?
So yes, so there are smaller studies. I did not show all the studies, but there are studies wherein they have shown that in patients with type 2 diabetes who had higher BMD compared to non-diabetic counterparts, most of the geometric parameters, including the buckling ratio, were worse in diabetic patients, even with higher BMD.
Ma'am, one query from my side, that the bone strain index have been specifically studied on any population? Has been like the diabetes again is one of the population where that can be a very help, like the
Yes.
TBS and everything is having a very importance in those endocrine disease, and diabetes is mostly one of them. So
In smaller studies, it has been seen, studied in PHPT patients, in secondary osteoporosis, and also in acromegaly patients. So wherein the BSI parameters were known to be worse again. So more follow-up studies are needed for us to say more confidently its role.
So I think we have a still long way to go to make them as a clinically standard procedures. But yes, it's a good to know, and I think within maybe 5 to 10 years, with increased availability of DEXA and increased availability of those softwares in our DEXA machines, I think in coming decades we will be using these parameters more often and not. So thank you again, ma'am, for your nice talk. So for the last part of our workshop, I'll be calling Dr. Akhila Bhandarkar, ma'am. So ma'am is assistant professor in the Department of Endocrinology and Metabolism, K.S. Hegde Medical College, Mangalore. And I'm very proud to say and happy to say that ma'am is a winner of this year's ESIN Kuchupilla International Travel Grant. And ma'am has got a lot of orioles to her credit. So ma'am will be talking about the body composition analysis of the DEXA, which is by far is a very important thing which is coming out. And for various endocrine diseases, obviously type 2 diabetes is one of them. We should assess body composition and obviously sarcopenia, because sarcopenic obesity is one of the most important metabolic abnormality coming up in current endocrinological practice. So with that, I will hand over to session to ma'am.
So good afternoon, everyone, and thank you so much for staying back actually till the end of, at least the last topic before panel discussion. And my part doesn't have anything of the bone, the most complicated part. So I think we'll be seeing more of a little simple thing. Maybe you'll find it much more simplistic, but it's a bit important also, and it's upcoming. A lot of research is required in this area, so we'll quickly dive into this. Not boring too much with history, but just to give an instance that it was actually body composition analysis which was initially studied by DEXA. Although now DEXA is mostly used for BMD, but it was Indrik Matika during World War I. We would not have thought of studying this during World War I, but this great personality studied about body composition in cadavers during World War I. So just remembering him when it's more than 100 years for DEXA. Principle, Manoj sir has clearly said about the dual photons and all, so not going to this. So yeah, so this is the WHO 5-level model of body composition, but this is again not so important when coming to DEXA. So we'll be starting from this part. So DEXA is all about 3-compartment model, meaning the entire body composition can be studied as bone, fat mass and fat-free mass. So that's how usually DEXA detects, out of which actually bone forms the maximum of area, 40-45% of the total area of DEXA scan. That's basically constituted by bone only. So what constitutes fat mass? We'll be seeing more of it. It's just one overview. That fat mass means it's all about the lipid, and it's mainly triglycerides, phospholipid in the membranes, all those things. Fat-free mass means you can probably interchange it as lean mass also, or lean body mass. So lean body mass includes organs. So it's very important here. So it's including organs, overall body water, even the minerals inside the soft tissue, because bone mineral is separate, but mineral mass inside the soft tissue, and protein. Okay, so protein is a muscle. So there are some other things also, like the soft tissue immediately around the bone, but not such important contribution to the fat-free mass. So before we get into the analysis, we should know for a good analysis how to perform a DEXA, especially for the body composition. So we need to know two important things here, which is falsely increased if we are not preparing the patient adequately. So that is hydration. So if a person is, as usual hydrated, he doesn't become anxious and take some extra gallons of water before scan, we are okay. He doesn't have to be deprived out of the hydration. So regular hydration is okay, but overhydration can affect the lean mass. So a falsely high lean mass you can get by overhydration. Also digestive tract content. So if just the patient has had food and lying for the scan, then again it can give a falsely high lean mass. Even exercise. So exercising, what it does is actually drives the fluid from the trunk and rest of the part to the periphery. That's the limb, upper limb and lower limb. So that can also give rise to a higher appendicular skeletal mass. So these three are very important, which can affect the lean mass. So relatively, fat mass is not much affected actually. So compared to the lean mass, it's mainly hydration, we could say. Hydration, that also say if patient has ascites and clearly some 5% of fluid content increases, only then it can affect, say 1% change in the fat mass can happen. So but relatively, lean mass is more affected by all these preparation. So best condition would be overnight fasting, usual hydration, empty the bladder before scan, because that can also add to, say, if you're seeing the trunk muscle mass and all, that can affect. And no strenuous exercise for 24 hours prior. So, and if you want to repeat it again, say for monitoring, repeat it on the same time of the day, the next time. So now, which DEXA machine? So machine to machine, I'm not going to discuss too much, although at the end I have a single slide, but it's mainly about the beam. So all of us have heard about pencil beam and fan beam, right? So pencil beam is actually no longer newly manufactured, but if we have an old machine, we'll still be using the pencil beam. So advantage of pencil beam is that, because it's so narrowed, it's very focused, and because of which the image clarity is actually better. But because it's narrow kind of a beam, it takes a long time, up to say 10 minutes, 12 minutes can also take for the scan. So little longer scan is not so preferred when you have a lot of patients. But the fan beam, it kind of overtakes the drawbacks of the pencil beam, in the sense the beam is wider, like a fan, basically fan shape, and multiple detectors are there, so relatively the speed of the scan is faster, but because it's a fan beam, little bit of edge and all can get distorted. The image quality may not be as great as pencil beam. So it's neither of them which is preferred if we have a choice. It's actually something called narrow angle fan beam, meaning it's the fan beam but not so wide beam. So the precision of the pencil beam is actually kind of still retained, and the speed of the fan beam is also taken care of. So this is a preferred beam if you have to analyze body composition. So positioning, so I think this is important here. We have to remember 4 lines when we position the patient. After positioning in the scan monitor, when we see, this is what you have to see. So that is, say one is called headline. So you can see the purple or the pink line just below the jaw. So that is one line which is important. And then the second is called as pelvis line. So pelvis line is just above the iliac crest. So that is also in pink actually in this image, the bottom one. And then we have 2 groin lines, that's the green one, which is actually kind of bisecting the femoral neck on the either side. And then the last one we have is a trunk line. So there are 2 of them. We can see that's passing through the glenohumeral joints here. So just to give you an idea, now that's the head area above the headline, usually not used in the body composition, although I think in pediatric cases it becomes important, but otherwise nothing. So the trunk area is in between the 2 trunk lines and the pelvic and the jaw headline here. Then the pelvis, not used much, but it has utility in some stress incontinence studies and all, they have used this area. And then the limbs are some things which are out of the the trunk line and the groin line. That's upper limb and the lower limb. This is how it is positioned. So coming back to the 3 compartment, we are not going to talk about the bone, which is already extensively covered. So regarding the fat mass, we'll see a few slides. Yeah. So these are the parameters we'll be discussing in the fat mass context. One is a fat mass index, AG ratio, trunk limb fat ratio, and the visceral adipose ratio. So first, we all have, I think, at least read about YY paradox, right? About our own Yagnik sir and Professor Yudnik. So how they were actually having exactly similar BMI. But when it came to body fat percentage, it was drastically different. It was, 9.1, and here it's missed out. It's 22 or 21 point something percentage. So that's how, meaning BMI was not, the foolproof kind of a thing. So because body fat significantly mattered. So there's no set guidelines to say this is the ethnicity-wise cutoff, but thankfully, Indian Endocrine Society has given a guideline for body fat percentage. So for males, a cutoff of about 25% is taken as high, and for females, about 30 is taken as high. And again, age-wise, we don't really have much, so I think we need more studies because post-menopause, we know body fat percentage goes up. So I think a little bit more studies required to know what is normal, is there a grading, all that is still, questions need to be answered. The next one, which is fat mass index. So fat mass index, how is it calculated? It's the total body fat in kg divided by the height in meter square. So that's the ratio. Importance of this is actually, it can be a substitute to BMI. Because BMI, as we know, it's not something to do only with the adiposity, it's overall weight. But fat mass index, it's a direct adiposity measurement. So it also has a lot of studies backing it. Correlated with the negative cardiovascular metabolic outcomes. So as such, there is no cutoff, but we have this enhanced reference. So you can look at this and remember one part of it. That's, this is very beautiful because you can see the BMI is below and the correlating kind of fat mass index is given above. And BMI actually doesn't differentiate between males and females. Again, there's a simple cutoff, right? But fat mass index, they have given what is a normal range for females, what's the normal range for males. So I'd like you to remember this number because we have some of the cases, right? So for males, 3 to 6 kg per meter square is actually normal, and for females, 5 to 9. So just remember this for now. So coming to AG ratio. So AG ratio, the name itself says it's the ratio between the fat mass of android region to the gynoid region. But before that, we need to know what is android and what is gynoid, right? So android region is the region between the last thoracic rib to the upper part of the iliac wing. So in the picture, we can see there's a pink kind of a top box here. So that's from the last thoracic rib to the upper part of the iliac wings. So what is gynoid region? Gynoid region starts from the, the pelvic line, you could say. That's the line which passes through the iliac crest. So from there, how much below? That is twice the android region of interest. You basically have to double the android region of interest so that it includes the glenohumeral, the glenofemoral regions. So that is that's how you define gynoid region. So, okay, it's all flying in the slides, probably the laptop incompatibility. So the AG ratio of more than 1 is considered abnormal for males, and more than 0.8 is considered abnormal for females. Again, see, this is not standardized because unless we have something coming from a standard study, these are all, majority of the studies giving this cutoff, that's all. So ratios basically show that the patient, person may have kind of a apple kind of a, or we can say apple and pear kind of distribution, the normal distribution. So if this goes above it, it's more of a abnormal or unhealthy fat which is deposited. So the fourth one, that's trunk limb fat ratio. So by the name, it's very easy to understand. It's the fat ratio of the trunk and limb. Let's go to the context. Why is it important? Why is the trunk fat important? Why is the limb fat important? So it said that whenever we speak about trunk fat mass, most of it, nearly 80% is actually visceral because it's all the organs there. So most of the fat is perivisceral. So which means higher the trunk fat probably is not good, okay? And coming to the limb fat, we know that most of it is subcutaneous. Almost 98% of the limb fat is subcutaneous. So with this only we understand that higher trunk fat mass is definitely not good. So if we have a higher ratio, it's definitely not good. But this is not the only importance of this indicator, okay? So more importance comes, the clinical significance is actually on the lipodystrophy syndromes. So because lipodystrophy is something where there is a selective loss of subcutaneous tissue from the lower extremity, and it is distributed or redistributed to the abdomen and the neck. So in this condition, we can clearly utilize this parameter, and a ratio of more than or equal to 1.5 is taken, or it's sometimes used to define lipodystrophy also. Again, no consensus. It's all based upon the studies available. That's it. So the last parameter of the fat mass, that's the visceral, visceral adipose tissue, you can say VAT. We need newer DEXA software actually to give this precisely. That's core scan and inner core in Lunar and Hologic, and it's mostly available in the newer machine. We can focus on the right-hand side image. So we see one image on top. It's clear that it's a CT image, right? It can't be a DEXA image like a cross-section. And the lower one is DEXA image. So in the CT image, we see that the outermost area, that's the subcutaneous fat tissue. And then we have a lean muscle in between. That's abdominal muscle. And then we have visceral fat. So this kind of a direct estimation is possible only by CT or MRI, such kind of examination. So in DEXA, we cannot really directly measure the visceral fat. So we have to use some indirect techniques, and that's what we're going to see now. So that is, DEXA actually sees the subcutaneous fat, the outer one, and it measures the total fat in that area. So one important point I forgot to tell here, which is there in the slide, is that the VAT is measured in the android region. Okay, it's not the entire abdomen which is taken. So it's only the android ROI which is taken, and all these things are done. So total body fat is assessed, subcutaneous fat is assessed, and just it is subtracted. That's it. So indirectly we get the VAT from DEXA. May not be as accurate as CT or MRI. So a VAT area, anything above 100 is taken as abnormal. So 100 to 159 is taken as an increased risk, but 160 or above is actually considered a very high risk for the cardiometabolic or any other such risk factors. So it has a better predictor of mortality, and it said that probably it could replace AG ratio or say SAT, all those things. So even in patients who have a normal BMI, if they have a higher VAT, then it's not considered good. Probably it's going to be one of the hot topics for future. So just as a summary, if you want to note, that's percentage fat cutoffs and all, fat mass index, AG ratio. Sorry for the overlap. So I want you to remember this for the next, this one, okay? So I have only kept the adipose part here. The lean mass will come later on, the same case, okay? So the first one, that's total body fat percentage. So this is a male patient. So what's the cutoff for male now? 25%, right? So this is actually, we don't know if it is low. That's again, one of the drawbacks, because we just have a single number. So as of now, let's take probably it's okay or low. We don't know. So let's see for more information, okay? So then we have the next one, which is fat mass by height square, which is fat mass index, okay? So fat mass index, I had asked you to remember one number for males, which is 3 to 6 for females and 5 to 9 for males actually. So either ways, be it a male or female patient, it is actually low. So somehow we are getting a clue, total body fat percentage we don't know, but this is definitely coming on the lower side. So this person is probably very thin kind of a person, very lean. So it's low. If you take it as a female, it is also again low. Coming to AG ratio, so it's a female patient, okay, sorry. Coming to AG ratio. So AG ratio for a female, more than 0.8 is bad, so 0.78 is still okay. I think we still have to warn this patient, because fat is so low everywhere else, but in the tummy it's definitely seen to be on the higher side, no? So very close to the cutoff, okay? And then we have the trunk limb fat mass ratio. So more than 1.5 would have been lipodystrophy. That's not there, so patient doesn't have lipodystrophy. Coming to the VAT area, we only have one single number, that's 100 centimeters square. 35 is probably very low, okay? So we would say this patient probably has, overall we understand is only that low fat mass index is there. So we'll just keep this as of now and take the remaining half after the lean muscle, okay? So this is the one. Coming to the lean mass, it's the same thing I initially showed. That's lean mass is a combination of organs, body water, soft tissue mineral mass, and protein, all of them. So, but our interest is actually muscle mass because that's what constitutes most of the metabolic risk, all those parameters. So, DEXA can determine actually like a regional segmental analysis. It can do, in the sense it gives a report like this. So, in the left hand side you see arm, leg, trunk, android. So, it gives like nice division with the it's given in grams. Okay, it's all this 4,000 and all, it's in grams of the muscle mass. And further, our more interest is actually in the appendicular skeletal muscle. It's not all the regions. So it's mainly the arms and legs and the corresponding value. So we usually tend to, we don't add manually, but it's given by the system. It's the addition or the sum of the muscle mass of the limbs, which is given as an appendicular skeletal muscle mass. And if we divide it by the height in meter square, it becomes appendicular skeletal muscle index, or ASMI. So I used to have a doubt why only appendix is taken, why not trunk? Okay, so it's not completely ignored because there are studies which was seen to compare why is trunk needed, is it not needed. So it is found that it has a good association between the limb skeletal muscle mass. So it kind of correlated. It didn't give additional information, but it kind of correlated, which means we could leave it off. And measuring trunk muscle needs a proper training to the person who does also, because we saw those lines, no? It has to be properly kept. Whereas trunk line is not so difficult to draw. It's just the side parts, that's it. So that way also it kind of reduced the error when we stuck only to the appendicular muscle mass. And when correlating with MRI, it was found that trunk muscle mass was slightly overestimated by DEXA, probably because most of the patients are not empty stomach, no? They would have eaten food. So it kind of affected, I think, the trunk and the abdomen muscles and all. So that's why it was told, kind of better to leave it off. So as I said earlier, the stress urinary incontinence is one area. If you want to investigate, the trunk muscle mass becomes more important, not the appendicular muscle mass. So lean mass brings us to sarcopenia. So sarcopenia, it's defined as an age-related thing, which is a loss of muscle mass and muscle strength and or low physical performance. Considered a geriatric syndrome, but now it is independently recognized. Okay, so there are various definitions, not going into the depth of it. The two most important ones are the European one and the Asian Working Group criteria, out of which we are mostly using Asian Working Group. But it's sad that we are not a part of this study. Okay, so Asian Working Group focused completely on Thailand, China, and Korea, all those things, but the Southeast Asian countries like India, Pakistan, Sri Lanka was completely ignored. So we are forming a separate, SWAG-SARCO group under which the studies are going on. Until then, we'll stick to Asian Working Group. So typical case finding, how do we pick up a case of sarcopenia? We either look for functional criteria like functional decline or chronic conditions in the background, or if not, if calf circumference can be measured, or if quality of life questionnaire is available, that can be provided, and that's how we do initial screening. It's not mandatory though. And then we go for muscle strength analysis. Muscle strength is very easy. We don't really have to have Jamar dynamometer. It's very expensive. The normal digital is also found to be good enough in studies that can be used for muscle strength analysis. And then we go for physical performance. Very easy. The short physical, the battery which is available, just simple as walking test, followed by the DEXA, that is appendicular skeletal muscle index. So we see there are two things here, the DEXA value and the bioelectrical impedance analysis. It's mainly from the Asian Working Group. Not all of the societies give the BIA. So I think we'll stick mostly to the DEXA values here. That's for the males, less than 7 kg per meter square is considered low muscle mass. For females, less than 5.4 is considered as a low muscle mass. So if low muscle mass and strength is there, it is sarcopenia. Addition of low physical performance, it becomes severe sarcopenia, just like how osteoporosis and severe osteoporosis is there. So which one do you think is more important? And it's come in the guidelines also. Is it muscle mass or muscle strength? Strength, no? So probably whatever I'm talking may not be relevant at all then, right? It's all DEXA. But yeah, so the revised European consensus has said it's the most important is a low muscle strength, because just doing that will tell sarcopenia is probable. And if we have, if we can examine quality or quantity, then we go ahead with confirmation of sarcopenia and find out if it is severe or not. Can anyone say what's wrong with the report if it's clearly visible? So this patient is found to have sarcopenia. Okay, it's a female and cutoff was, I think, cutoff is 5.4. She had some 5.1. So is it okay to give a report like this? What will you do if you get a report like this? Exactly. So muscle strength is not seen. We just saw the definition. Most important thing is muscle strength. So this is a wrong reporting actually. We're not supposed to give this. We have to change it to either low muscle mass or a probable sarcopenia as per the revised criteria and not sarcopenia per se. Because so many of our PGs only we had done a study, they were all found to have sarcopenia in the report. While their muscle strength, muscle performance was absolutely normal. So we just asked them to improve their diet and probably get reassessment later. Yeah. So this is the other half of the report, which we saw initially. The female who had low fat mass index, no? So we'll look at the, okay. So I've changed it to male here. Sorry for that disorientation there. So here we have the muscle part of this patient, and appendicular skeletal muscle index is 5.31. So is it okay? It is less. So we know that this patient has low fat mass index as well as low muscle mass. Actually, the diagnosis was a case of muscular dystrophy. So a patient had both on the lower side. Not to leave sarcopenic obesity, so we are sticking to the cutoff of 25% for males and 30% for females for body fat percentage. So anybody crossing this would have the obesity part of it. To satisfy the sarcopenia part of it, we use a Asian Working Group criteria. So we know that less than 7 and less than 5.4, and the remaining muscle strength criteria, if they satisfy, we can diagnose them as sarcopenic obesity. So just a case for that. So this is a middle-aged woman. So all of you remember this thing? The percentages now? Okay, fine. So the total body fat percentage of this patient was 42. Is it okay? It's high. So 30 is a maximum for a female. So that is high body fat percentage. So coming to the fat mass index. So that is 11 in this patient. What was an okay one? 3 to 6. Right? For females, this is high fat mass index. Okay. So what is okay for AG ratio in a female? 0.8. So, but this is high. So again, high AG ratio. Overall body fat is high. Especially it's focused around the tummy also. So then what about the trunk limb fat mass ratio? So it's 0.9. Is it okay? More than 1.5 would be for the lipodystrophy. There's no lipodystrophy. Okay. And what about VAT area? It's 173. It's high. So this is a high risk VAT, in fact, because it's more than 160, not just 100. So fat parameters are all, out of this thing for this patient. What about lean ASMI? It's 4.86. It is low, right? So low muscle mass. So this is a combo of high fat, low muscle, which is sarcopenic obesity. Okay. Again, we need the muscle strength, although I've labeled as sarcopenia here. So we have to examine the muscle strength and confirm. So this is just the same slide. There's nothing addition in this, the fat mass summary. So pitfalls, this is the absolute last slide, I promise. So the hydration, feeding and exercise effect, we've already seen. So device-wise effect, just a small note here, because it said that the lunar shows a slightly higher fat mass compared to hologic lean mass. And there's no standardized cutoff, but if you want, I can show the table which gives the equation for the conversion. So conversion equation are not standardized, but we do have it. Muscle quality, because these guidelines talk about quality also, not just quantity. So quality of a muscle, one of the major factors affecting is the intramuscular fat. There is a lipid deposition in the muscle, which is actually ignored by DEXA. It doesn't separately quantify the intramuscular fat. So that is something we need more work on. And I think for this correlation, we need still MRI or CT for more information. Yeah, thank you.
Thank you very much. It was a very nice understanding, and I am very sure that the residents have got a very benefit with that. So any questions from this? I think there should be some questions. Give him the mic. So just, I think before Dr. Ahmed sir's question, so apart from that ratio, the AG ratio, any other parameter for detecting the lipodystrophy? So
DEXA-wise, it's usually only this one which is used, and there are also like separate parameters where they use only trunk fat percentage separately, fat percentage of the limb separately. So separate things are there, but this is more standardized. More studies are available for this.
Right. Yes, sir.
I think the cutoff of 25 and 30. If we use that cutoff, all of us over here would be classified as obesity.
That's true. Actually, mine also came in that.
So we have a study from, it's a CUBE study from Chandigarh. Yeah. They have used 32 and 40 over there. 32 for females, males, and 40 for females.
Okay.
I think we can use that criteria.
Yeah, as for our convenience, at least we'll all be okay with that.
I think also for the ASMI cutoffs, I think that is one area I think we should come up with more and more data from the Indian point of view, because the AWGS, which you have rightly pointed out, didn't include any of the Indian participants there.
True.
So, and I think Indian participants are different in terms of body composition analysis. So I think we should try and make our data of ASMI and maybe push for changing the cutoffs or whatever modifications of the cutoff as far as the Indians are concerned.
Even the BMD actually changed a lot for Indian population and other South Asian population. So I think there could be a difference.
Right. I think so. The most important take home, I think, from this discussion should be that for obesity, for defining obesity, metabolic syndrome, type 2 diabetes, BMI is getting obsolete day by day. It's more of body composition analysis which is coming now. Obviously, infrastructural thing that we need to have a DEXA, assessing that it's a costly thing as well as the availability is the thing. But as far as the technical things are concerned and maybe the treatment wise concerned, so maybe we should focus more on the definitions on the body composition analysis to define obesity.
At least we could just do a waist circumference, I would say, if not for this thing. Rather than simply seeing BMI, just an inch tape and checking waist circumference, we would.
Yes.
No, the BMI is better than doing nothing.
Yes.
Yes, obviously.
It's a basic entry point to have an idea of the body mass.
Right, sir.
Then we have to understand that it has its fallacies. It may be contributed by the muscle mass, the water, the fat mass and others. And for now definitive treatment, and when we are intervening with, say, obesity reducing agents such as the incretin analogs, I think then you have to follow by body fat analysis like bioelectrical impedance, DEXA or whatever.
Right.
Agrees.
Any more queries from the house? I think we should go ahead with the panel discussion then. Okay. So I would like to ask all the panelists to come to the dais. Dr. Manoj Chadda sir, Dr. Khushbu, Dr. Anshita ma'am, Dr. Akhila ma'am, Dr. Lakshmi ma'am, I think unfortunately is not there because she has a ICMR presentation to make. So please all take a seat. I just have a 2 minutes break. So, हाँ चार. अच्छा अच्छा.
कौन ऐप डाउनलोड करके कल से करना आज तो आज कितने बजे डांस है?
So going to the last part, so to make it more interacting as possible, so I have made it into the Menti platform. So if you can kindly scan the QR code to the QR code scanner. So I'd like to take your opinion as well, your inputs, and obviously I'll take all distinguished faculty's input as well. So all have scanned? Is it coming? So can you answer this one, just a trial one? Oh, I think Kolkata is still a capital. Oh, that's a good thing to know. Anyway, it was once. Fine, that's a good thing. So I'll just have made some basic practical
You haven't
question.
given the time frame, right?
It's okay, I'll move it. Okay, yeah, that's right. So anyway, that's also a right answer as well. So the important thing, I've just tried to take out what are the experiences of the residents which are working in the now the DM curriculum, how they are exposed to the DEXA and all. So for that, I have just made some questions and we'll follow up with the questions to the experts. So the first questions that as of now, how many DEXA advices you have given in your prescriptions? Oh, that's a good numbers. Oh, very fine. That's a very good numbers. So good one. I can expect so at least 13 among 20, 21 have advised more than 50 or more than 100. So expecting a very good response with that. So with that, I want to go to sirs, Manoj sir. So a 35-year-old woman,
I thought you was going to focus on the residents.
Yes, sir. I think they will also ask, sir. So the question to you, sir, this is a very common situation. A middle-aged woman comes from a rheumatology OPD in a tertiary care center with suspected glucocorticoid-induced osteoporosis. They have taken she has taken intermittent steroids. We don't know about the total cumulative dose. So shall we advise straight away DEXA and how to go ahead with that? So.
Okay, good. I think the rheumatologists contribute a lot to our problems of osteoporosis. But I've been dealing with rheumatologists of late, including from Kolkata, and their interest is not as much as probably the endocrinologists. But in this case, we know from whatever information is there that she is going to be already on 2 years and she's going to be on it for a longer time. So we know that within the first few weeks of treatment, say within 2 weeks of treatment, the major amount of bone loss starts. So number one, should we rush into a DEXA at this stage? The answer is probably no. We should look at the fracture risk, remembering that it's not the quantity of the bone which gets affected, but the quality of the bone. Yeah, but I would definitely like in the near future a DEXA for this lady to know where she stands, and probably although she's only 35, I might be forced to think of treatment once the risk increases. One thing that we should understand, unlike hypertension, hyperglycemia, hypercholesterolemia, where you need to take a decision within a few days or a few weeks, sometimes waiting for 12 months can give you better answers than any of these tests that we have been talking about today. So a little patience in endocrinology. I remember one of our seniors from UK, while discussing Cushing's diagnosis, also said that a wait and watch is also a good diagnostic test in endocrinology.
Right, sir.
And the sites, we know that steroid predominantly affects the trabecular bone, so we would look at the lumbar spine, but the hip also should be looked at.
Right, sir. So thank you for your input. So again, questions to the residents. So I think it's a more of a revision questions, or which Lakshmi ma'am has already done, just to wake you up again. So what are the various fracture screening tools for osteoporosis? You just need to write. Obviously, FRAX will be one of them. Maybe would like to see other answers. You have written? Fine. So, is TBS is a screening tool? It's not like it's a screening tool. Yes, OSTA, it's one of them. FRAX Plus, obviously FRAX and FRAX Plus. SCORE is one of the more important. Yeah, so good one. I think we have got so these are the important fracture screening tools which we need to know and which ma'am has already said. So I think as Lakshmi ma'am is not there, anyway I'll ask Dr. Khushbu here. So as type 2 diabetes is one of the most important cases where there is a significant chunk of our endocrinology practice. So any fracture tools having more proven predictive accuracy than the FRAX tool in such cases?
So one of the most obvious limitations of FRAX is that it doesn't account for diabetes, but we have a workaround that. Lakshmi ma'am has already discussed that. So the easier way is to increase the age by 10 years. The second that you can do is tick on rheumatoid arthritis, so to calculate the FRAX. The third that you can do is decrease the T-score by 0.5 and take that into consideration. For example, if your T-score is minus 1.9, take minus 2.4 and then treat accordingly. And ADA recommends actually that for diabetes, T-score of minus 2 is the threshold for treatment. Of course, all of this is now corrected by FRAX Plus, where diabetes is included. So that is one.
Yeah, fine. So I think FRAX Plus is a very good alternative to FRAX, especially when we are talking about the type 2 diabetes patients. So again, I will go to Dr. Khushbu again, but again for the residents. So when you are assessing the patients in your clinical practice as osteoporosis workup, so do you advise vertebral X-rays routinely in your clinical practice, or just when the patient is talking about back pain, or you get a palpation findings, they may be fractures or localized pain? So it's almost okay, so more in the presence of significant back pain. Fine. So I'll move to Dr. Khushbu again. So again, as you have discussed very nicely about the VFA tool, and you have mostly discussed about the lateral X-ray, its sensitivity and specificity. So maybe where we have both these facilities available in the tertiary care centers, so we'll advise to include the VFA tool whenever the patient is doing DEXA, or we'll just write a lateral X-ray, or rather we do both?
So the answer is that in case you're ordering a bone DEXA scan for any other reason for osteoporosis evaluation, then probably VFA is a cost-effective evaluation. And of course, there are other indications if you're having height loss, if you're having back pain, if you're having fractures, if the patient is on steroid, as sir said that the lumbar spine is the main that is affected. So definitely in those reasons, VFA should be definitely done. But otherwise in our country, X-ray is definitely a lot more cost effective than a BMD assessment. So as what we were discussing in that, if with the basic screening tool along with an X-ray, could be one approach. So
that's right.
I just wanted to make a comment.
Yes, sir. Yes, please.
So there is no recommendation anywhere for doing an X-ray of the spine, but I think it's definitely worth doing one lateral lumbar spine before you take a decision to start treatment. It's worth it.
Right, it's a very valid point. I think in our clinical practice, it's a very simple test, the most and very cheap and readily available in all parts of our country, just to advise a lateral X-ray of dorsolumbar spine in patients who are working on osteoporosis. So next,
just like to add one thing. These are user-dependent investigations. So take mild fractures mentioned in VFA with a pinch of salt. Please look at the Genan scoring yourself. Look at the image of the vertebra yourself before you label the patient with vertebral fractures.
Right. So next question to Anshita ma'am. I think ma'am has again dealt with the most difficult aspect of DEXA thing. So so in DEXA, all these are added softwares when we are installing the DEXA machine. So with the current understanding, so what's your take on installing this hip structural analysis software, and which we have a 3D shaper DEXA technology which is coming up, which is again an added software to the DEXA machine, which I think from the Spain, from Barcelona they have coming up, and a lot of in osteoporosis symposium, especially in the Western countries, in the IOF symposium, they are coming up very aggressively and they are promoting their software aggressively as well. So in India at least, what's your take in such softwares?
Yeah, as you very rightly said, these are add-ons to usual BMD that we are doing. As of now, it is too early to say whether or not HSA should be installed mandatorily in DEXA machines. For research purposes, yes. But I think when we have more data, especially in Indian context, maybe then we can say that HSA software should be routinely used in DEXA machines. Of course, from what data we saw today, it does add on. It does give predict fracture risk better than just BMD alone. But we need more clinical studies before we can say that HSA software is required such. As for the 3D shaper technology that you very correctly said, it has come up from Spain. So basically, they have generated normative data on QCT from Spanish women. And again, using a very complicated software, they're able to superimpose these QCT images and on the usual DEXA and get 3D volumetric BMD that is comparable to QCT. And with the usual DEXA machine, again, that requires a software. Whether it is a perfect alternative to HSA, probably as of today it is not, simply because it is not validated well yet. In the future, and with regard to HSA, there is a lot of data, it is well validated to quite an extent as compared to the 3D shaper DEXA technology. So as of now, it cannot be an alternative, but once it is well validated, it could be in the future.
Right, ma'am. So maybe in the coming decade or so, we can get the more use of it. So again, to the residents, so we know the body composition analysis can be done by the DEXA. So other machines you have come across, maybe you were using in the departments, in your respective endocrinology departments. So can you name any such various dedicated body composition analyzer where only the body composition will be, we will be analyzing? Yes, yes ma'am, yes ma'am. Yeah, good, very good answers. Obviously InBody is one of them, bioimpedance machine which ma'am was referring to it, and bioimpedance metry as well. Right. So to Akhila ma'am, so if we do this body composition analysis by this dedicated body composition analyzer or versus the ASMI with the DEXA machine, so what's your take on that?
Yeah, so I think DEXA is actually good enough, but when we're talking about other body composition analyzers, we are mostly talking about the bioimpedance analysis. And problem with the BIA is not about the results it gives, but there are variety of machines. In BIA, if we just say BIA, it's not, all the BIAs are not same. While DEXA, we can say most of the DEXAs, if you say one company, then most of it is similar. Because BIA, the recent one is something called as multi-frequency bioimpedance analyzer. So that is found to have a very good correlation with DEXA, and almost, the segmental analysis is also found to be very close to MRI. But the old generation bioimpedance analysis was actually not accurate. So I think diagnostic accuracy is one fault, and the other factors like say hydration, the food, all that is going to be much more problematic with the BIA compared to DEXA. So if you have to screen, say you're doing a camp, in that case maybe a portable, because it's portable, that way you have an added advantage of using a portable BIA. But if you are in a setup, like a established setup, definitely spending on DEXA is much more worthwhile than a BIA. But if you have more money, then multi-frequency BIA is costing very good also, and it's giving very good results also. You can go for a multi-frequency analysis.
So again, so it depends on the infrastructure, obviously, the cost, the area for installing the DEXA machine. So maybe dedicated body composition analysis can be a good choice as well. So next question to Manoj sir, I think sir is the best one to answer this. So the endocrinologist, after passing DM, like a young endocrinologist, want to set up his own DEXA machine. So, sir will be the best person to tell, will that be a financially and academically feasible, especially interested in a bone mineral health research? And again, which model, sir, can advise for such thing?
So, if a young endocrinologist is just getting into practice, my first advice is wait for some time, there's no hurry.
Yes.
See, the problem with investing into a machine is that you have to service it. You have to pay the EMIs. And like my colleague, I don't know how many of you know Dr. Nishit Shah in Mumbai, he says that if the only tool that you have in your hand is a hammer, then everything around looks like a nail. So if you start with a DEXA machine in your practice, you're going to start asking for DEXAs where they're really not necessary. So that's the first part of the advice. Second part is, no, I have all the space and the money. Space is not an issue. You need about 150 square feet. But if you have, say, 70, 80 lakhs, or you can arrange for it, or you have a sponsor, then, like I said, it's not the running cost which is an issue. It's the primary initial investment. So if someone is ready to take care of it, I think it's a good tool, because as we were just discussing, a dedicated machine with a dedicated technician, nothing like it, because instead of sending the patients around to other centers where you're not sure how reliable the report is, and while the patient is waiting in your clinic, it's less than a 10-minute job. You can get a DEXA done, but please follow the monitoring time interval that we've discussed, and it should not be every 6 months, and it should not be in every patient that comes to you.
Right, sir.
And in terms of model, I think what we have in India are the Hologic and the Lunar. These are the two popular models, and to tell you the truth, they are both owned by one company only. So it's whichever you get a better deal, you can go for. And I think all of you are using, you want to chip in your bit, please do that.
Yeah, sure, please.
We work in CMC, we have a Hologic machine. So, but it's the institute's machine and it works very well. And we have a dedicated team, and they have regular tests and everything. So the reports are very well reliable about that part.
Right. I think to have, yes. So if we have a setup and if we have the opportunity, as sir rightly pointed out, set up a DEXA with a dedicated technician, really very important for the patient care, and as well as obviously research input into the literature. So going to the next part, so again a very revision question. So which of the following parameters is not included in the FRAX tool? Very quick answer I think I should get. Yeah, perfect. Yeah, fine. So obviously lumbar spine BMD is not there, so they calculate in the femoral neck. So this I need to ask to Anshita ma'am. So I think mostly it has been answered by Lakshmi ma'am in her presentation. So without doing that DEXA, if we get a FRAX tools and having a risks of more than 10.5 or 3.5, that is according to the ISBMR guidelines. So obviously, ma'am told about other guidelines, more cost effective, which they've got in the studies. So can we straight away start on the anti-osteoporotic therapy in such cases?
Yeah, so as you said, Dr. Lakshmi talked about this in detail. If a patient is having a high risk of a major osteoporotic fracture or a hip fracture based on a FRAX tool without a BMD, in our setting where we know, as we discussed in detail, how the DEXA access is limited, yes, it can be an indication to start anti-osteoporotic therapy. And of course, she talked about other cutoffs as well, which could be used. But the bottom line is that there's high or very high risk as per the FRAX tool. Even without BMD, the patient should not be left deprived of the advantage of the benefit of anti-osteoporotic therapy. Of course, if the BMD is also there, that will further refine the fracture risk, and as she said, it will be helpful in monitoring treatment.
Right.
Apart from that, it can be used. Yes.
Right. So going to the next question. So before that, for the residents, so on the basis of TBS, can we start anti-osteoporotic therapy? Suppose we have a normal bone mineral density, but we have a poor TBS, suppose in a type 2 diabetes patients, in acromegaly patients. So the opinion of the house is, at least for now, we can't. So to Dr. Khushbu, so I think she has told about the specific cutoff for that, but I think the next part is most important, that do we have enough TBS data from India to define that cutoffs?
So as of now, no. There are data sets from PGI, and Dr. Shinjan also has a data set and few studies from our own center as well. But they are as of now too small to define a pan-India cutoff. Again, multiple studies that ISCD has quoted, they are saying the numbers are all over the place to actually define ethnicity or race-based cutoff as of now. So probably a bigger number is required before we can answer this question as of now.
So we haven't reached, I think, at this point, so that we can maybe initiate anti-osteoporotic. It's still very much BMD based because all of the studies are follow-ups of the anti-osteoporotic with that. So next to Anshita ma'am, as we have said about the buckling ratio, so can it be paradoxical to the BMD found in the endocrine diseases? And then what will be the interpretations of that?
Yeah, so there can be conditions wherein the BMD may be normal with a high buckling ratio, so that means which is a bad parameter, and conversely there can be conditions wherein the BMD is low but the buckling ratio is less. Not only in endocrine diseases, also it could be because of racial variations, because changes in height or structure of a person. For example, if there's a taller person, heavier person, because of the more more bone radius and with less cortical thickness, they could have a higher buckling ratio, but with normal BMD. And particularly in Asian women, if we say they are comparatively shorter or more stocky, so they could have a lesser buckling ratio even with a poor BMD. So there can be paradox. And what are the endocrine diseases wherein we can find this paradox? It has been seen in type 2 diabetes as well, wherein even with a good BMD, because of reduced cortical thickness which comes in the diameter of the equation, they can have a higher buckling ratio. And what are the interpretations then? Interpretations in the sense that how do we further proceed if we get paradoxical results? So as of now, what we can say is that since BMD remains the gold standard to decide whether or not to go for therapy, if the BMD is poor, irrespective of the buckling ratio, we should go ahead with therapy. If it's the other way around, if the BMD is good with a poor or a high buckling ratio, then as of today, we have to see it in the clinical context. We just cannot go by the buckling ratio and use it as a stand-alone tool to decide whether or not to treat. So if in such patients, if there is high risk of fracture, if there's a high FRAX score, they can be considered for therapy, but not just based on the buckling ratio.
Right, so and it's very intriguing to see the type 2 diabetes there everywhere, and with increasing bone involvement even in the hip structural analysis and the buckling ratio. So we get to know that we know less of the type 2 diabetes in the bone disease. It should be explored more and more. So again, for the residents, the last question. So you need to write what are the various endocrinological diseases where the body composition analysis needs to be advised. Only the body composition analysis. So obviously obesity is one of them which we were discussing. Other diseases, you can just write it. All of them, of all endocrine diseases, I think that will be the most. Yeah, so lipodystrophy is one of the most important, which ma'am has said. Yeah, that's right. So lipodystrophy is one of the common thing. Hypogonadism, yes, okay, very important. Okay, so at least a couple of them has answered all of them, so maybe all of endocrine diseases. So with the lipodystrophy, so the last question to ma'am, so any other specific diseases where the body composition analysis from DEXA can clinch the diagnosis?
So if you're talking about, say, where DEXA is having a supportive role, then it's mostly all the endocrinological disorders like this said.
Yes.
Because we deal with the hormones which are important for growth, for the muscle strength, for the puberty, all of them. So they are all the supportive role, but the diagnostic decision is what I think already they have mentioned, the residents have clearly mentioned, that's the 4 important thing where DEXA forms a part of the diagnosis. That is, one is a sarcopenia where we need it to confirm the presence of this thing, sarcopenia, that's one thing. And then additional thing which is the osteosarcopenia, I think somebody had mentioned that also. So that is one more area we need DEXA definitely. And the third one is sarcopenic obesity. So that's one more case which we discussed, and the lipodystrophy. So sometimes the lipodystrophy, although clinically you can make out the body distribution, body fat distribution, but the diagnosis, most of the studies have utilized DEXA. So these are the 4 things where it is indispensable, but rest lot of the endocrinological conditions needed for support, as rightly mentioned.
Right. So I think with that we have come to the end of the exhaustive workshop. I think the most important part, I think the residents should learn from this and at least take home some take home messages from this workshop. From my bottom of the heart, I'd like to thank all the esteemed speakers. Manoj sir, Dr. Lakshmi ma'am is not here, Dr. Khushbu, Anshita ma'am and Akhila ma'am for sparing their time, and has been a very beautiful deliberation. Is the most easiest of way to understand the various intricacies of the DEXA. So I think we are still not ending because sir has some interesting thing to show. Yes sir, please.
I just wanted to share one slide with you.
আসেনি তো না 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 কোথায় এসে এবার এসে yes sir, I got it.
I just wanted to show you this patient of mine whom I've been looking after for the last 15 years now. That's done at Hinduja every 2 years. So I've got about a dozen readings. The important part I want to show you is when we started, in the first year and a half, if you can read or just look at the graph, that in the first year and a half, his BMD went up by about 97%. So it literally doubled. So what would be the situation where you can get so much increase in BMD with whatever treatment I did? So this was a hypogonadal male who came to me, was about 45. He had a lumbar compression, he had a hip fracture, and obviously there must be an element of vitamin D deficiency because you don't get so much increase of BMD in the first year. But the important part is that with whatever treatment we gave, testosterone and then the treatment for osteoporosis, it's gone up by about 120%. So it more than doubled his BMD. So in endocrinology, the point that we're trying to make is that a lot of osteoporosis is reversible. Unlike the aging process, there we talk of halting the decrease and we talk in terms of 5, 7, 10% increase. So this is about 120%. And that last dip that you can see, he was lost to follow-up during the COVID period. So there was some decline, which now has improved over the time. So it's a good tool for monitoring. I mean, like the third time I'm saying it's not the best, but it's the best available with us. So we should use it reliable. And when we say reliable, it should be something which, you can depend, okay, this is done on the same machine. So that's why if you have your own machine and if you're ready to invest about 60, 70 lakhs, nothing like it. Thank you.
Thank you again for this and this case scenario. So I think we are, thank you again all the esteemed speakers and all the listeners, I think for listening 3 hours continuously, very patiently. So thank you all. And I think we can close the session. Thank you, sir.
Thank you. Thank you, Shinjan, for that excellent moderation, as well as I would like to thank all the respected speakers, Akhila Madam, Anshita Madam, Khushbu Sir, and obviously Manoj Sir, and obviously to the Lakshmi Nagendra Madam, who is not here for any reason. So a very good, it was a nice session. So after this exhaustive session, let's reap the fruits of it. So the certificates of participation are available at this counter at the corner of our hall from our representatives. Kindly, those who have registered, kindly collect it from this corner. So those who are registered, kindly collect your participation certificates from us. Thank you. And now we can join in the Subhash Mukherjee Hall, where there is an academic extravaganza in the form of 2 nice cases are going to be discussed by the maestros of endocrinology. Thank you. We will see you again in the Subhash Mukherjee Hall. Thank you.